هو دكتور خالد اني يا عبد العزيز.
السلام عليكم. السلام عليكم.
مساء الخير.
مساء النور.
انت 900
ريجسترد، ومع الاند سيشن كان عندنا على الزوم بس 120 واحد في الاند.
السكرين الشير ده يا جماعه
اتز يا خالد
موجود. طيب
في شاكوش، هو ده بتاعك؟
الشاكوش الشاكوش بتاعي بس مسمار مش باين.
انت عارف الشاكوش اللي بيشيل المسمار، الحدادين بيستخدموه، النجارين المسلح.
ايوه
اسمه قرناص.
بس ده
ففي مثلا
الشاكوش
عندنا اللي هو بيخلع المسمار كده، في ليه زي في شيب كده ويخلع المسمار. فعندنا في مصر مثل في مصر بيقول: لو انت قرناص انا مسمار من غير راس.
يعني مش هتوصل لي برضه.
يعني
بس انا مش شايف دلوقتي ازاي اعمل شير الكاميرا. لازم اخرج من البرزنتيشن ولا
لا؟ بيبقى فيه اللي هي علامة الكاميرا.
احنا عندنا السكرين كويس قوي طالع، بس مش ماكسمايز. يعني اعمله
مش ماكسمايز.
لا، هو دلوقتي تجي حاجة تانية. ارجع زي ما كنت. ايوه
كده ماكسمايز.
كده
ايوه
كده ماكسمايز، مش كده؟
اتفضل انت بقى. انا
بس صورتي مش باينه برضه. انا هوريكم صورتي يعني عشان تنبهروا. بس يا يسري انت محلو ولا ايه؟ احنا لسه بدأنا ولا لسه؟ عامل ايه قول لي بس عشان
اعمل من غير راس.
طيب قول لنا بس نبدأ امتى عشان احنا تعرف عندنا بان دلوقتي للسعوديه مفيش حد بيطلع، ممنوع. يعني دلوقتي قالوا لنا النكست بوسيبل ديت هيكون في ماي. انه ده
احنا كنا جايين، انا والدكتور طارق حلمي كنا جايين عندك، كنا هنلف
عمره
جدة. لا، هنلف على السعودي الالماني، عاملين زي بروجرام كده زي اللي انت كنت عامله، واتفقوا معانا، وكنا المفروض هنيجي الويك اند ده، بس مفيش حاجه حصلت. فاتسيمز عشان اللوك داون اللي حصل.
هم تواصلوا معاك، انا اللي عرفته انه تواصلوا معاك، مش كده؟
تواصل،
بس ما ادانوش خبر. انا ما ادانوش خبر انت جاي
عن طريق اللي في جده نيو سيرجن
دكتور ايهاب.
ايوه، هو اللي عامل الجديد يعني.
نيورو سيرجري هم اللي جايبينك.
ايه
ده؟ لا 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 نزعل احنا. طبعا انت في بيتك هنا.
طبعا الله يخليك، الله يسلمك. احنا we'll start.
ان شاء الله.
بسم الله الرحمن الرحيم. It's a great honor and pleasure to welcome you all to the second day of the virtual webinar for the Aging Spine, 9th Aging Spine meeting. Yesterday we had about 900 participants registered and from all over the world. And this is the really merit we got from COVID-19 era, that we have more participants. We never ever can get all these attendance if it's an on-site meeting. So thank you very much for your attendance. And today we are having 4 webinars. We'll start with the 5th webinar and titled Challenges in the Aging Spine. We'll start with Dr. Khalid Batargi, our dear colleague from Saudi Arabia, and he's going to put to us a challenging case of a spine. Thank you very much, Khalid. You proceed, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like just again to thank the panel for and the organizing committee for inviting me to this regularly webinar, and I'm happy to be part of it. I hope, inshallah, next year we can be present physically, because we are missing Egypt and the nice people of Egypt. I would like to share my presentations. You can see it or not yet?
Not yet.
Just give me a second so I can share with you. Is it now? Is it on? You can see it?
But maximize it.
Is okay?
حطه على الواتساب.
انت شغال يا خالد من الموبايل ولا ايه؟
أيوه من الموبايل.
طب ماشي.
You can see it?
we can see it now. Maximize بس. تقدر ولا صعبة من عندك؟ خلاص كده كويس.
Okay. Is okay?
It is.
Even the case is not a typical elderly patient, but it is a very interesting case that I would like to present it, because it has a lot of challenges and a lot of questions. It's a 49, it's actually 52 female patients presented with an acute paraparesis, and the investigations revealed D5 and S2, S3 osteolytic lesions, small lung nodules, and axillary lymph nodes, thyroid nodules also. It was diagnosed, I want just to keep it very short because of the time. It was diagnosed as a multiple metastatic spinal lesion secondary to thyroid carcinoma. And this is the X-ray of the patient. And this is the MRI of the patient. And you can see this is the D3 and to D5. This is the lesion at the D5. So how can we manage? I'm just asking quick questions so we can get the panel interested in this case, and also the colleagues who are with us on the webinar. So can I have suggestions of how to treat these patients?
Neurology, please.
She is in paraparesis. She was not able to walk. and she has a severe back pain, mainly on the thoracic spine.
She needs decompression at both sides, the thoracic and the sacral, and fixation at the thoracic. I don't think the sacral needs fixation. And then continue with the chemo radio.
Now, so the panel would agree with these suggestions, right? So what happened to these patients? This was the surgical interventions, anterior corpectomy of D5, and posterior pedicle interbody fusion with expandable cage. And this was... You would agree on this, right?
يلا الله يحفظك إن شاء الله. الله يحفظك.
Yes. Yes, we do.
Okay. This was, and this is the post-operative X-ray, AP, and lateral. Now we have the dilemma and the questions. This patient became post-operative conditions. She developed complete paraplegia with incontinence, and her general condition worsened after the operation due to the paraplegia. What do you think we should do now?
I think we needed to make a CT scan to see if there is any insult to the cord itself. Then we can exclude any iatrogenic causes of paraplegia from the surgery first.
Yeah.
Then we evaluated also the distal part, which is coda equina in the sacrum, because you didn't mention anything about going distally.
No, the surgeon who interfered did not touch the sacral part. He was satisfied with the anterior corpectomy and the posterior fixation. By the way, it is done on the same sessions.
Okay, so we needed to exclude any iatrogenic causes of injury to the cord by doing CT to see.
This is the CT.
Okay. There is insult now. One of these screws is encroaching on the canal itself.
Yeah. This is exactly what happened. Now, the dilemma, how we should tackle this problem. The patient became paraplegic. She has a tumor with a metastasis, and the relatives were they were not happy. So they complained to the court.
I think the first thing is to reposition the screw if they accept. So, because it's crucial that you have to rectify what went wrong, apart from any litigation. So
they refused that the surgeon should touch their mother again, even if he put the screws wrongly, because they have complained to the court.
Dr. Khaled, may I comment regarding this case that it is a thyroid metastasis and it is a hypervascular tumor most probably, and a lot of these patients bleed during the surgery a lot. So pre-operative embolization is recommended. And also, sometimes you will face such medial positioned screws like this, which you can show us in this CT. But actually, a lot of these patients has no paraplegia. So there are many causes of paraplegia. Like Professor Korna said, the lower down sacral tumor can cause the incontinence. The extension of the thyroid metastasis elsewhere can cause that. The bleeding can cause vascular insult to the cord. No, I cannot say that the cause of the paraplegia is only this medial positioned screw. So I agree with Professor Hawari that we can reset the screw and clarify to the family of the patients there are many causes, and it is actually a terminal case, multiple metastases, thyroid nodule. So it is good that the surgeon accept to do such procedures to allow the patient die in dignity or live in dignity. Let us to say that instead of going to the court, and such a screw may be not the cause.
And also that the patient has been operated in the same setting from anterior and posterior descendants. This is a lengthy operation and might lead really to exhaustions of the surgeons. Plus, as you said, Dr. Khattab, Professor Khattab, that the patient has bled a lot. She has received 8 units of blood, and the surgeon was exhausted only from the anterior, and then it took him about 7 hours to operate these patients. And this is the reason also why the relative denied him again to interfere and to correct the malposition of the screws. Now, the dilemma, why I am presenting this case, because the verdict of this case, when it came to the court, the screw in the third thoracic vertebra was placed wrongly. This is the verdict of the jury. And the patient's worst condition was to the operation performed by the surgeon, who was not privileged to perform the procedure. This is another dilemma that the surgeon has faced in these conditions. Now, as a jury, I am putting you as a panel, and I'm asking you, as a surgeon, what was or how you can judge this case?
Dr. Khalid, you have to rely on the clinical, because this is in the third thoracic vertebra. So is it paraplegia starting from this level or from the same level before the surgery? When you examine the patient, you can judge it, because in the thoracic, if this insult from these screws, so I think the paraplegia will start from this level. If the insult is still from the same lesion, I think we have to consider what Professor Khattab and Professor Yusri mentioned about the complication of the tumor itself. So clinically, it is very important to see the sensory level, and from this point, you can make your judgment.
The paraplegia starts from the same level, of the
gentlemen.
Yes,
Shadi.
Good afternoon, everybody. If I may interject on this very interesting case. So, Dr. Baterji, thank you for sharing this case. It is very interesting, and it's there's a lot of controversies about what may be causing or may have caused the paraplegia. If you go back to the picture of the screw, if you don't mind,
please.
I wouldn't say the screw is malpositioned. I think the screw is in okay position. The size of the screw may be bigger than maybe larger than the pedicle, and that's why you see a medial encroachment on the canal and maybe misplaced slightly in the upper or lower part of the pedicle. The million-dollar question is at what point in time that patient lost the neurology? Is it because
directly? Post-operative directly.
Yeah, but there's no way to tell at what point during the surgery the insult happened, because was there any neuromonitoring done during the procedure?
No.
So no neuromonitoring. So you cannot really tell when there was ominous signs of losing sensory or motor. Number one. Number two. I agree with Dr. Khattab. This is a procedure that bleeds significantly if you do not do preoperative embolization. Did the patient get preoperative embolization of the tumor?
But this is metastasis, Dr. Shadi.
No, I understand.
Is it
absolutely.
embolization will help in metastasis?
Absolutely, it does help with metastasis, and it should be done within 24 hours to 36 hours of the procedure. So they can do selective embolization of the tumor depending on its vascularity. Sometimes they may not be able to do it if the feeding vessel is related to Adam Kiewicz or a vessel that also supplies the spinal cord. So a preoperative embolization may help in reducing the bleeding and give you a relatively I wouldn't say a dry plane or surgical field, but it would reduce certainly the bleeding from not doing anything, or compared to not to do the embolization. Third, the fact that the patient needed a significant amount of blood and transfusion, that leads me to believe that at some point the patient's hemodynamics were in hypotension status, and that may infarct the spinal cord. That may cause the spinal cord infarction. And the paraplegia and the loss of spinal cord function, if you may, that you presented may be the result of a hypoperfusion of the cord rather than a mechanical insult from the screw, which also the screw, albeit it is encroaching on the canal, it does not seem that it is the only answer to the problem. Did the patient get any MRI afterward to see if there are signal changes within the spinal cord?
He has yes, she had an MRI done to her, but I don't have it now but the position of the screw, it is in the canal.
No, I understand. That's one of the issues, but also I would like to explore all the other pieces of the puzzle. That's all.
Yes.
Because from the story and the amount of transfusion that the patient needed, I would not be surprised if there's another element that was
the cause of the paraplegia.
That contributed to the paraplegia, not necessarily the main cause. There are multiple pieces to the puzzles here. One of them could be the mechanical screw misplacement. The other piece could be the hypoperfusion of the cord.
If I may just continue on this case. Now, as I said, the relative has complained to the court. And based on these information, and mainly because the colleague did not have a license to, let's say he was not privileged to do this surgery, the verdict of the decision of the judge was like this. It's a violation of the Article 41 of the Health Practice Law. And the surgeon is charged to pay the value of the blood money amounting of $438,000 to be paid to the complaint. Now, as a panel, do you think this judge or this judgment to this colleague, due to this position or to the complication happened to the patients and to the license issues, was it fair to our colleague?
Can I ask a quick question, Dr. Boterji? What do you mean by the patient, the physician was not licensed or privileged? I'm not familiar with this.
To be a spine surgeon in Saudi Arabia, you have to have a privilege of doing spine surgery. So if you are a neurosurgeon or an orthopedic surgeon, and you don't have a proof or a certificate or a fellow that you are practicing a spine surgery that has been given you the privilege to do spine surgery, that means you are doing a surgery without a privilege.
So it's similar to practicing medicine in the United States without board certification, basically.
Exactly.
Okay.
I'm just presenting this case because I want to the young generations and to our colleagues who are practicing, that they should really look at these case as a learning case. that we have to, as you have said, and I'm thanking the panel for bringing the puzzle together. This surgery is a very extensive surgery. It was done at both sides, anterior and posterior, simultaneously. There was no preoperative embolizations. A big amount of blood loss. The surgeon was not, by law, even if he has practice, but he was not licensed to do the surgery, and therefore the jury and the judge has convicted him to pay the blood money of this amount. So my question again, do you think as a panel now, if you are in that position, how you do consider this colleague?
Khaled, first of all, I would have a very good consent, put everything in the consent before doing the surgery, and give them the choice whether she would die from the metastasis or would do the surgery and put all the complications, the paraplegia, and let them countersign before doing that surgery, and be a friend to the patient, to the family, so that they won't go to court for whatever happens. And if that happens, and this sum of money, I think it's really not much for what happened. So I would just pay it, and instead of losing my license.
This is exactly what you have said, Dr. Yusr, yesterday in your last lectures about being a good surgeon. Talk to the patients, be patient, and consent the patient, explain to the patient what would happen. I don't want to go further because of the time. I think I just present the case to give the panel and the other colleagues the view of how the law would treat doctors in such cases. So you have to be more careful by selecting your patients. And I thank you, the panel, for their participations.
Thank you so much, Professor Batarghi, for your nice case highlighting the importance of protecting yourself by following the medical legal aspects, starting from the consent, the indications, proper prepare your patient, put plan B, advise the patient regarding the possible complications, use neuromonitoring intraoperative, prepare enough blood, everything, every minor details should be considered before such heroic surgeries, and before everything, got license, got training, and this is one of our goals in the Egyptian Scoliosis Society and this meeting. And the next speaker will be Professor Bahak Korona, a professor of orthopedics and spine surgery from Al-Azhar University, will highlight the cervical spine deformity, how to evaluate your patients.
Assalamu alaikum. Thank you for the panel and the organized committee for inviting me for second talk in this fantastic seminar and the webinars, and I might be happy also to be there. The deformity, we have to define it is ugliness. Deformity, alternation in or distortion of the natural form of the part or organs or an entire body. It may be acquired or congenital. If present after injury, the deformity usually imply the presence of bone fractures or bone dislocation or both of them. What about the function of spine? The supporting the head and its movement, transmitting the axial load from the cranium, maintains the horizontal gaze, and protecting the important neurovascular structure such as the spinal cord, the nerve, and vertebral artery. Why important to recognize the cervical deformity? Cervical spinal deformity can have a significant negative impact on the quality of life of the patient. They can cause pain, can cause myopathies, radiculopathies, sensory and motor deficit, and inability to maintain horizontal gaze, and in severe cases. The deformity in the cervical spine typically resulting in an abnormal position of the head relative to the chest and the shoulder. While it is usually cosmetically bothersome to the person, cervical deformity also can result in difficult for swallowing, breathing, can severely disrupt the personal ability to perform normal tasks such as driving, eating, and also reading. What is the causes of the spinal deformity? The cervical spinal deformity. The most common causes of cervical spinal deformity are degenerative, which is progressive collapses of the intervertebral disc and or the vertebra, post-traumatic resulting from injuries, and inflammatory due to certain inflammatory conditions such as ankylosing spondylitis. The most common form of cervical spinal deformity is cervical kyphosis, commonly presented with neck pain, myopathies, and sensory motor deficit due to either compression of the neural element, impaired of the cord perfusion from an overstretching the spinal cord. Cervical deformity are categorized into two primary ways. Either it is fixed or reducible. Fixed means that the deformity is rigid regardless of the patient position. Reducible means that the deformity is flexible and it can be corrected. Depending on whether it is fixed or reducible, the deformity may be required surgery either from the front, from the back, or sometimes multiple stages from both the front and the back. The aim of the presentation is to provide an overview of cervical spinal deformity, including the biomechanics, radiographic parameters, classification, and surgical procedures. Biomechanics of the cervical spine, it is very important to know about the cranial central of masses, CCOM, the line bisecting the nasion, anions. This mid-sagittal line demonstrates the force factor on the cervical spine in flexion, in the neutral alignment, and also in extension. The posterior tension band ligament and the paraspinous muscle balancing this force. In the CCOM movement, further anterior increases the bending moment and required great counterbalance from the posterior element within the neck. We have 60 degrees of the freedom of the movement. The cervical spine is a weight-bearing mechanical structure with 60 degrees of freedom of movement. The principle of motion, which including the flexion, extension, axial rotation, lateral bending, along with a small amount of coupled anterior-posterior translation movement along the Cartesian coordination, and the cervical spine is able to move within the neutral zone. It is very important, neutral zone, which is relatively little force, therefore required very little energy expansion from the paraspinous muscle. But we have what we call an elastic zone. Additional movement beyond the neutral zone required more effort to movement the elastic force from the soft tissues. Therefore, this zone is called elastic zone. Additional, the movement relies in both the neutral and elastic zone, provided the total range of the motion, which is the range of motion as the given segment. An abnormal increasing in the natural zone or range of motion may indicate ligamentous injury or spinal instability. The global physiological range of motion of the cervical spine is approximately 90 degree flexion, 70 degree extension, 20 to 45 lateral bending, and up to 90% rotation in each side. When the cervical kyphotic deformity is present, the head center of mass movement anterior and the movement arm increasing relatively to the IAR, thus creating a large bending moment. The resultant large bending moment required greater paraspinous muscle contractions to keeping the head erect, which in turn can cause fatigue and pain. In addition, the kyphotic cervical deformity shifting the axial load anterior thus can potentially accelerating cervical disc degeneration. Decreasing in the height from the degenerative changes can cause more cervical kyphosis, thus creating the notion what we call the kyphosis, Beckett's kyphosis. Furthermore, kyphotic deformity can also lead to stretching and lengthening of the spinal cord, resulting in increased tension and impaired the microcirculation, eventually leading to spinal cord ischemia and resulting in myelopathies over time. Kyphotic deformity may be asymptomatic or symptomatic. Asymptomatic patient with cervical kyphosis accounting about from 2% to about 35% from this deformity. If the kyphotic deformity is severe, we have a deformity called chin-on-chest deformity or drop head syndrome and other type of deformities. The patient can have significant difficulty with swallowing, maintaining the horizontal gaze, which is very important for daily life. What about radiological parameter? We can do a lot of X-ray, plain X-ray, and we can measure. We have many parameters for that. There are several radiological parameters commonly used to assess the cervical spine, including cervical lordosis, C27 sagittal vertical axis, T1 slope, and the thoracic inlet angle, and the neck tilt, and the last is the chin-brow vertical angle. This is the angle which is very important to be known by the spine surgeon and physician. The cervical sagittal vertical alignment, it demonstrates the distance between the C7 posterior superior end plate and the plumb line from the C2 centroid. The T1 slope, it is denoting the angle between the extension of the T1 superior end plate and the horizontal reference line through the midpoint of the T1 superior end. What about thoracic inlet angle? This is representing as an angle between the extension of the T1 superior end line connecting to the sternum and a reference line orthogonal to the midpoint of T1 superior end plate. The neck tilt angle denoting the angle between the line parallel to the T1 superior end and the vertical reference line. Cervical lordosis is another kind of deformity. There is no universal accepted definition currently for the normal cervical lordosis. By convention, a lordotic alignment is usually reported as a negative angle, whereas the kyphotic angle generally reported as a positive angle. The most common method for measuring the cervical lordosis, including the modified Cobb method, Jackson physiological stress line, Hermison and posterior tangent method, and the Eschlicher index. This is the method you can measurement of the cervical lordosis. There is many reported about the angle and how to measurement, and this is study, and the measurement is -39 plus or -9.5. This is another study which is measured by different angle. Also, the cervical lordosis can be accentuated or changes by the presence of the poacher or thoracic kyphosis. So the result is similar to the main C2, C7 lordotic -9.9. It is also important to notice that the cervical lordosis can be influenced by the posture of the patient and thoracic kyphosis. An average increase in cervical lordosis by 3 degrees from standing and from the sitting. In addition, cervical lordosis tend to increase with the age as a compensatory mechanism for the increase in thoracic kyphosis, and also reducing the lumbar lordosis to maintain the horizontal gaze. The C27, which is sagittal vertical, it is regional sagittal alignment, not a global, because we have a global sagittal alignment. This is the regional sagittal alignment of the cervical thrust is usually measured by C7 from C2 to C7 sagittal alignment, which has been shown to correlated with the healthy related quality of life. The C27 sagittal vertical is obtained by the measuring the distance between the C2 plumb and the vertical line drawn from the posterior superior end plate of the C7. However, the measurement we're obtaining from the cervical computer tomography imaging, thus the results are almost certainly erroneous due to the superior supine position. There is another reported with the measurement with the different angle according to supine or standing position. The cervical deformity classification, which is very important to be known by the surgeon, there is no universal accepted classification system for cervical deformity. The common classified system has been proposed by AMS, adult cervical spine deformity, and Chopper, adult spinal degenerative scheme. But the common using term, it is by the surgeon, is this deformity is flexible, rigid, kyphotic, or scoliotic, which is the most commonly used term. Unlike scoliosis, where the classification are used to determine the fusion level and the research required uniform description, in the cervical spine deformity, the level of the deformity are rather obvious. In 2015, AMS et al. Proposed the classification system for cervical spine deformity, including deformity description and the +5 modification. Based on the apex of the cervical deformity, he proposed the 5 deformity description, including the cervical area, cervicothoracic, thoracic, coronal, sagittal, or craniovertebral junctions. Also, the 5 modification, including the C27 sagittal vertical axis, and also the CPVA, the chin brow vertical angle, and the T1 C27 lordosis. Modified Japanese Score Association also scoring, and the Chopper classification for thoracolumbar deformity. This the proposal one, which is being mentioned by AMS. He classified this cervical deformity into deformity description into 5 types with 5 modification of this system. What about the surgical procedure for the deformity of the cervical spine? The aim of the cervical spine deformity surgery, including spinal alignment, correction of the deformity, restoration of the horizontal pose, decompression of the neural element as necessary, spinal stabilization, which with a biomechanical sound construct with adequate fixation point, avoid a complication. So we have a specific surgical technique, including either anterior, which you can use anterior cervical discectomy and diffusion, anterior cervical corpectomy and diffusion, and anterior osteotomy. This is an demonstrated sequential reduction of the cervical kyphosic using anterior cervical screw and the blade system. This is demonstrated the anterior osteotomy to correct the kyphotic spine. And this is the demonstration of the anterior cervical osteotomy. The drawing shows the buttress plate being used to prevent the graft exclusion during the posterior operation when the patient is in the prone position. What about the posterior procedures? We have a posterior instrumentation and diffusion alone, the Ponti type osteotomy, Smith-Peterson, or pedicular subtraction osteotomies. Also, some cases needed to go on a combined technique, anterior and posterior. This is algorithm for the cervical deformity if you have an fixed or non-fixed. If the patient has a fixed, is it focal kyphosis, go for anterior raise. If it is diffuse kyphosis with diffuse enclosing, if there is no diffuse enclosing, go for the 3-column osteotomy. If there is a diffuse enclosing, yes, open wedge osteotomy and posterior fusion. In non-fixed the deformity, cervical deformity, ventral compression less than 3 level, go for anterior approach. If there is a vertical compression and more than 3 level and posterior compression, go for the posterior approach and osteotomies with laminectomy and diffusion. In conclusion, cervical deformity can significantly impair the patient quality of life. Various surgical strategy and the technique existed to treat this challenging case. And this is a patient who somebody did for him and leading to this deformity. Regarding the specific surgical approach used, a solid understanding of the spinal biomechanics, a thorough preoperative neurological examination, a detailed review of preoperative imaging carefully, careful surgical planning, meticulous surgical technique are essential to ensure the best clinical outcome in the cervical deformity correction. دي أنا في النهاية بس ده تأثر شاعر بالطفل اللي هو دوت، فأنشد يقول: كل الذين يرجون المزيد وعندهم قوم من الأفضال ما أغباك، انظر لهذا الطفل يرسم ساقه متمنيا لو عنده ساقه، فاقنع بما آتاك ربك شاكرا فهو الذي من خيره أعطاك. الحمد لله على نعمه العظيمة. Thank you for your attention.
شكرا جزيلا دكتور بهاء for this constructive lecture, and we'll go for the next speaker, Dr. Ahmed Morsi, Associate Professor of Orthopedics and Spine Surgery at Shams University. He will highlight the surgical option of cervical canal stenosis.
مساء الخير جميعا.
مساء الخير دكتور أحمد، اتفضل.
مساء الخير دكتور يسري بيه، مساء الخير دكتور بهاء بيه، دكتور خالد بيه، مساء الخير. شاكر جدا لتشريفي بالدعوه بالإلقاء المحاضره. طبعا يعني دكتور بهاء بيه وفى الموضوع الديفورمتي حقه، واعتقد ان احنا هيبقى فيه يعني الموضوع برضه ريليتد لموضوع السيرفايكال ديجنراتيف سيرفايكال سباين اند ستينوزس. ابدا شير يا دكتور محمد.
Yes, please, Dr. Ahmed, and let us speak in English because we have some international friends attending.
I suppose you can see my screen now.
It's coming. It's coming.
Okay, is it apparent now?
لا لسه.
بس هي جايه
تمام.
بتاخد وقت.
There were a comment actually from Professor Gamal Baroud regarding Dr. Batargi case, and he recommend the importance of having medical insurance against malpractice, which is important, I think, message to be delivered to all of us.
It's mandatory in Saudi Arabia that everybody has medical insurance.
Yes, I think so.
Khalid, who paid this sum? Is the surgeon or the medical insurance or the institution who was working?
Dr. Khalid, you are muted. Kindly unmute yourself.
Both, I'm saying. The surgeon has to have, each doctor has to have a medical insurance for himself, and the institutions has to have also an insurance for the institutions also.
I think we have a problem with Dr. Ahmed Morsi getting in. So can I ask Shadi? Shadi, are you online?
Yes, I am. Can you hear me?
Yes, we can. Clear and
All right. Can I start?
Very friend and very eminent spine surgeon in the University of Boston, and he's the head of the orthopedic department. and we're glad to have him as always. Shadi is going to give 2 talks. The first talk will be treatment challenges in pathologic and metastatic spine disease, and the second would be the first would be a role of ATP in the aging spine. Shadi, can you go ahead, please, and start both your talks sequentially?
Can you see my screen?
Yes, we can.
Excellent. So first, I would like to thank the panel, Dr. Khattab, Dr. Hawari, Dr. Konra, for having me here today. I'm always very happy and honored in the presence of Yusri and Habibi Muhammad. Thank you for the invite. As stated, I'm going to give 2 talks back to back. I'm going to try to stay on time. It's 10 minutes per talk. So the first one is entitled is the role of ATP or the anti-psoas fusion in the aging spine. And I'm going to start by, let me see here. Excellent. So why it's that important is because we are human beings and we age with time and we cannot stop the clock. We're all heading to become an elderly population, if you may. And elderly population in the United States is the fastest growing population. And if we look clearly at any persons above the age of 60, they have a 50-50 chance of having a lumbar stenosis, and 70% of them, they will develop some sort of lumbar deformity. But however, as we are a healthier population now than before, the 60 is now the new 40, and who doesn't believe me can take a look at the picture of Dr. Yusri Al-Hawari here when he was 40 years old. And this is a picture of him at age 60. And some believe that there are rumors that he's operating in Boston sometimes. So I'm going to present with you a case of a 76-year-old male who is very active, presenting with back pain and leg pain. So his current complaints are 60% lumbar pain and 40% sciatica. And the sciatica goes down to the bilateral lower extremity. On the right side in the anterior thigh is more proximal. On the left side is more distal, down to the calf, plantar, and dorsum aspect of the foot. He had 3 prior lumbar surgeries. An original laminectomy with decompression in 2016 at L5S1. Another laminectomy at L4-5 in 2017. And a revision laminectomy of L4-5 in 2018 with an additional laminectomy at L3-4. So he had surgery with decompression between L3 and S1 over 3 years. Continued to have back pain, leg pain, trialed the facet blocks, the epidural injection, physical therapy, oral medication, you name it, he's miserable. On the physical examination, he does have loss of the lumbar lordosis. Examination on the right side is positive for femoral stretch test and weakness in the iliopsoas and quadriceps and diminished sensation in the L3 dermatome. On the left, he does have a positive straight leg raise with weakness in his foot dorsiflexors and plantar flexors with diminished sensation in the L4, L5, and S1. We got the imaging here. As you can see, this is his x-ray, and it's very noticeable he does have a loss of a lumbar lordosis with discal lapse mainly between L3 and S1. And on his MRI, although you do not see a significant central canal stenosis, there's a little bit of hint of spondylolisthesis at L3, L4 with severe discal lapse, and discal lapse at L4-5 and L5-S1. But when you look at the sagittal pictures, you will see that he does have a foraminal stenosis that is rather moderate to severe on the right at L3-4, clinically correlating with his right leg pain, and a severe foraminal narrowing at L4-5 and L5-S1 on the left, also correlating with his sciatica. So to further evaluate the discal lapse and the ankylosis in this gentleman, we got a CAT scan, and it shows almost bone-on-bone appearance with almost autofusion between L3 and L4, and some vacuum phenomena with discal lapse at L4-5 and L5-S1. And when we look at the lumbopelvic parameters, we see that his lumbar lordosis is about 10 degrees and his pelvic incidence is about 43 degrees with a lumbopelvic mismatch about 33 degrees. So here are the challenges of this case. This gentleman had the prior 3 lumbar decompressions. His pathology or stenosis is primarily foraminal. He does have a flat back deformity with a lumbopelvic mismatch of 33 degrees. And he does have a pseudo-ankylosed spine, basically no mobile discs that you can use to your advantage in order to gain lumbar lordosis. And he is 76-year-old. And on top of that, I just want to add one more picture for the surgical considerations. If you look at the position of the iliac crest compared to the disc space levels, you see how high is his iliac crest is about the level of L3, L4. All right, so based on all these challenges that I just cited, we do have a lumbopelvic mismatch, flat back deformity, foraminal stenosis, ankylosed spine, and a deep-seated pelvis with L4, 5, L5, S1 are below the iliac crest. So what would be your preferred surgical treatment for this patient? Would it be a revision decompression, or would you say enough is enough? He had a prior 3 decompression, now we'll do fusion. Should we typically wait for the results, or should we go for the questions?
Go for the questions, Sheikh.
We go for the. Okay, so we'll go for the next question then.
Because 60% are with fusion, you know.
So it's the 60% are fusion. Okay, so that's good. So now you chose. We chose a excellent, great. We're on the right track, I guess. So now we selected fusion, right? The next question would be, how many levels would you fuse? Can we activate the next question? Now remember, he had a decompression between L3 and S1, and he does have a collapse and loss of sagittal balance.
Most of the colleagues, 6% L3 to S1.
Excellent, very good. Now that we all agreeable that it's a fusion L3 to S1, what would be your technique of choice? Would you do an open standard posterior fusion without osteotomy? Now remember, you are doing there is a lumbopelvic mismatch about 30 degrees, and the discs are not mobile. So would you do a standard open posterior decompression without column osteotomy, or would you do with column osteotomy, or would you do standard ALIF with posterior open fixation, or would you resort to any minimally invasive surgery?
Most of the colleagues actually are going for standard open posterior decompression and fusion with posterior column osteotomy.
Okay, so that's excellent. And then, all right, so here where I'm gonna deviate from the crowd, and I'm gonna ask a hypothetical question. If you were to use a minimally invasive surgery, what kind of minimally invasive technique do you think it is viable in this patient? Is it a TLIF, MIS TLIF at multi-levels, or MIS transpsoas approach? Now remember, we talk about the anatomy and the iliac crest, how high it is. Or would you consider the ATP, or it's a form of OLIF, or a combination of the above, like a TLIF with an ATP, or a direct lateral with a TLIF?
we can say that, 50-50. Some will go for missed TLIF and the others will do a combination.
Okay, great, excellent. So that would be great segue to the next slide. So what was done? So this is what I did. I did the ATP or the trans-psoas or the anterior to the psoas approach. You see, this is an illustration on the left-hand side showing the difference between the ATP exposure to the spine, which is an oblique and anterolateral exposure, compared to the trans-psoas or the direct anterior. So this is the ATP surgical corridor, and this is another drawing that I made to illustrate that surgical corridor. And you can see with retracting the vessel, you can see how much exposure you can get to the disc space in the front. This is an intraoperative picture showing the exposure at L5-S1, and the asterisk is demonstrating the L5-S1 disc space in anterolaterally through the ATP exposure. So the exposure can be ample, can be safe, and you can do a complete discectomy and a release, anterior release over here, similar to what would you do through an ACDF for a cervical kyphotic deformity or a neutral spine. So this patient here, this is a preoperative picture, the preoperative lateral X-ray. And as you can see, his flat back deformity and the disc collapse between L3 and S1. And I sense that the right answer would be probably, if you cannot do an MIS procedure, just do an open posterior osteotomy. But that in a 76-year-old male, an osteotomy of the magnitude of the osteotomy had to include a not Smith-Peterson osteotomy. It would be a pedicle subtraction osteotomy, and that can be very bloody and may not be very well tolerated. So this is what I did. I did an anterior release using the ATP approach. I was able to open all the disc spaces, and you can see how much lordosis you're able to gain and establish just from opening those disc spaces in the front through the ATP. And this was followed by a percutaneous fixation. I did not do any open procedure. I did not do any osteotomies in the back. I just put the screws percutaneously just to lock him in this position. So if we look at, and we compare the preoperative X-ray with his lumbar lordosis being about 10 degrees to the postoperative X-ray, with a gain of a regional lordosis plus 35 degrees from the baseline, and the global lordosis of gaining about approximately 38 degrees from baseline. So I see that the procedure that we did over here, albeit a minimally invasive, gave him an additional correction better than a PSO, and certainly with much less risk of bleeding and complication. And this is AP view. So this is a gentleman here. He happened to have sent me a video. Now he's 78-year-old, and this is to show us what he does on a daily basis in order of exercising. He exercises approximately 35 minutes to an hour every day. So he starts with stretches. He follows with push-ups. He does the resistance bands. He does sit-ups, abs and core training. He does an upper body with chest press and pull downs. And it's approximately 35 minutes every day. And as you can hear in the background, his wife very proud of him, saying a 78-year-old man. So why ATP? Just to answer those questions, it is anatomy preserving technique. So I'm not really taking anything out of the spine. I'm not doing osteotomies. I'm actually opening and reconstituting the normal, establishing the normal disc height and the segmental lordosis. The ATP can allow me to do a direct decompression, and similar to an ACDF does a direct decompression of the cord, I can do direct decompression of the dural sac, and indirect by increasing the foraminal height as well. And it provides an accessibility to entire lumbar spine between T12 and the sacrum through a small single incision anterolaterally. And in my opinion, it is an access solution to all lumbar pathologies. And I like to call the ATP is a BS, and a BS stands for a broad spectrum surgical treatment. You can do it for an isthmic spondylolisthesis at L5-S1. You can do it for a complex deformity like this adult scoliosis. You can even do it for traumatic burst fracture and or tumors or infection. So I would like to thank you for listening to me on the talk of the ATP. Now I'm gonna move to the next talk, if that's okay with everybody.
Yes, okay, Shadi. Move to the next talk, and we'll keep the discussion after your second talk.
Excellent. Let me do now reshare my screen so I know, make sure this is over here.
أحمد مرسي. الباقة خلصت. النهارده آخر الشهر.
Oh, sorry. I don't know what happened here. Oh, that was the old one. I had it up. I don't know where it went. Oh, here it is. All right. Can you guys see the screen now?
Yes.
Excellent. So I apologize for this delay, and I want to also thank you again. I would like to thank Dr. Baturgi as well for his case presentation, because that would ties into my case presentation as well. And this is the title of the presentation is Treatment Challenges in Pathologic and Spinal Metastatic Disease. So the background is why this is important is because as we are a growing population, as with age, there's more than 1.2 million new cases of cancers are discovered, at least in the United States alone. More than half of those patients will develop spinal metastatic disease at some point in their lives. 10% of those would develop spinal cord compression, similar to the case that Dr. Khalid presented. And 5%, half of those will lose the ability to ambulate. So it is a big deal. The goals of treatment are mostly for the majority of those patients are palliative, to reduce pain, provide column stability, and improve their quality of life. And as Dr. Khattab mentioned, is to live with dignity, at least for the last month or a year of their lives. In a very minor part of these patients, the minority is to provide them with curative treatment, and those can be applied to the primary tumors, typically. And in some metastatic ones that the primary is curable. So I'm gonna just present a few cases to start with, and then we'll do some highlights and we go back to the outcome. So this is a 77-year-old male with prostate cancer. As you can see, there's the metastatic disease is disseminated, is not typically confined to one vertebra, is mostly everywhere. He does have pathologic fracture throughout the thoracic and the lumbar spine, and his neurology has a Frankel C weakness. And this is another patient who has a multiple myeloma with disseminated disease. As you can see on the CAT scan, it's everywhere in his thoracic, lumbar, and even part of the pelvis. So when treating with this patient, the complexity involves taking into consideration multiple factors, patient-related factors, tumor-related factors, and the mechanical of the spine itself. So when you're trying to design treatment, you have to look at these three elements. How is the patient's neurology? What's their life expectancy? You got to look at the mechanical aspect of the spine. Is the spine stable enough to maybe do something minimal? Or is the spine is collapsing and you have to do a major reconstruction? You also got to look at the tumor sensitivity to other treatment. Is this tumor that is radiation sensitive, or is tumor that is going to be resistive to chemoradiation? You have to do something surgical. So when you start looking at a treatment decision making, a lot of questions come to mind. Radiation therapy, decompression with fixation and fusion. What we looked at the data showed that radiation therapy is no longer preferred, and decompression alone in patients who have metastatic disease with risk of pathologic collapse yield the worst outcome. So the modern surgery with radiation, the combination of surgery and radiation, yield better outcome and quality of life for these patients. So now we answer the question. Surgery is the preferred answer in a patient who is relatively healthy and can tolerate surgery. Now, the next big question is, what would you do? Typically, these patients have skip lesions. They have metastatic disease in their lumbar spine, in their thoracic spine, and sometimes in their cervical spine. Most of these patients, they tend to lose neurologic function quickly. And you have to be able to make a decision on an urgent basis what to do. A lot of these patients also, they have poor metabolic reserves. They don't have the good nutrition support. They've probably been deprived of food, anorexic due to the cancer, in a catabolic state that their body is not going to heal very well with a big complex procedure. And a lot of them, they either have undergone radiation therapy or they're about to receive radiation therapy for local control of the disease. So these elements would put a lot of challenges on the decision making. So what is the standard of care? Still a midline, big, open incision, debulking of the spinal cord, corpectomy, and reconstruction. Whereas we know that these type of procedures, they are associated with increased reoperation rates due to infection, hardware instrumentation, and local recurrences of the disease. So what about minimally invasive surgery? Now that we established that the maximally invasive surgery, it has a high revision rate. So there have been some reports on limited minimally invasive approaches to very well localized tumors in the spine, and that those were treated with percutaneous instrumentation and some tube decompression, and they show that they have an okay stability. They allow early post-operative ambulation. They have much less wound complication than the literature have shown in the open procedures. They have much lower blood loss and shorter hospital stay. So now we have an answer that minimally invasive may be a better and viable alternative than a major open procedure for the reason I stated, but we still don't know what to do about the metastatic disease that involves multiple segments in the spine: thoracic, lumbar, possibly cervical. So at this point, since we don't have a good answer for that, we decided to study that in our institution. So myself and my partner, Tony, so we decided to say, we're going to treat those patients and we're going to do multiple points of fixation, same way we treat the femur. When you have a peritrochanteric lesion in the femur, you just don't put small plate, but you just span it with a long cephalomedullary nail. So we don't use cephalomedullary nails in the spine, so we're going to span it with screws and rods. So our inclusion criteria was to look at patients who have more than 2 skip lesions, basically 3 or more skip lesions, and more than 6 levels of the spines are involved or fixed. And we followed those patients to see what happened to them. Typically, we treat them, and the treatment was a percutaneous instrumentation alone. So basically, we're taking the spine that's kind of collapsing, crumbling, and we're just putting screws and rods in it with limited fusion by decorticating the facet joints. So we did percutaneous pedicle instrumentation using fluoroscopy. And as you can see here, that's an intraoperative picture of the percutaneous fixation that's been utilized in one patient. Patients are typically in the prone position, as you can see here. This is us putting a T1 to pelvis percutaneously. This is a close shot of it. So in this database, we had 13 patients. Now we did an updated review of the database, and we're up to 24 patients now. But I'm going to present the data that we presented in the WOS in the Academy meeting a couple of years ago. So 13 patients were included, and on average, 12 levels were instrumented per patient. 5 patients, they necessitate adding iliac fixation because there was involvement in the sacrum and the pelvis. The average time or length of procedure was 3.5 hours under anesthesia, and the average blood loss was about 450 cc's. And in terms of clinical outcome, at 2 weeks post-op, most of the patient has more than 50% reduction in their VAS scores for back pain. And they all have, although all patients showed improvement after surgery compared to preoperative neurologic status, 80% had 1 grade improvement and 20% had 2 or more grades improvement of their neurology. We did not observe at 1 year follow-up, we did not observe no hardware-related complication, no surgical wound complication. And all the patients that they were eligible to receive radiation therapy, they were able to start that successfully at 2 weeks post-operatively. So we realized that surgical stabilization without doing a direct decompression, without doing a major laminectomy, yield into satisfactory functional outcome. Let's go back to the cases I presented earlier. This is a 77-year-old male with a prostate cancer. And that's his post-operative X-ray. And this is the 60-year-old male with multiple myeloma. And that's his X-ray, T1 to pelvis. Play the video. This is 6 weeks after the T2 to sacrum instrumentation. And this is his X-ray in the AP lateral views. You can see the percutaneous small incisions where we used to place the screws, and you can see the skin changing from his radiation therapy. So this is 6 weeks post-op. He has completely healed incision. He already started radiation at 2 weeks after surgery. So in conclusion, and our data on this patient, that a percutaneous fixation throughout the thoracic and lumbar spine can be a one-stage fix, because we know that if you do a smaller surgery, you're taking the risk that the other part of the spine may deteriorate and may collapse with time. It allows the patient early ambulation and early weight bearing, almost immediate pain improvement of their pain scores, and it reduced the surgical morbidity and the blood loss that we were talking about, the 7-liter blood loss with multiple need for multiple transfusion by the one that Dr. Baterjee was talking about. And it allows early initiation of radiation therapy. And in the interest of time, I'll stop here. I'm happy to answer any questions.
Thank you so much, Shadi, for your nice informative talk. There is 2 questions regarding the last one. What about using cement, either by kyphoplasty or vertebroplasty in these cases? And the other one, in cases with acute paraplegia, shall you consider it an emergency and you intervene directly, or you take a biopsy and do embolization and then plan the surgery?
So these are great questions, right? So then let me answer the first one. I have used cement augmented screws. So if I feel like the instrumentation mainly at the junction, basically on the top and the bottom, mostly at the top. If the fixation in the upper thoracic spine seems to be weak, or I feel that the screws are soft, or the bone screw interface is soft, I would supplement it with, I would inject the cement through the fenestrated screws in the top area. And seldomly, I may use it in between the segments that are being fused. But you have to be careful. In most of these patients, if they have lytic lesions, the posterior bony cortex of the vertebra may be affected. And if it's deficient and you're putting cement in those, they may leak into the canal, become a bigger problem. So yes, in some patients I'm not against it, and I have used it in the past. And the other question would be, would you act right away? Do you take a biopsy? The neurology is one element, and it's certainly something that would push me to do something sooner rather than later. But you would be surprised how many of these patients, when you put them in the supine position, when you put them on a complete bed rest, a lot of the compression on the spinal cord is dynamic. Is when they're up sitting or when they're walking, the spine start bending and start having a mechanical compression on their cord. And when you put them flat on their back, a lot of that dynamic compression, the dynamic mechanical compression on the cord become less, and they may start experiencing some improvement of their symptoms. So not all patients you have to be running into the OR right away. This decision has to be made between you as a surgeon, between the patient, and the oncology team. If the oncology team tells you this patient has less than 3 months to live, at this point you're going to sit down, talk to the family, and say, listen, the prognosis doesn't sound very promising. I think with all the data we have, maybe the best course of action is to keep them comfortable and not have them going through a major surgery. However, if the oncology team comes and tell me, well, this person has a very good chance that they would be surviving a year or two, then I'm gonna be convinced to do something sooner rather than later, because I'm gonna preserve their functional status or the function of their spinal cord. So it is not, there's not one answer that fits all. It's really custom to each case by case. And as I told you, I have seen numerous patients that they come in with flaccid paralysis in lower extremity. You put them on their back, you put them on flat bed rest, and you give them some steroid, and the next days they start, or the day after, they start moving their legs. So I think it's very important first to put them on a complete spinal precaution, give them maybe a couple doses of IV steroids, and reevaluate them, because a lot of them, they will have some dynamic compression of their cord, because with the spine being affected, the vertebra becomes like a marshmallow, like sponge. The more you put pressure on them, the more they bulge and the more they cause compression dynamically on the spinal cord. Whereas when you put them on the supine, in the unloaded status, that dynamic compression may improve, and that you may see some improvement in their functional status. And that's why a percutaneous instrumentation may be viable in those patients without doing any direct decompression.
Can I ask questions there, Shadi?
Of course.
I have two questions. First one, how you are confident with when it comes to decompression? You say, this patient I will decompress, regardless whether this is a MIS or an open procedure, or I don't decompress. Is it the rule that you don't compress if there is a spinal cord compression? This is the first part of my question. The second question, I'm amazed how you do MIS from upper thoracic to the sacrum. Does the road really go smooth through all these screws, or how you manipulate these? Because usually we are used to the MIS 2 levels above, 1 level below, and so on. So the short distance. My question is how you pass all the roads through the upper thoracic to the sacrum.
Great question. So let me answer the first one. Is it absolutely, is there a standardized way of saying I'm going to do MIS and no decompression at all, or I'm going to do decompression? The way I look at it, if the spinal cord compression is mainly ventral and lateral, I think that patient would benefit from percutaneous instrumentation alone. If there is a component of a dorsal compression of the cord, mainly epidural dorsal compressing the cord from posteriorly, then in addition to the percutaneous fixation, I may do a mini open central midline laminectomy and decompress the cord through it. So in the series that we presented, the 13 patients, 12 of them had only percutaneous instrumentation, and only one patient had a midline mini laminectomy or a partial laminectomy because he had a component of a dorsal epidural metastatic disease that's causing compression on the spinal cord in addition to a ventral compression. So there was 360-degree circumferential compression of the cord. So that's to answer the first question. For the second question, the technicality, yes. It is technically challenging. It's not as easy or straightforward like passing a short construct rod. However, you can use the curvature of the rod to your advantage. Typically what I do, there's a thoracic kyphosis and the lumbar lordosis of the rod, and I pass the thoracic kyphosis first, but flipping the rod sideways. So I flip the rod 180 degrees and I pass the kyphosis in a lordosis fashion. Then I turn the rod when I'm over the hump, when I'm almost near the tip of the thoracic kyphosis. Now I turn the rod 180 degrees and pass the remaining part of it. So it is certainly tricky, but it's not impossible. If we were able to do it for 24 patients, I think it's feasible.
Thank you.
What about, can I ask? Professor Batarji presented about debulking. Can we do debulking in different levels?
Yes. It's not unusual when you do the percutaneous fixation and you stabilize the spine. You can at that point choose. At this point, you don't have a big open incision from top to bottom, and you're fighting time, and you're fighting bleeding, and you're fighting anesthesia. The entire instrumentation takes approximately 2.5 hours. And then you can still have a time to do limited decompression or debulking on any segments you would like to do so. And as we've seen in our results, we're able to achieve those surgeries on average is about 3.5 hours or 3.7 hours of general anesthesia time. So that include the skin incision, and the closure time, which sometimes the closure can take up to half an hour or 45 minutes, even for those small percutaneous incisions.
Shadi, thank you very much. Great talks. and as always, and would like to have you for the coming meetings, and thank you very much. And now we proceed for the next talk. Dr. Ahmed Morsi. Dr. Ahmed Morsi in.
Yes, Dr. Yusri, I'm in.
Surgical options in cervical canal stenosis. تفضل دكتور.
Yes. Is my screen apparent for you, sir?
Yes, we can see it.
Okay.
Proceed.
Okay, so this talk will be about the surgical options for treatment of cervical canal stenosis. As you all know, that cervical canal stenosis is usually a progressive spinal canal diameter narrowing. It is usually associated with muscle spasm, neck pain, due to agents on the neural elements, whether the spinal cord or the nerve roots. There's a progressive decline in neural function in both neural elements. It occurs usually more at males. Also, about 13% will present at the third decade of life, and above the age of 70, mostly 100% of normal individuals will have some element of cervical canal stenosis. Briefly, the pathophysiology is represented by some osteophytes formed, especially posteriorly over the end plates from the ancovertebral joints as well, and from the facet joints, in addition to buckling of the ligamentum flavum due to the collapse of the anteriorly located disc spaces, together with the posterior bulges of the discs, and sometimes with ossification of the posterior longitudinal ligament. Sometimes there may be non-obvious compression or stenosis on the static MRI or CT, but some patients, as just Dr. Shadi mentioned in the previous lecture, may have some kind of dynamic instability or dynamic stenosis or dynamic compression, where when the patient flexes his neck, he starts to develop symptoms of weakness or electric-like pains in upper limbs or in lower limbs. The neural compromise is usually either direct or indirect, and may be static, like with the ligamentum flavum, posterior disc bulge, end plate ossifies, or dynamic in cases of unstable spine. The pathology, as we know, affects the spinal cord from anterior and from posterior, and the neural foramina as well. The most common cause of cervical canal stenosis is a degenerative type. Although patients with pre-existing congenital canal stenosis may present earlier when they develop the degenerative changes, so they may present in the third or the fourth decade, while degenerative canal stenosis patients who have no element of congenital stenosis will usually develop later on in the fifth or the sixth decade. Other causes include the ossified posterior longitudinal ligament and the diffuse idiopathic skeletal hyperostosis. Patients with rheumatoid affection may have a compromise at C1, C2 levels, but facet joint affections, being synovial joints and affected by the rheumatoid disease, can also be a contributor to cervical canal stenosis. Some patients who experience trauma and fractures, whether properly or improperly managed, can develop some kind of cervical canal stenosis, whether foraminal or central. Of course, tumors and infection can present with signs and symptoms of canal stenosis, but I will not talk about this in this lecture. I think it's a different scope lecture. The normal canal diameter is usually between 17 and 18 millimeters. It can decrease down to 12 to 14 millimeters, where in just case we can define this as narrowing of the spinal canal. Of course, it's measured on the axial views of the CT scan. Normally, the spinal cord diameter at the cervical region is around 1 centimeter, and there should be at least 5 millimeters around the cord, as a total of 15 millimeters as the space available for the cord to be found on axial CT cuts, or in axial MRIs. As I said, patients with elements of congenital stenosis will present earlier in life. Those without congenital and only degenerative type of stenosis will present later in life. These are the pathological changes that occur: disc height degeneration and reduction, facet joint arthrosis, osteophytes from anterior and posterior and from ancovertebral joints as well, buckling due to the collapse of the ventral disc height, buckling of the ligamentum flavum, many times described as hypertrophy of the flavum. It may occur in single level, double level, or may affect the whole cervical spine level. As a result, there will be spinal canal narrowing and intervertebral foraminal narrowing with subsequent impingement of the spinal cord and the spinal nerves. In the early stages, it will be a compression and compromise of the vascular supply of the cord and nerves. Later on, it will be direct compression of the cord and the nerve. And these are examples of MRI sagittal T2 sequences. Here we can see in the left picture or image that we have two levels of disc prolapse and degeneration with disc height decline. Why this is not a simple disc prolapse? Because we can see here there are osteophytes anterior and posterior on both sides of the disc space, with narrowing of the disc space in comparison to the levels above, with compression of the spinal cord, and as we can see, the cord edema or cord myelation or myelomyelation changes that are apparent, denoting there is cervical myelopathy. On the right side, there's another picture with marked diminution of multi-level disc space, 4 levels starting from 3 down to 6 cervical 6 levels, with end plate osteophytes posteriorly and bulging annulus fibrosis compressing the cord, which appears more or less festooned in appearance. There's no marked myelinic signal or edema in the cord as compared to the right one, but in this patient we can expect that this patient will have much more radicular symptoms in his upper limb rather than lower limb symptoms. And we can see here that the ligamentum flavum posteriorly is a little bit thickened or buckled, posing or imposing some kind of compression on the dorsal aspect of the spinal cord, with disappearance of the CSF signal, bright CSF signal anterior and posterior to the spinal cord in cervical region. Talking on the pathophysiology, it has been strongly suggested that the vascular supply and the compromise of the vascular supply of the spinal cord and the nerve roots have a critical role in the occurrence of the pathology. We know that the spinal cord is supplied by a single anterior spinal artery, which is formed by the union of two anterior spinal arteries arising from the vertebral arteries, and supplied by two posterior spinal arteries, each from one side, arising from the posterior inferior cerebellar arteries. As we can see here, this is the vertebral artery, okay, and these are the anterior spinal arteries, giving the single anterior spinal artery which descends on the anterior furrow, on the anterior aspect of the cord, and the posterior inferior cerebellar arteries here give rise to a posterior spinal artery, which descend down the posterior aspect of the cord, separate from one another on both sides of the spinal cord. The clinical picture, as we know, it includes neck pain, shoulder pains, radicular pains, sometimes referred pains to the upper limb, gait instability, frequent falls. Sometimes the patient may present with lower back pain, and rarely bladder dysfunction, very rarely, is a consequence of cervical canal stenosis. If you find the patient with cervical canal stenosis with complaining of bladder symptoms or abnormality or disturbance, better send him to a urologist to check his prostate if he's a male, or check his lumbar spine, because mostly the cause of bladder dysfunction will be from the lumbar region or dorsal, mainly from the lumbar region rather than the dorsal or the cervical region. There will be a limitation of the range of motion of the neck muscles, because these muscles are spacting, trying to guard against motion and limit pain. This muscle spasm will add to the congestion and disturb the circulation of the cervical roots and the spinal cord. we may find wasting of the hand muscle and exaggerated reflexes in the lower limbs and in the upper limbs if the level of stenosis is high. This is the classification which describes the state of myelopathy in the patient, graded from grade 1 to grade 5. And we can see here that it describes mainly the walking ability of the patient and his gait, and if he's wheelchaired or normally ambulatory. And there's a range between the two degrees of affection. Before we proceed to diagnosis or surgery, whether we are going to manage the patient medically or surgically, we should consider other pathologies in nearby joints like neck to shoulder joints, because some patients may have associated pathology, especially if you find that the imaging studies you're getting are not that severe and are not enough to explain the patient symptoms. As we can see here, these are the main imaging investigations, and the imaging is of special importance, not just to diagnose the presence of the disease, but also to decide which way we are going to attack this pathology. The X-rays are the primary and are very important, and you usually will find the patient having many X-rays because usually the patient's condition is long-standing and maybe refusing surgery for several years, so you have to check for newer X-rays. You have to check for the alignment of the cervical spine to decide which approach are you going to follow, anterior or posterior or combined approach. You have to check for the disc space height and the foraminal stenosis and the location of the most prominent offending element on the X-rays, as well as on the MRI and the CT. The CT is important also if you are planning to go from the anterior approach, because it will help you detect any ossification of PLL, which will make anterior approach very difficult and insufficient to decompress the cord and the foramina. For example, here in the X-ray, we can see that the spine is straight. There is no cervical kyphosis. This makes this patient liable for an anterior approach as well as a posterior approach. Some of you may prefer going anteriorly to correct at least partially the cervical straightness and the lack of lordosis in this patient. Of course, we are going to study or look at the levels of affected pathology and if there's any abnormality at C1, C2, especially if this patient is a rheumatoid patient. Here we can see on the MRI that the offending agent is both anterior and posterior at C3, C4 level with minor disc bulging inferiorly. So this is a 3-level canal stenosis, most prominent at C3, C4. And this really makes you very confused whether to go to from the anterior approach or the posterior approach. But bearing in mind that this patient or this buckling of the ligamentum flavum is due to the decline in disc height anteriorly, going through the anterior approach and restoring the disc space height using a large sized cage while removing the offending elements anteriorly may help stretch this ligamentum flavum posteriorly, indirectly reducing the posterior compression, which makes you decide for anterior approach rather than posterior approach. Of course, if you get multi-level affection, for example, 3 or 4 levels, so going anteriorly will be not the best choice because the incidences of pseudoarthrosis are much higher with multi-level anterior fixation or fusion. And it will be also time consuming, much more time consuming than the posterior approach. And this may pose more morbidity for the patient. Here in the last image on the MRI, we can see also that the main offending element of the pathology here, sorry. The main offending elements here is coming from anterior, from the end plate osteophytes and the disc bulges. And here's the myelinic changes you can see within the substance of the cord. Usually these patients with cervical stenosis, especially moderate to severe ones, will not improve without surgery because as I just said, the problem is both vascular compromise and mechanical compression to the blood supply and to the cord directly in severe cases. And the progression occurs usually in a step-like fashion. The patient gets deterioration in his symptoms, then gradually improves, then again, and then again the attack is repeated, and every time there is much more deficit, much more morbidity, and much more neural compromise. There may be some periods of stable symptoms, and this may falsely give a notion that this patient is improving and may not need surgery, so better not to be deceived by these periods of stable symptoms. Early surgery usually raises the chances of improvement. More rapid improvement occurs with earlier surgeries, and more profound recovery occurs with earlier surgeries. What happens if we neglect this patient and he needed surgery and he refused the surgery and we didn't offer him surgery? There will be progressive weakness and stiffness. There will be frequent falls and other fractures in hips, knees, or spine. There will be a gradual reduction in his activity and social withdrawal, depression, and so on. Many patients experience sleep disturbances because of the neck pain or the neuralgic symptoms in their upper limb. And regarding the bladder control I just mentioned before, it will possibly not be due to cervical problems, mainly will be due to some sort of occult or non-diagnosed lumbar problem. The non-surgical treatment is usually described in mild to moderate cases where there's no deficit, no ataxia, no frequent falls, or while we are preparing for surgery after it is decided and the patient has agreed. Also for some neglected severely affected cases who are chair-bound or non-ambulatory, and there is no hope of recovery, and they are not complaining of severe pain or severe symptoms. The aims are usually to relieve pain by medications or by physical therapy, to stabilize the spine using a collar, use walking aids to reduce the incidence of fractures, and improve blood supply by using vasodilators and other vasoactive medications. When are we going to proceed for surgery? If failure of medical treatments occurs, especially in moderate cases where we can try medical treatment. If there is evidence or progression of the cord myelacea on MRI T2 sequences, if there is a progressive deficit, whether weakness in upper limbs or lower limbs, gait abnormalities, frequent falls, all of these are indications for surgery. In some cases with stationary moderate to severe upper motor neuron lesions, we have to go for surgery also, even if there are stable periods of quiescence or partial improvement. This is not an indication for neglecting surgery, but an indication for proceeding to surgery. But also in some patients with persistent pain, with moderate stenosis, the patient can benefit much from surgery. The aims of our surgery will be first to slow or prevent actually the progression of the neural compromise, to bring some improvement, which is usually partial, not total or not complete improvement in the patient ataxic gait, and even if there's any spasticity in his lower or upper limbs, to relieve the radicular symptoms, which is usually attained by widening the intervertebral foramina and foraminotomy while doing the surgery, and fuse the unstable spine, whether this instability is pathological, arising from the disease itself, or inherent in the patient, or iatrogenic, being brought by previous surgery, or by index surgery if I'm performing massive decompression for massive cases of stenosis. I will usually need to stabilize the spine because removal of much bone will consequently or subsequently bring much instability. The approaches are usually anterior or posterior or combined, whether first single stage or two-stage. The anterior approach is usually in the form of multiple AZDFs. Less commonly, canal stenosis in cervical spine is diagnosed as a single level. It usually entails corpectomy and reconstruction or multiple ACDFs. Usually, the advantages are the anterior approach attacks the primary pathology, which is the end plate ossifies and the disc bulges, which are compressing the cord. It can correct deformity if the patient has hypolordosis or or straight spine, or in some patients marked kyphosis. It is usually under compressive forces. The cages or the bone graft will have a higher chance for healing and lower chances of pseudo arthrosis. We can improve also the foraminal height by restoring the disc space using a bigger size cages, and we can add plating to make the construct more stable. The disadvantages is of the anterior approach is usually it is a multiple in multiple level, more than 3 or more levels may bring pseudoarthrosis. Sometimes the anteroposterior diameter is increased in some patients, so there's still canal narrowing, although we have removed the whole disc and the whole PLL, still there is narrowing due to the anteroposterior diameter increase of the body. You can't bring much bone because you didn't remove bone while you are doing ACDF. So we have to use some iliac crest graft or bone graft substitute. And sometimes there is persistent posterior pathology like the ligamentum flavum and facet joints if you don't restore much the anterior disc height. It usually entails the anterior approach, whether discectomy and posterior end plate ossified removal, foraminotomy from the posterior uncovertebral joints, PLL removal, unless there is dynamic stenosis, not physical stenosis, so we can just fix and stabilize the spine for the aim of fusion. Realigning the cervical spine, improving the lordosis and correcting the kyphosis if any, and in some patients with increased anteroposterior diameter of the body, of the vertebral bodies, and multi-level affection and osteophytes, we can perform corpectomy and reconstruction, of course, with stabilization. These are examples, whether anterior stabilization alone if there's dynamic instability, or corpectomy and reconstruction using titanium mesh cage and instrumentation in the form of plating. As regards the posterior approach, it can be performed either without fusion in the form of foraminotomy or laminectomy or laminoplasty. With fusion, some cases we need fusion if we are performing massive laminectomy, and we usually use either lateral mass screws or pedicle screw fixation. The advantage of the posterior approach is usually it can be used in multi-level affection rather than better than the anterior approach. And in this approach, we can perform either decompression alone or decompression and fusion. These advantages is that you can miss easily the anterior pathology if there is marked osteophytes from anterior aspect or marked large size disc prolapse or bulging. It cannot restore the lordosis in patients with kyphosis, so it's usually either replaced by anterior approach or combined with the anterior approach to correct the cervical deformity. If you perform the posterior laminectomy, whether with instrumentation or without, there may be a posterior cord sagging, and this may result in some kind of root palsy, especially root C5 palsy. You usually need over decompression, not just the level of stenosis. You have to remove one level higher or lower, the lamina I mean. And fixation may be difficult, especially in the lateral mass in elderly and osteoporotic patients. These are examples. Here is keyhole foraminotomy from the posterior aspects if the patient is mainly complaining of radicular symptoms with no myelopathic symptoms or ataxia. Here is a full laminectomy in all the cervical levels, and as we can see here, this patient, for example, although he has a straight spine, where he has to be corrected using ACDFs, but laminectomy was only done for him posteriorly with very much improvement in neurologic conditions in the lower limbs, but later on this patient may develop easily into kyphosis. Other examples, these are the anterior approaches in the form of corpectomy and mesh cage with or without fixation. Of course, if I'm going to replace the body or do corpectomy, you have to do supplemental plate fixation, and you can use hybrid fixation in the form of ACDF together with corpectomy. Here on the right side, you can see the full laminectomy performed with lateral mass screw fixation and fusion from the posterior aspect. Here are examples of posterior approach alone. Posterior approach alone, lateral mass fixation with laminectomy. Here are combined approaches: anterior interbody fusion with tricortical fibular or iliac crest grafts, and posterior laminectomy and instrumentation and fusion from the posterior aspect. Here, same here, but with supplemental anterior plating. Usually the post-operative regimen is in the form of cervical support till fusion, unless you are fixing the patient, the vertebral bodies with anterior plating, starting rehabilitation programs to reduce the incidence of falls and restore balance and muscle power, because patients will get some time to recover their neurological power. Use of walking aid to reduce the risk of falls. Use of medications to support the neural elements and improve the chance of recovery. These are the complications of surgery, whether anterior or posterior. Here we can see root palsy, especially root C5 palsy, which occurs more with the posterior rather than the anterior approach due to posterior sagging of the cord. Limb weakness also with posterior rather than anterior. Pseudoarthrosis more with anterior, because usually if you have multi-level anterior ACDFs, you will get one of them will fail to fuse. Construct failure, this is usually more with the posterior approach because the lateral masses may be weak or osteoporotic. Dural injury can occur in either approaches, and the repair will be much difficult or impossible from the anterior approach, but much easier in the posterior approach. And infection, which will depend mainly upon the surgical technique and the surgeon meticulous technique and the duration of the surgery. So it's better to perform whichever technique you are well-oriented with and well-trained in. In summary, moderate and severe cases are critical indications for surgery. Patients do improve in variable degrees after surgery. The earlier the surgery, the earlier the recovery, and the much more benefit the patient may gain. We should consider cervical spine alignment while choosing between the anterior and the posterior approach. And we should study the pathology location and make our decision accordingly. Thank you all for listening.
Thank you so much, Dr. Ahmed, for your informative talk. And due to short of time, we will proceed for the last presentation. It will be low back pain. Is it really a dilemma, and how we can solve it? First of all, I'd like to thank Utopia for sponsoring this webinar. And I'd like to present this presentation in combination with my great mentor, Professor Al-Hawari. The natural history of back pain, it is really common, and we can say it is normal, at least expected. 80% of the population can present to you in the outpatient clinic complaining from back pain, and it is most probably due to wear and tear. And 40 to 60% of the people, the normal people, can have one of the Fuhrman stages in their MRI. And it is really a problem and affects the quality of life. And 50% of the workers can seek for compensation due to the back pain. And the patients with chronic back pain can really have some sleep difficulties and anxiety and depression. And in order to tell the patients that you will go for rapid recovery, inshallah, 50% within 2 weeks, 70% in the first month, 90% recover by 4 months, we need to identify the causes. Professor Hawari, can you tell us how to identify the causes and probably manage our patients?
It's a long history of causes for low back pain, and if you want to go by every disease, then you will be in a dilemma. So is there a easy way to collect all these diseases and to go into a diagnosis more quickly? Yes, it is. First, what's the spectrum range of back pain? It could be mild, like muscle strain, or could be fatal, like rupture aortic aneurysm. So you don't want to miss this fatal aneurysm as a low back pain minor. Pain generator, many pain generators from the skin down to the bone, the facets, the annulus. In the past, we thought that the annulus has no blood supply or no nerve supply, but it's yes, there is a nerve supply from the C fibers from chronic inflammation or degeneration. So it's better to put all the patient symptoms and findings into a syndrome, like entrapment syndrome, collocation syndrome, instability syndrome, osteoarthritis syndrome, spondylitis syndrome, pathological fracture syndrome, spondyloarthropathy, anxiety, and what's rest you can put it in miscellaneous. What do we get in the entrapment syndrome? Usually it's a leg pain, not combined. And it follows a nerve distribution, whether most commonly L5 or S1. And numbness is the key for this entrapment syndrome. And it crosses the knee, and the patient can get pain at rest. And this is an example of L4-5 and L5-S1 disc prolapse, huge disc prolapse, which the patient ended in decompression at both levels. The collocation syndrome is different from the entrapment syndrome. It's leg pain mainly. It comes with walking, and this is the key. And improves by sitting or bending forward. And there is no rest pain. There's minimal signs unless you do a provocative test. You ask the patient to go up, down the stairs, and then you re-examine or put him on a bicycle and then re-examine, and then you can find your sign. And the stenosis can come from any element of the spinal canal, the disc, the fasces, the ligamentum flavum, all can cause the stenosis. And you can get the instability syndrome. It's common. It's the main symptoms, like when you have instability of the knee. If you have a deficient ACL knee, the patient has got no pain at rest. Once he uses his knee, then he gets the instability and gives way. Same with the back. It's mainly back pain, occasional leg pain. It's more with activity, no rest pain, and the patient is better with brace. And this is an example of a patient who had 5-1 fusion, and after several years, he developed this instability pain, and he had spondyloarthritis above the level of fusion, which necessitated going up a level more. Osteoarthritis syndrome or spondylosis has same symptoms like osteoarthritis of the knee. You get morning stiffness, patient is better till the afternoon, and then at night he's worse again. The episodes of locked back, mainly it's back pain, and it's worse by brace, same to the knee. And you can, by the MRI, you find degenerated either disc or facets. And the spondylitis, this is inflammation, this is infection. It's characterized by severe back pain, night pain. The pain is there whether the patient is resting or in activities, and then you have the general symptoms. This is an example of patient having discitis of the L5-S1 together with lytic spondyloarthritis, and the patient has got really, he's a sick patient. He's not a normal patient. Patient is sick from the spondylitis. Then you have the fracture, pathological fracture syndrome. There's a history of fracture, usually a minor trauma. It's a rest pain. Patient is kyphotic. It's progressive. He has no leg pain, usually female over the age of 50. And this is an example of a compressed fracture. And what you see in this compressed fracture is the gas shadow, or in the MRI, the fluid in the vertebrae. And this is pathognomonic of pathological fracture. And this can be easily treated by doing a vertebroplasty of that level, and it really relieves the pain very rapidly. And then you have the spondyloarthropathies, the SPA, including spondylitis, Reiter, other disease. The pain is axial in the middle of the body. It starts with sacroiliac pain. Then you don't want to diagnose these cases when they are kyphotic. You want to diagnose them early so that they can benefit from the biological treatment. And HLA-B27 is positive in like 85% of these cases. But the early sign, if you look at the L4, and you find that the L4 becomes square. And this is the early sign you can see in the plain X-ray. And as I said, you don't want to diagnose these patients when they are kyphotic like this. The head doesn't reach the bed. You want to diagnose it before that. And then you have the anxiety syndrome. We see it all of the time. It's usually female. Our compensation seekers. The pain is everywhere. Overactive examination. There is no anatomy or pathology to explain. And usually you end diagnosing fibromyalgia or chronic fatigue syndrome. There are other syndromes like gynecological, which usually it's a sacral pain. You have all the uterus and the tubes and the ovaries, they're all behind the sacrum. So you get sacral pain, you don't get low back pain. In the renal, it's loin pain, it's in colics, and muscular is a diffuse pain. So you have to be very efficient in your diagnosis, time efficient, cost efficient, and you can see there are no overlaps between syndrome. But sometimes the patient has more than one symptom, so you can diagnose two syndromes together. For example, if you have the patient has got a instability and then this instability is pressing on the nerve, so you diagnose which are the symptoms more, the instability symptoms more or the leg symptoms more. And then I will give you with Dr. Muhammad Khattab to present his case.
This is a male patient presented to us with back pain for 8 months. So it is a chronic back pain with occasional right foot burning sensation and sleepless. And he is overreactive to examination with normal range of motion, and the stellate grazing is negative. So there is no tension signs, and there is no true radicular pain, and no sciatica and no weakness. Although the patient MRI can highlight that the presence of degenerated L4-5, L5-S1 lumbar disc with disc protrusion, but the symptomatology is not that compatible with the radiological investigations. Hence, the diagnosis of neuropathic back pain, as we heard from Professor Yosri. And most of these cases are complaining from the back pain, which became chronic, sleep disturbance in 60% of the cases, and the 25% will have mood disturbance as well. And of course, the neuropathic pain has some characters, either spontaneously produced, like spontaneous pain, burning, intermittent shock-like sensation, or dysesthesia, unpleasant sensation, paresthesia, or sometimes it's stimulus evoked like hyperalgesia. Stimulus very minute to cause pain that may cause severe and propagate abnormal pain. Once the patient has such character of neuropathic pain, and you by these symptoms you can diagnose and of course correlate them with the radiological investigations, hence you need to treat them properly. And regarding the pharmacological treatment, there are some recommendations by some pain societies we will highlight in the next slides. The non-pharmacological treatment may be of value, like physiotherapy, pain management programs, acupuncture, or transcutaneous electric nerve stimulations. Regarding the recommendations, we heard from Professor Hawar yesterday a great talk regarding the chronic neuropathic back pain, and he told us there are the first line of medical management go to pregabalins and duloxetine, and the second line is with opioids, tramadols, and of course the rule of non-steroidal anti-inflammatory drugs, the conventional one, is limited in such cases. So my target to treat these patients is to improve the sleep disorder and reduce the anxiety, and this can be achieved by controlling the hyper-excited neurons. And my drug of choice actually is duloxetine, because according to the FDA approval, it is recommended for patients with diabetic neuropathy, fibromyalgia, patients with osteoarthritis, with a common scenario in our cases. According to the FDA as well, it can be taken once daily, unlike the pregabalins, which needs titration. We heard we yesterday from Professor Hawari that we need to start by 150 milligram pregabalins twice a day, and we can increase those up to 1,800 milligram a day. Also, regarding our aging population and the patients with renal impairment, duloxetine is in favor over pregabalins, and the recommendation which is published in 2020 after the era of COVID-19 that FDA warns about serious breathing problems and seizures in patients taking pregabalins due to some of them use opioids as well. So I found duloxetine is my drug of choice. So to sum up, duloxetine is preferred over pregabalins, at least because the risk of abuse is not present there, plus the advantages which is approved in the literature. So my best treatment for this patient is to give him proper pharmacological treatment plus physiotherapy, and of course surgery is not an option at all for such cases. So Dr. Hawari, can you conclude and tell us the take-home message of this session?
So low back pain is no longer a dilemma. You can categorize the symptoms and signs into syndromes. Start with pain relief. You should be cost-effective in diagnosis and the treatment. Bed rest is not an option. You should look for the cause and try to eliminate that cause. And at the end, I think instead of just memorizing the 100 causes of back pain, you are just putting syndromes, the 9 or 10 syndromes, and you just try to fit the patient in any one of them. Thank you very much.
Thank you, Professor Yosri. I think by this take-home message, we end the first webinar. I'd like to thank the whole faculty for their participation and engagement, and I will have only 5 minutes rest, and then we'll go for the next webinar. It will be in collaboration with the AO Spine. It will highlight the cervical spondylotic myelopathy, updated presentations. Thank you so much, dear friends and colleagues. Thank you.
Thank you.
We will use the same link, okay? Thank you.
Elixir Pharma is an Egyptian national shareholding pharmaceutical company which was established in the early 2018. Elixir Pharma is currently managed by Dr. Hani Ali, the CEO who put Elixir Pharma in the rank of the top 100 Egyptian pharmaceutical companies among 800 other companies. Launching Recoxybrite, the current first generic atoricoxib and ranking second in the selective COX-2 market, was just the beginning of success in a long journey yet to be pursued. Because of Recoxybrite, we are currently serving many patients who suffer from chronic pain like osteoarthritis, low back pain, and rheumatoid arthritis, with once daily tablet of Recoxybrite 60 or 90 milligrams. Not only chronic, but also acute pain as acute attacks gouty arthritis, flare attacks, and post-operative acute pain with 120 milligrams once daily for only 7 days. It is a pleasure to have you along the whole journey. The journey of better well-being. Elixir Pharma is an Egyptian national shareholding pharmaceutical company which was established in the early 2018. Elixir Pharma is currently managed by Dr. Hani Ali, the CEO who put Elixir Pharma in the rank of the top 100 Egyptian pharmaceutical companies among 800 other companies. Launching Recoxybrite, the current first generic atoricoxib and ranking second in the selective COX-2 market, was just the beginning of success in a long journey yet to be pursued. Because of Recoxybrite, we are currently serving many patients who suffer from chronic pain like osteoarthritis, low back pain, and rheumatoid arthritis, with once daily tablet of Recoxybrite 60 or 90 milligrams. Not only chronic, but also acute pain as acute attacks gouty arthritis, flare attacks, and post-operative acute pain with 120 milligrams once daily for only 7 days. It is a pleasure to have you along the whole journey. The journey of better well-being. Elixir Pharma is an Egyptian national shareholding pharmaceutical company which was established in the early 2018. Elixir Pharma is currently managed by Dr. Hani Ali, the CEO who put Elixir Pharma in the rank of the top 100 Egyptian pharmaceutical companies among 800 other companies. Launching Recoxybrite, the current first generic atoricoxib and ranking second in the selective COX-2 market, was just the beginning of success in a long journey yet to be pursued. Because of Recoxybrite, we are currently serving many patients who suffer from chronic pain like osteoarthritis, low back pain, and rheumatoid arthritis, with once daily tablet of Recoxybrite 60 or 90 milligrams. Not only chronic, but also acute pain as acute attacks gouty arthritis, flare attacks, and post-operative acute pain with 120 milligrams once daily for only 7 days. It is a pleasure to have you along the whole journey. The journey of better well-being. Elixir Pharma is an Egyptian national shareholding pharmaceutical company which was established in the early 2018. Elixir Pharma is currently managed by Dr. Hani Ali, the CEO who put Elixir Pharma in the rank of the top 100 Egyptian pharmaceutical companies among 800 other companies. Launching Recoxybrite, the current first generic atoricoxib and ranking second in the selective COX-2 market, was just the beginning of success in a long journey yet to be pursued. Because of Recoxybrite, we are currently serving many patients who suffer from chronic pain like osteoarthritis, low back pain, and rheumatoid arthritis, with once daily tablet of Recoxybrite 60 or 90 milligrams. Not only chronic, but also
Hello everybody. Now we'll start the next webinar, webinar 6. So it will be degenerative cervical myelopathy. It is in collaboration with the AO Spine. Our dear friend Dr. Sameh Abou Al-Futuh, the chairperson of the Gulf chapter in the AO Spine, is moderating this session. And of course, our dear great mentor, Professor Al-Hawari, is with us. Dr. Sameh, sorry for the delay, but we are very happy to have you and our dear friends, Dr. Omar Al-Nouri, Dr. Marcus Head, and Dr. Naif with us. So please start introducing your team and highlighting the message of the AO Spine to the attendees in the Aging Spine. Thank you, Dr. Sameh.
Well, thank you very much, Mohammed Khattab, for the invitation. And let me start by congratulating you on running this successful event for the 9th year. It's really a pleasure being with you today. Thank you, Professor Al-Hawari, Mohammed Khattab. It's really a pleasure being with you guys today. As Mohammed said, we'll be talking about degenerative cervical myelopathy, and we're assuming that the majority of our attendees are already senior spine surgeons who are experienced and have a vast experience in spine surgery. So we'll not be spending a lot of time talking about the signs and symptoms of degenerative cervical myelopathy. Instead, we'll be talking about what the literature says now about this devastating pathology. Let me start by introducing my co-presenters here. Dr. Omar El Nouri, he's a consultant orthopedic and spine surgeon at Hamad Medical Corporation in Doha, Qatar. Omar had the majority of his spine training in Boston University in the United States of America, and he's currently the orthopedic educational officer in the GCC Council. The third presenter is Dr. Marcus Head, who is a consultant orthopedics and spine surgeon at Mediclinic Parkview Hospital in Dubai. Marcus has a vast experience in spine surgery, particularly in minimally invasive spine surgery. And last but not least, Dr. Naif bin Dajem. He is a consultant orthopedic spine surgeon in King Fahd Specialty Hospital in Dammam, Saudi Arabia. They've had most of his training in the United States as well in two of the research institutions, which are Johns Hopkins and Mayo Clinic. So let's start with the first question here. Where are we today with cervical myelopathy? Because we know very well that the literature and the evidence has changed significantly over the past 3 to 4 days. And the moment we start thinking about cervical myelopathy as a spinal cord injury that happens in slow motion, that's the moment that we'll understand how devastating this injury is and how devastating the signs and symptoms that the patients can get. Now, the major problem with cervical myelopathy is that whatever you see, signs and symptoms of the patient doesn't necessarily correlate with the underlying pathology. It's usually something bigger that looks in your MRI and on the cellular level in those patients.
When was this condition was first described? In 1838, Clare and Robinson actually were the first one to describe cervical myelopathy as a complication of cervical arthritis. But in 1928, Stocky was described this cervical myelopathy as a caused by cervical tumor, particularly cervical chondromas. Yet it was not really described till 1934 by Bett and Eccles, when they described this cause because of disc studies. Now we know when it was first described. What's the prevalence of cervical myelopathy? Can you please vote for that?
And can you please guess the results of the votes once we're done with the voting? All right. So, as expected, the majority of the attendees have voted for 1 in 50,000. And to be honest with you guys, we used to think exactly the same, because when we review the literature, we'll find that the best estimate for the prevalence of cervical myelopathy is actually 1 in 50,000. Some other papers describe 1 in 500,000. Few other patients describe 1 in 100,000. But that's actually not really accurate, because the current estimation of the prevalence is actually a 1 in 50, not 1 in 50,000. And let me tell you why. If we take a look at this paper that was published recently in the Global Spine Journal in June 2020 by Benjamin Davis and Sam Smith, which are the primary investigators of the degenerative cervical myelopathy group in AO Spine, basically in this paper, they involved individuals who are totally healthy. They didn't have any signs or symptoms of cervical myelopathy, and those population, they underwent a whole spine MRI. What's interesting is that 1/5 of those patients showed radiological signs of spinal cord compression. And we already know from the previous literature is that if you follow patients with spinal cord compression on over years, almost 10% of those patients will develop signs of myelopathy, whether it's thoracic or cervical. And that pushes us to the point that it's actually 1 in 50 patients walking on the planet are estimated to have signs of cervical myelopathy. That's pretty devastating. That's a huge number. Now, despite the fact that it has this high prevalence. It didn't gain that much interest in the literature till the mid-2000s, and that's when AOSPine poured all the resources of research in the organization towards two topics, actually: spinal cord injury and degenerative cervical myelopathy. And that's when we started to notice that there is an increase in the number of papers and the number of literature talking about this devastating pathology.
The pathophysiology behind the cervical myelopathy actually is dependent on multiple factors. As you can see here on the picture on the left side, that there is osteophyte discogenic complex that is compressing the cord and causing localized ischemia over the cord, plus to dynamic instability, which is like the segment is unstable and it will cause axial tension over that area. That's all lead to cellular toxicity in a kind of inflammation and excitotoxicity. And so now we know the pathophysiology about cervical myelopathy, but how to evaluate the severity, how it will guide us in the treatment, what's the option we can give it to our patient. So here's a scoring system which was published in 2007, and it came from Planet Japan, the well-known Japanese Orthopedic Association Cervical Myelopathy Questionnaire, which give us the guide and how to assess the severity of the cervical myelopathy in patient, and it give us a guide how to treat those kind of cases. But always there is a problem with this questionnaire. There was a problem with this scoring system. Can anybody knows, or can anybody types what you think that the cause of this scoring system? Can you type it in the chat box?
So I'm not able to see the chat box, unfortunately, but actually what the problem with the Japanese Orthopedic Association scoring system, the fact that it is coming from Japan, from the Far East, that those were actually the problem with those. It's actually chopsticks. And let me tell you why. Let's take a look at the Japanese Orthopedic Association here, and let's zoom on that upper part of the questionnaire. You will find that the upper extremity function is basically guided based on your ability to be able to use or not to be able to use chopsticks. Now, I learned how to use chopsticks recently over the past few years, and before that didn't make me a cervical myelopathy patient. And that's what pushed Ed Benzel from Cleveland Cleveland Hospital to actually publish the modified Japanese Orthopedic Association score. And let's take a look at the upper part of the upper extremity function over there, and we'll notice that you're basically rated now based on your ability to be able to use spoon or to bottom your shirts like the rest of the word. Now, I've realized that a lot of patients or a lot of surgeons will talk about their MJOA scores, but when you ask them about the contents of the score, most of them wouldn't know the items of the modified JOA. And that's why I would like here to take a few seconds to talk about those items. So the first part we have already talked about, which is the motor function of the upper extremity. Again, it's the ability of using a spoon or bottoming your shirt. And based on that, you get a score from 0 to 5. The second part is the lower extremity motor function, and basically it's on your ability to walk upstairs and downstairs and on steady surfaces, and again, you get a scoring system from 0 to 7. The third part of the questionnaire is your upper extremity sensory function, and the last part of the questionnaire is actually your sphincter dysfunction. And again, you get a scoring system from 0 to 3. The higher the score, the better your condition is. But what's interesting is that it wasn't until 2016 when Mike Fehlings, Alex Vaccaro, and Giuseppe Barbicallo published this paper in the European Spine Journal, which was a prospective study that was done in over 26 sites between AOSPine North America and AOSPine International, and they included more than 750 patients. And only based on that patients, we have categorized Based on that paper, we have categorized patients into normal patients who scored more than 17 on the MJOA, mild from 15 to 17, patients with moderate cervical myelopathy 12 to 14, and the patients with severe cervical myelopathy are those who scored less than 12. Now, the problem with the MJOA is that it doesn't necessarily correlate with your MRI scan. So take a look at the image on the right side here. That's probably one of the nastiest images that we can probably see with a severe cord compression. Yet this patient, when he filled the MJOA score, he scored 17, and that probably makes him in the mild category or even a normal category. On the other hand, when you look at the left side, you'll realize that this is probably a more benign picture with not as severe spinal cord compression as it is on the right side, yet that patient scored 13, which actually places him in the moderate category.
Now we know the pathophysiology, the history, and how to score the cervical myelopathy, but what's the natural history? As we all know, that 2/3 of the patient, they will deteriorate over times and over years, and that's what we are telling our patient. So in the first year, around 6% of the people with the cervical myelopathy, they deteriorate, and around the 10 years after that, more than half of them, they will deteriorate and will have worsen in their symptoms. And that's why the AO conducted a prospective multi-center, North America conducted a prospective multi-center study, and they published it in 2013 in JBJS. And they found the evidence that the surgical decompression, it improved the MJOA score, and it will reduce the neuric disability, neck disability index, and it will improve the SF-36. And this study was conducted at international level over 479 patients, and it was published after 2 years from that in 2015, and they concluded the same. In brief, the neck disability, neuric MJOA, and functional outcome. So there is a paradigm shift in treating those patients. What we used to tell our patient that surgical decompression, it will stop your neurological deterioration. Actually, it is inaccurate, and it's not true. It's improved the neurological function, as we mentioned in previous 2 studies. And that's what will bring us to the current guidelines. So what's the current guidelines for treatment for cervical myelopathy?
This is a systematic review of guidelines based on 5 systematic reviews performed by Global Spine Journal in 2017 by, as you see, the big group, Failings, Wilson, Wang, Danru, and they worked out what to do with the mild, moderate, and severe categories based on all of the numbers. They used multiple studies, and we'll see from the following case series what they recommended. So case number 1 is a 58-year-old man. He's a farmer. He has difficulty with fine dexterity, unable to eat with a spoon, unable to button his shirt, and difficulties with urination. And examination shows altered sensation, both upper and lower limbs, hyperreflexia, bilateral Hoffmans, and an unstable tandem gait. His MJOA is 10. And as you can see on the MRI scan, he has multiple levels of compression with myelomalacia behind C4. So what would everyone do for this patient? Surgery or no surgery? Have your votes. So 83% of you would perform surgery for this patient, and 83% of you would be correct. His MJOA score is less than 12, so he's into the severe category. And there is very strong recommendations and very good evidence that this is the correct plan. There were more than 32 studies performed in this systematic review, and it shows that the MJOA score would improve by about 2 points over 36 months, which means that you'd move from the severe category probably into the moderate category. The NDI and neuric scores would also improve. So case 2.
So this is a 68-year-old female patient who presented with a progressive difficulty with handwriting. She has a history of multiple falls. On examination of significance, she has a reduced grip strength. Bilaterally, she has a bilateral positive Hoffman signs. She has bilateral brisk reflexes, and she is unable to perform a tandem gait. And the MGOA score was 13. So in this case, what would you do for this patient? Would you do surgery or no surgery?
So 76% this time have gone for surgery, so reduced from the 83 from last time. And her score at 13 goes into the moderate category. And the evidence from the Global Spine Journal paper was that surgery would be recommended for moderate category score, with a strong recommendation with moderate evidence. The MGOA scores improve on average by about 2.58 over 3 years for moderate categories. So you can remove them from the moderate group to the mild group.
Here's a case of 3, 47 years old male patient who presented with right hand numbness. And on examination, there is normal motor and sensory, positive Hoffman on the right side, and normal deep tender reflexes. As you can see here from the MRI, there's C5-6 disc herniation and C6-7, which is compressing the cord and the foramina. His MGOA is 17. What do you think was the best option for this patient, surgery or no surgery?
Wow. Well, very interesting. We're very much on an even split here, which would match up very well with what the recommendations actually are, in that really we don't know. The mild category is between 15, 17, and this patient's 17. The quality of evidence for this is very low. The recommendations are weak, and the options are either to try surgical intervention or supervised structured rehabilitation. If this is done, you need to keep a pretty close eye on the patient. And if you get any signs of deterioration, then proceed to surgical interventions.
All right, gentlemen, here's another case for you. That's a 64 years old female patient who has neck pain, bilateral arm pain. She has a steady gait. On examination, she has an altered sensation over distribution of C6 and C7 bilaterally. She has a strength of 4/5 over both biceps and triceps. She is stable with tandem gait, and she has no signs of upper motor neuron lesion. And as you can see on the MRI on the right side, she has severe cord compression with signal changes as well. And the same question for you guys, would you go for surgery or no surgery for this patient?
Interesting that it swung back towards surgery again at 73%. This is a patient with no myelopathy, but radiculopathy. And for this, the quality of evidence is actually low, and the recommendations are pretty weak. We don't actually know. The options are either surgical intervention or supervised trial of structured rehabilitation. But as I say, the literature doesn't give us a very good answer for this at the moment.
So this is like a 47-year-old male patient who is otherwise healthy, has been complaining of neck pain without radicular pain or radiculopathy. On examination, he has a full strength, both upper limbs, intact sensation, and he doesn't have any signs of upper motor neuron manifestations. The images on the sagittal and axial cuts. Would you do surgery or no surgery in this case?
So 75% saying no surgery, which is entirely reasonable for this case. This is a patient who has absolutely no evidence at all. This is no myelopathy, no radiculopathy, but does have radiological cord compression. Whilst the Global Spine team would recommend no prophylactic surgery, but close follow-up and patient education, the quality of evidence is low and the recommendations are weak, but overall would recommend no prophylactic surgery. This was a study done by the spine, AO Spine, where they surveyed 900 spine surgeons who are members of AO Spine to see exactly this last scenario, what a non-myelopathic, non-radiopathic MRI scan would provoke people to do. And interestingly, 67% would perform surgery. Most of them would go anterior for ACDF. And the primary treatment goal was to try and prevent myelopathy, which obviously the evidence doesn't support. So one of our next questions, which of these factors would you consider to be the most predictive of future neurological deterioration in someone with asymptomatic compression? Just to warn you, there is another option down at the bottom of the screen in case you don't see it. So reasonably even split, but the majority going for a spinal cord area of less than 70 square millimeters. Joint second is a compression ratio less than 0.4 and also EMG changes. And the correct answer is actually the EMG changes. This paper by Bidarik and another paper that he wrote in 2011 actually followed patients for 10 years who were asymptomatic to see what would be the most likely to predict future myelopathy. And EMG was the only one that had any positive predictive value at all.
So here's a case 6, a 70 years old male patient, wheelchair bounded. He presented with a severe myelopathy, and he's in all case of chronic obstructive pulmonary disease on steroid. On examination, he has severe neck pain, severe arm pain, and global weakness in both upper and lower limb. As you can see here on the imaging on the right side, MRI and CT scan, that there is a severe compression over the cord and with a cervical deformity and localized cervical kyphosis. I know that most of you will go for operation, but will you correct the deformity at the same time or not? And can you please vote for that?
So a fairly even split, but a small majority would try and correct the deformity. And this matches up with what's in the literature as well. We know that deformity will reduce HRQOL scores and increase disability. And we know that also that if you've got an increase in kyphosis, that sagittal malalignment will increase cord tension, cause cord flattening, and reduce cord perfusion. But we also know that about 34% of normal people will have cervical kyphosis. There is a very low level of evidence that uncorrecting deformities will contribute to adjacent segment degeneration. So it's a difficult choice to make, but overall the guidance is you should try to correct the deformity. So your surgical approach should address the pathology to try and get any correction that's possible.
Now, since we know that the surgery is the way to go now with cervical myelopathy, and that it actually improves your the neurological function of the patient, doesn't just halt the neurological deterioration. So which approach to go for surgery? Is anterior, posterior, a combined approach? Is the fusion, motion preserving surgery? It's really difficult to decide in those patients.
So when it comes to surgical approach, considering every other option has been consumed, and I think Dr. Mercy talked about some of the things I'm going to talk about in my talk. But basically, the major considerations will dictate whether to go anterior, posterior, or preserving motion approaches are the cervical alignment, the number of stenotic levels, the location of the compression, and some other medical conditions like goiter or radiation therapy. But in my opinion, the most important one to consider is to go where the pathology is. Now, the alignment, basically, we're talking about the global, regional, and focal. You have to review the images, all of them, the X-rays and CT scan, as well as the MRI, with meticulous attention, because things can go wrong by missing simple facts that you can see and staring at them. Age is very important, and the expectations of the patient as well, and the implant failures and the surgeon's failure, as well as choosing your patients. Failing published this paper in about 3 years ago, talking about comparing both anterior and posterior to help in decision-making process and trying to get some sense of each one of them. So basically, in this table, you can see the anterior approach and the posterior approach and the options in each one of them, and then the kind of decompression you can obtain from each one of them, whether it's anterior and posterior. The second table was talking about the pros and cons and the potential complications. And I think these are very fundamental to not only the surgeon to know them, but also to discuss with the patient, because all of these could happen to anyone, and they could happen in the best hands of the best surgeons. But to keep everybody on the same page in terms of the surgical team and the patient, these things can happen to anyone, and they should be aware of them. And one of the most important things I would like to stress in these potential complications is the dysphagia or dysphonia, and that will dictate whether what kind of patients you have to choose. For example, if you have a patient who is basically a singer or who's using like the radio or the television broadcasting, you need to be very, very meticulous and discussing this potential complication in that patient, because you probably will ruin his life if you go with the procedure. And in those patients or with those other patients that have had a prior surgery and you need to revise them anteriorly, whether to go from the prior surgical incision or a new one, you need to send them to the ENT surgeon to get some sense of what the vocal cord look like, because some of them might have some asymptomatic unilateral vocal cord paralysis. In the literature was reported between 7 to 21%. And that's basically will give you a lot of sense whether to go from the surgical, prior surgical scar or something else, in addition to get an ENT surgeon to help you with the exposure. But also another thing that I learned is you can get like a recurrent laryngeal nerve probe that will tell you where the nerve is and will dictate how to keep yourself away from that. The other paper was published by the North American AO Spine, and basically it's comparing both anterior and posterior surgical approaches to treat the same pathology we're talking about. And it was a retrospective multi-center study. It was aiming to get what kind of approach is the most optimal. And they recruited about 278 from different sites in North America with a good follow-up up to 87%. The outcomes were measured to get the modified Japanese OA, as well as the NORIC scale, the NDI, and the SF36 scale. So these are the tables comparing both anterior and posterior, with more predominance of the anterior approach compared to the posterior in terms of number. but getting all of the variables in terms of age and gender and smoking history, as well as the other quality of life questionnaires, the improvement was almost the same. And anterior and posterior, there's not much of significant difference after you get the patient factors and the pathology factors controlled. So in a nutshell, in this study, there is no much of difference. They both have equivalent efficacy, whether you go anterior and posterior, if you control the other confounding factors. So if the pathology on the left side is more anterior, so we opted to go with anterior single level ACDF in this patient, but the pathology also can be multiple levels in another patient with a good alignment, and you can always go posterior, and everybody has different approach and different schools to go with it. You're not wrong if you go anterior as well, if you have a good alignment and you have an approachable, reasonable number of levels you can approach, and the magic number, they would say nothing more than 3 levels, but nobody can fault you if you have discussed all of the other considerations I talked about earlier. But the most important thing I would say, you need to consider the alignment, and that's a fundamental concept I would say the patient will gain some benefit from, as well as the satisfactory to the surgeon as well. Now, the other option is to go posterior with a moisture preserving approach. Basically, it's the laminoplasty, and we know there are like 2 basically techniques. You can go the French door technique, which is basically you're doing bilateral unicortical osteotomy or like decortication, but also use the middle line to do a split decompression, and you can put your implant inside, and that will keep the door open in each side. But you need to maintain the inner or the ventral cortex maintained. The other technique, you can use also the open hinge technique or the open door technique. So basically, you open one side by doing laminectomy on that side, where the junction between the lamina and the facet joint, but also you do unicortical on the other side, and you keep the ventral cortex intact because you're aiming to have that side healed, and that's where the healing happens. But also that will help you in keeping the door open on that other side. And then it comes to the argument whether you do the opening door technique where the symptomatic side or not. That's a different thing. But I think from what I've been seeing and trained, you do the open door technique where the symptoms are or where the compression is.
Exactly, Naif. I think another very important point is that if you have it symptomatic equally on both sides, so always try to have your opening side on the non-dominant side. In case you develop a complication like C5 palsy, it's always better to tell the patient that you developed that on the non-dominant side, and try to have your hinging side on the dominant side always.
That's very good, because I think that what makes the surgeons better than others, considering all of these small details, and they will dictate the major significance changes. So basically, after doing the trough preparation and choosing like open or French door technique, then you can use the reconstruction laminoplasty options. For me, I've been trained to do the left side one, which is basically used for the open door technique. A small hint to that is the screw you put on the facet. It has to be in the middle or the upper half, not in the lower side, because you don't want to put it lower half, and then that will penetrate the joint below it. So you just keep it in the middle or the upper half.
The very important trick here is always remember to trim the spinous processes between C3 and C6. Remember, you're elevating those spinous processes more towards the skin. It's very important to trim those to avoid getting pressure ulcers in your skin as well.
Absolutely, I agree. So another thing, which is basically addressed indirectly, but this is a really good paper that I was able to read during my fellowship, was triggered to go after seeing one of my mentors' case. So this is talking about the cervical alignment in the upper, like in the cervical spine, because most of the time we pay more attention to the lumbopelvic or lumbosacral pelvic relationship or correlations. But this paper is addressing the significance of the cervical spine, despite being far away from the center of rotation of the whole body. But this is very important because any simple mistake can get you south easily, and you can go from a normal person to a severely hyperkyphotic or hypolordotic, and that will alter every single reading in the thoracolumbar sacral pelvic alignment or measurement. So the study was talking about, these are not just numbers, as the same applies for the lumbosacral pelvic measures. These numbers, like radiographically found to be really significant, but also has a significant value in terms of having a good outcome for these patients. So I don't think they should be taken for the academic per se, but I think they need to be implemented on a daily basis in real life practice. One of them that I learned, which I will present in the next few slides, is the T1 slope. So so these are like 3 different cadaveric appearances of the cord and how it looks like, if it's like kyphotic deformity on the left side, or if it's like neutral. And you can see the cord is tense on the left side and also in the middle side to some extent, but you'll get it more relaxed and shortened on the kyphotic, reducing or getting the normal appearance of the cervical spine curvature, which is the lordosis. So alignment, I think it's a very important thing to be considered if you decide to go for surgery to address it as long you go. Now, this is a patient in his 50s. He's an accountant, right high dominant. It looks like benign apparent images. So he has some focal kyphosis in his cervical spine. He has like neck pain. He has bilateral radiculopathy in both arms. And you can see about 15 degrees difference between flexion and extension in C5 and C6. The thing that was triggered me and I learned from it is my mentor picked up that the T1 slope is really flat and it's basically 0, which is not normal. But for this patient, it's basically normal, because the taking home message from this, if you have somebody who's like T1 flat or 0, you need to get like a sagittal alignment assessment by having like scoliotic appearances of the whole spine. Because this patient, it looks like benign to you because you have 2 different pathology like of significance impaction on his radiographic and clinical appearances, like C3 and 4 and 5 and 6. And he has like cord changes in each side. But also if you assess each one of these levels by looking at the CT scan as well, they're like an osteophyte. You need to address them intraoperatively. You're not just taking the disc out and putting a graft, because you could do that and anybody can do that. It's like the small details in your surgical plan. By taking all of these small compressive elements, your patient will be happy and you'll be happy. And it doesn't mean you did like a good ACDF, the patient will improve if you didn't take these compressive sites. And I learned from him is if you do a CT scan, you can ask the radiology to get what's called the foraminal view, which is basically like an oblique view of the foramens. And that will show you the whole foramen, how they look like, and if they're like big enough or the osteophyte you need to address, but also tells you how wide the pedicles from each other, the interpedicular size or distance, but also tells you how far the vertebral artery foramen far away from your ancus if you plan to take the ancus out as well. Now this patient, after taking full images, he has a coronal abnormality or scoliosis, but also he has a T1 flat, and he has, if you look into each one of his spine elements, like the cervical, thoracic, lumbar, each one of these curves are like decreased in terms of the normal variant. So this is like a normal variant for this patient per se. The key question in this guy, if you look into only his cervical spine x-rays and you correct him to a lordosis, he's going to compensate above the fusion by another focal kyphosis. So I think that's a fundamental learning point, at least for me, is when you have somebody whose T1 slope is flat, you need to get scoliosis images, but also not to take everybody for granted. So we opted to choose 2-level ACDFs in this patient. You can always argue about doing like 3 levels or doing arthroplasty or whatever, but that's a different talk we could address at some other time. So this is the patient preoperatively and pre and post-op. So on the right side, you can see him preoperatively, he's maintained, and the middle one, his measures almost the same, and he's not hyperlordotic in his cervical spine. His cervical spine is normal for him, and other curves are decreased in each one of them, not like anybody else. So one of the things, I'm sure Dr. Morsi talked about them in details, and I agree with him. This is a really good paper talking about why we have potential complications like the C5 palsy, and they were monitoring this nerve intraoperatively. And they found this incidence of C5 is about 7%, as well as 7% bilaterally. You know, like they try to explain why it comes in most of these decompressive procedures. They were saying that the C5 comes in the midpoint of the decompression distance, and hence it's subjected to the greatest tensile force when the cord shifts posteriorly. But also anatomically, they were saying the C5 itself is really shorter, and it's more acute angle compared to the other nerves. So when you decrease the pressure on the nerve posteriorly, or you change the alignment anteriorly, the nerve, just like the hand, and somebody is pulling you from your hand. So the nerve is subjected to more tensile stretch. And I agree with Dr. Morsi. It was reported to have the incidence of this nerve palsy more with the posterior approach, like decompression and fusion, compared to the anterior approach.
Exactly, Naif, and I think that takes us to switch gears here and talk about the future directions in the research for degenerative cervical myelopathy for this pathology, because surgery is the way to go with cervical myelopathy in the majority of the cases, yet surgery comes with a cost as well, whether it's a C5 nerve palsy or any other complication. And that brings us to a very important study here that actually where almost 50% of the resources of AO Spine dedicated to research in the past 5 years were pushed for that study in particular. That's the riluzole study. So riluzole is a sodium glutamate blocker. That's an FDA-approved medication for the use in amyotrophic lateral sclerosis, ALS. And as Omar talked earlier in the beginning of the presentation, now that we understand that big part of the pathology is an inflammatory process on the cellular level, so we thought that if we use sodium and glutamate blocker, then we're altering that circle and we're preventing the progression of the inflammation and preventing the progression of degenerative cervical myelopathy. Now, take a look at the chart on the right side. You realize that the majority of the patients who got operated, they got an improvement in their MJOA score. Yet there is this percentage of patients those in green who haven't changed in their MJOA score. And there is also a small percentage of patients who actually deteriorated with surgery. And that deterioration was in terms of neurological complications, whether it's a C5 radiculopathy or non-C5 radiculopathy or any other neurological complications like white cord syndrome, for example, or reperfusion injury. So before they conduct that study, they actually conducted the study on rodents and animal models, and they published their results. Mike Fellings and his colleagues published their results in 2015 and 2014, and they came up with a conclusion that riluzole reduces neurological decline after decompression surgery, and that riluzole alleviates the neuropathic pain. So what they did basically is that they conducted a multi-center placebo-controlled double-blinded randomized controlled trials. It has all the fancy names that you can wish for in a trial. It was run in 16 sites across North America from March 2012 to June 2017. It included 300 patients who had moderate to severe degenerative cervical myelopathy. Remember, that was based on the MJOA score results. And the intervention, half of those patients, 150 patients, received riluzole 50 milligrams twice daily for 2 weeks before surgery and 4 weeks after surgery, versus the other 150 patients who received a placebo medication. Their outcomes mainly, they had their primary outcome as the change in the MJOA, while the secondary outcomes were the change in the Nordic grade, neck disability index, SF36, ASIA, grip strength, and visual analog score for the pain. Now, let's take a look at the results, actually. So in this slide, you can see the primary outcome, which is the MJOA. So you can see that all the patients who got operated, they actually got an improvement in their MJOA. Yet, unfortunately, there was no significant difference between the riluzole group and the placebo group. Well, that's a bummer, right? Probably most of us would think, well, the primary outcome wasn't that significant between both groups, but you never live with your primary outcome. Let's take a look at the secondary outcomes here. What about the visual analog scale? So the majority of the patients who got operated in general, they got an improvement in their pain scores in both the neck and the arm scores, yet it was in favor of the patients who received riluzole. And the same thing happened actually with the SF-36. So the patient with the riluzole group, they had a better functional outcome than those who received the placebo. And basically, they concluded from that study that there was no significant change in the primary outcome, which was the MJOA, yet there was a significant benefit of using riluzole over placebo in two of the secondary outcomes, which were the visual analog score and the SF-36. And that actually raises two important questions. The first question, in my opinion, is whether the MJOA is sensitive enough to describe the severity of cervical myelopathy. I would say probably not, yet it's the best scoring system we have so far in the literature for cervical myelopathy. And the other question is, remember those patients received riluzole for 2 weeks preoperatively and 4 weeks postoperatively. So would the results change if we use it for a longer period? Maybe. It's not something that we can estimate, it's something that needs definitely further studies in the future. Now, some of you would probably argue, well, we're not doing those surgeries, we're not using riluzole just to relieve pain. If it's not improving the function of the patient, then what's the point of using riluzole? Well, that's what Benjamin Davis did. So in the BMJ in 2019, he basically distributed a questionnaire on 485 patients who were diagnosed with cervical myelopathy. And he listed all the devastating signs and symptoms of cervical myelopathy and asked them, if you are to take one of those symptoms out of the equation, which one would you take? Interestingly enough, the majority of the patients picked pain as the number one devastating thing that they want to get rid of. They picked pain over walking function, they picked pain over bowel and bladder function, over sexual function. But if you look at the literature over the past decade or so, it's actually not addressing the patient needs. If patients want to get rid of pain and that's the thing that's bothering them mostly, unfortunately, the literature is going in other directions, talking about function, radiology, quality of life, and complications, with very few papers talking about pain.
Do you know how many names exist in the literature describing this condition, cervical myelopathy? Can you please vote for that? So interestingly, like majority of people, they choose 5, but actually the correct answer is 11. There's 11 different names in the literature describing the same pathology. As you know, there is in Asia, most of their cases was OPLL, and they end with a cervical myelopathy. And in other regions, there's different names. And there's no single ICD code like other disease. So in the literature, if you want to search about cervical myelopathy, you have to address all of those names, which you can see it on the right side, and it will cover this area.
That makes it really difficult for us, Omar. If you want to conduct a study on diabetes mellitus, for example, you're just type diabetes mellitus because all the medical community already agrees on the name diabetes mellitus. If you're running a meta-analysis or you want to conduct a literature review on cervical myelopathy, it's really difficult to search when you have all of those, when you don't have an agreement or a consensus of a single name for the pathology.
I agree with you. And that's why AO came with an idea, and they recruited a spine surgeon, family physician, and the patient to have a common name that you can describe it and we can use it in general. And they came out with 2 names, cervical spondylolytic myelopathy and degenerative cervical myelopathy. The first one is difficult for the patient to pronounce, so they agreed to choose degenerative cervical myelopathy as a name of the choice to describe this disease, and we can use it in the future literature. So we advise everyone to use this name for the future literature if you are describing this kind of disease. And they said 10 research priorities for cervical myelopathy for the literature in the future. And they made the first priority is awareness, which is pretty interesting. So it is not what's the best therapy for the patient or what's the best imaging or what's the natural history. It's the awareness of the disease. So you need to educate your physician, patient about the disease, how they diagnose it earlier, so we can interfere at earlier paces and we can change the natural history of the disease and to reduce the social economic impact as a sequelae of cervical myelopathy. It is not, and interestingly, in the literature, more than 60% of the literature, they are not addressing those 10 priorities. They're addressing assessment and monitoring, advanced imaging, which is not the first 10 priorities which was set by AO.
So it's very important here to stop and to pay a tribute to all the team of AO Spine, degenerative cervical myelopathy group, and the spinal cord injury group that's led by the principal investigators, Mark Cutter and Benjamin Davis from Cambridge University, and also the excellent impact by the University of Toronto from AO Spine North America by Mike Fellings and Jeff Wilson. They definitely have changed the game over the past 3 to 4 years. The majority of the literature we know now is coming from the excellent work that this group has done over the past decade or so. So it's very important to mention that. I'd really advise everyone to visit the website myelopathy.org to get to know about the future studies. If you want your center to be included in one of the future studies as well about degenerative cervical myelopathy, it's an excellent group to be involved in. Now, since we're talking about research, let's take a look at this chart. So a disease like multiple sclerosis, which is devastating, I understand, but it has a prevalence of 1 in 50,000. So every 50,000 walking on the planet, only one of them has multiple sclerosis. If you take a look at the amount of money that was poured in research and grant funding for multiple sclerosis over the past decade, it's almost approaching $6 billion. Now, does any of you know how much money was poured into research and grants for degenerative cervical myelopathy over the past decade? If you guys know any of that, can you type it in the chat box, please? Any estimate that you think of? All right. So it's actually pretty embarrassing. It's actually estimated to be $35 million. And that's a disease that has a prevalence of 1 in 50. And that has $35 million, which is pretty low. So we probably need to do a better job funding those grants and doing better literature quality when it comes to this devastating pathology.
Exactly, Sameh, and that's why, because it has a high social impact over the society. As you can see here on the picture, there was a study conducted in the United Kingdom with the myelopathy group, and they estimated the cost of admission, loss of productivity, and the disability payment, and the total loss per year is around £75 million. And the lifetime loss of earning per person is like £500,000, which is like a huge impact on the society and a huge loss. That's why we need more literature and more funding over the to learn more about the disease and how to diagnose it early basis and to interfere on early basis, so we can less the burden on the community and save the people and save money over the society.
And before we leave, let me highlight some few points from the presentation here. Always think of degenerative cervical myelopathy is the commonest cause of spinal cord impairment in modern history. It's not spinal cord injury anymore. It's degenerative cervical myelopathy. And surgery is the way to go. It actually improves your neurological function. It improves the quality of life and is definitely cost effective. And then future directions, we should probably increase the awareness of degenerative cervical myelopathy, optimize the management for those very controversial group with mild degenerative cervical myelopathy, And we definitely need more and more strategies and papers talking about imaging, serological and genetic biomarkers to deal with this devastating pathology. I'd like to thank my fellow presenters for their excellent efforts and the time they dedicated to come up with this presentation for you today. We'll be welcoming your questions after Professor Al-Hawari's presentation. Thank you very much.
Thank you so much, Sameh, for this informative presentation, and with this very nice scenario in presenting the cervical myelopathy. And thanks for the whole team, and thanks for the AO Spine for collaboration with us. So the next speaker will be Professor Al-Hawari, presenting the strategy for managing and preventing osteoporotic fractures.
Hello, everybody. Let's have two different scenarios and see the paradox in these two cases. Case one was a male, age 65, a smoker, had chest pain, unstable angina, and angiography was done, and a stent was put in, and the patient was sent home with instruction to quit smoking and anti-hyperlipidemic drugs. The other case, we see it every day, and a female, 65-year-old, again smoker, had a fall in the kitchen, so it's a low energy trauma, fractured neck of the femur, had the right hip replacement, and was sent home with instruction to have physiotherapy. So what happens to the first physician? We all praised him, and he saved a lot of money for the community and the patient, while the other patient, surgeon, he can easily in Saudi Arabia go to jail. So what's osteoporosis? Osteoporosis is a systemic skeletal disease characterized by two things: low bone mass and loss of the microarchitecture of the bone tissue. So it's not like before, loss of bone mass. No, it's two: loss of bone mass and microarchitecture deterioration of the bone tissue. What does it mean, osteoporosis? It means porous bone, whether in density and quality, both density and quality. So it's called a silent disease because you don't know it except when you have a fall and you break a bone. Osteoporosis can occur both in the cortical bone and the cancellous bone. In the hip, we have more cortical bone than cancellous, and that's why we can get a fracture. And also in the vertebrae, we have more cancellous than cortical, and again, you can get a vertebral fracture. Bone strength reflects the quality of the bone and the bone mineral density. And what affects the bone mineral density, you can easily obtain it by doing a DEXA. But what affects the bone quality, there are many causes: the rate of remodeling, trabecular connectivity, degree of mineralization, damage accumulation, and it's difficult to assess it. You can assess it by the X-ray, CT, or you can assess it by bone markers. Diagnosis of osteoporosis or fragility is really underdiagnosed. We only diagnose less than 2% of patients with osteoporosis, and the treatment is offered to only 36% of diagnosed patients. So we have a huge gap between diagnosis and treatment in these cases of osteoporosis. Prevalence, yes, it's common. 1 in 2 women over the age of 50 has got osteoporosis. and 1 in 5 men over the age of 50 has got osteoporosis. Hip fractures are associated with morbidity, permanent disability, lack of ability to walk, and complete daily activities loss. And they die within 1 year, 20% die within 1 year after the fracture, and 30% will have a permanent disability, 40% are incapable of independent walking, and 80% not able to do their daily activities. So it's a huge morbid disease. So women with prior fracture have an 86% risk to have another fracture. 1 in 5 postmenopausal women with prior vertebral fracture will have a new fracture within 1 year. 45% of women with a hip fracture reports a prior fragility fracture. That means we didn't save this 40% of women from having another fracture. And women with prior fracture have chances 2-4 times to increase another hip fracture. Osteoporotic fracture prevention can be primary by modifying risk factors like smoking, alcohol intake, glucocorticoid intake, giving vitamin D and calcium, and increase awareness, and treat any present osteoporosis. Or you can do it secondary, أضعف الإيمان, by preventing falling, by using the FRAX tool to predict if this patient is going to have a future fracture or not, and to start doing the fracture liaison service. And please don't miss your second chance. If you already missed the first chance, don't miss the second chance. There's a very important booklet. You can download it and print it, give it to your patient, by preventing falls and related fractures, done by the National Institute of Health. So how to prevent falling? There are certain factors which increase the risk of falling, like sarcopenia, which is present in the elderly, unsteadiness. When we get old, we have unsteady gait, medications, eyesight problems, the surroundings of the house, diseases like neurological diseases, cardiovascular, Parkinson, old age and dementia, worn-off canes. All of these are risk factors, and they will accelerate falling. The cause of falling itself could be a loss of footing. If you are standing on a stool or ladder, you can easily fall. Loss of traction: when you walk on wet floor, you can fall. Loss of balance. Urinary tract infection: you have to go to the WC several times at night or during the day, and you increase the incidence of falling. Mental and physical dysfunction, which can happen in the elderly. Changes in reflexes: you're not have the same reflex when you're young. You cannot protect yourself. That's why you can fall and get a fracture. And the polypharmacy, the sedative tranquilizers, the elderly will take. And to get a fracture, you have to have a fracture triangle. You have to have a force to have a fall, and with the force in the direction of the fall, either twisting or direct force, which can produce the fracture. And you should have a soft bone or fragile bone. And by the three sides of the triangle, you get a fracture. What are the consequences of a fall? You can get non-fracture injuries, head injury. You can get skin injury. You lie for a long time till somebody comes and help you. You can get hypothermic. You can get pressure sores. There are post-fall syndromes. We always hear that this gentleman was never the same after the stroke, was never the same after the fall. And there is always a fear of falling, which we call it a precocious parking. You don't want to fall, so you sit early than the chair, and then you get a fall. And then you get reduced mobility. You will be isolated, dependent on the others, which at modern age it's really, you cannot find somebody looking after it. And then you get subsequent falls and fractures, and all of this will increase the amount of cost the community of the patient is paying for that fall. How to prevent falling? By applying indoor safety tips, outdoor safety tips, address the risk factors, treat the causes, balancing exercises, and sometimes you wear a protector like the hip protector, so if you fall, you're protecting the trochanters and you don't get a fracture. You can use a FRAX. FRAX is a fracture risk assessment tool developed by the World Health Organization, and the task force was led by Dr. McCloskey in 2008 to provide a prediction tool for assessing an individual risk factor in order to provide general clinical guidance for treatment decisions. And this is it's not a form you have to print. It's an online calculation tool. You just open, you just have to download the application, and then you put the patient name and age, and you fill in the boxes, and then it will tell you what's the prognosis of this patient getting another fracture. And it has got a national recommendations. If you are living in UK, it's different if you live in Brazil, if you're living in the Middle East. It depends where you live, and then it can give you a different score. There are modifiers for the FRAX. As I said, where do you live? The DEXA, you put into the form, and something called trabecular bone strength. All modern DEXA scans can give you something called the TBS, which is the trabecular bone strength. You don't have to look for it except in the DEXA report. And FRAX will tell you who to treat, but not how to treat. Fracture liaison service. This is a very important service. You have to start it, and it really doesn't need a lot of money to start it. The aim of this fracture liaison service is to prevent the secondary fracture. And as we heard earlier, there is a large gap between the patient diagnosed and the patient treated, and we have to close up this gap. How to make this fracture liaison service? You have to have a stakeholder. You can be the stakeholder, and you have to have a dedicated coordinator to act as a link between the patient, between the orthopedic team, between the osteoporosis team, which can be an endocrinologist, can be a rheumatologist, and you have to and you start a fall prevention service. And all of this linked to the family practitioner. So it doesn't cost much, and you can start it by yourself. Who to treat? You should treat postmenopausal women with hip or vertebral fractures with a T-score less than 2.5% and a T-score of -1 to -2% and a 10-year probability of fracture through the FRAX score. So you need to have a DEXA and you need to have a FRAX score. What are the drugs used for osteoporosis? You can use either to stop destroying the bone or using the anti-resorptives like bisphosphonate, like androgenate, zoledronate, and the ibandronate, or denosumab. Or you can build the bone by using the teriparatide or parathormone analogs. How the DMAP works? There are many ways to kill the osteoclast, and this what the denomap does, and also the bisphonate. And it depends how the way you are killing this osteoclast and the side effects you can get. Denosumab treatment over 3 years reduce the fracture risk, and you can reduce it in the new vertebral fracture by 68%, non-vertebral fracture by 20%. compared to placebo. So it's working. And this trial was extended for another 10 years using denosumab for postmenopausal women with osteoporosis. And the summary of this trial showed that denosumab treatment for up to 10 years was associated with persistent reduction of bone turnover, continued increase in bone mineral density without therapeutic plateau like other bisphosphonate, low incidence of new vertebral and non-vertebral fracture, including the hip. The benefit-risk profile for denosumab in the aging population of postmenopausal women remains favorable. So this was the extended or 10 years trial. So does denosumab versus bisphosphonate in postmenopausal osteoporosis and glucocorticoid-induced osteoporosis act the same? This study was done comparing the DMAP with the zoledronic acid in postmenopausal women with osteoporosis previously treated with oral bisphosphonate, efficacy and safety. And the percentage change from baseline was in favor of the DMAP compared to the zoledronic acid. So another try, DMAP compared with risendronate in glucocorticoid-treated subjects. And the summary was DMAP continued to increase bone mineral density significantly more than risendronate through 24 months. Treatment differences at all treated sites were larger at 24 months and at 12 months. Serious adverse events, including infection and fracture, were similar between both groups. DMAP offers a useful osteoporosis treatment options for patients receiving glucocorticoids. The conclusion was Prolia or DMAP provided a 10-year data of efficiency in the reduction of risk of vertebral and non-vertebral fracture. It also showed in different head-to-head studies superiority over the bisphosphonate, which is taken once a year, the zoledronic acid. DMAP offer a useful osteoporosis treatment options in patients receiving glucocorticoids, and the American College of Endocrinology 2016 guidelines recommending DMAP, among others, as an initial therapy for postmenopausal osteoporosis and glucocorticoid-induced osteoporosis. So how long to treat and the drug holiday? Teriparatide is only limited for 2 years. You cannot use it more than 2 years. Oral bisphosphonate in moderate risk patients, consider a bisphosphonate holiday after 5 years, because you can get atypical fractures, you can get osteonecrosis of the mandibule. And high-risk patients consider a bisphosphonate holiday for 6 to 10 years of stability. So with the zoledronic acid, in moderate risk patients, consider a drug holiday after 3 annual doses. In high-risk patients, consider a drug holiday after 6 annual doses. With DMAP, a drug holiday is not recommended. So you know now when to stop and when to give. There was a recent postmenopausal guidelines done 2002, and it gives the risk of subsequent fracture is highest immediately after the index fracture. The fracture risk assessment is simplified and made clearer, helping sorting patients into distinct categories, whether they are very high, or low risk. Early intervention is warranted in patients with high risk using agent with rapid effect in reducing fracture risk. Individualized treatment strategies and also long treatment strategies are done through this new or updated guidelines. So in a very high risk patient with fracture within the past 12 months, multiple fractures, fracture with while on osteoporosis treatment, fracture while on medication harmful to bone like glucocorticoids, very low T-score less than 3, and fracs probability more than 30% of the hip and the other fractures. All these patients are categorized in very high-risk patients. And then you have the high-risk patients. If the patient in age is above 65, has had a prior fracture in the past 6 months, T-score is less than or equal to 2.5, and T-score -1 to -2.5. And FRAX probability is at 20%. And then you get the low-risk patient if they have the age is menopausal, no prior fracture, T-score is -1, and the FRAX probability less than 20%. So you can now categorize patient into very high risk, and low risk patients. And then you can have the guidelines of management. And again, this is updated 2020, and it will tell you if in a high risk patient, what to give and what to start, and in a low risk patient, what to give and when to stop, and when to have the holiday. So the take-home messages are: we have fragility fracture every 3 seconds. All efforts should be made to prevent a primary fracture. Once a fracture, you have to start osteoporosis treatment. You should prevent the risk and causes of falling. Use FRAX to predict subsequent fracture and choose whom to treat. And there's a huge gap in diagnosis and treatment of osteoporosis. You should now know when and how long to treat. Calcium and vitamin D should be used in all cases. Thank you very much.
Thank you so much, Professor Hawari, for this informative presentation. And now 5 minutes questions and answers. For instance, I cannot find any questions between the attendees written in the questions and answer box. So I'd like to ask our dear friends from the AO Spine side regarding the anterior approach. Some cases present to you with some sort of cord malacia, and even starting to form something like serines. And although you can find this in the cord, you cannot find something hitting the cord from anterior, from the disc in front of that point. So shall you consider that something need to do something like dynamic MRI because of you said in the pathophysiology there is a dynamic factor, not only static factor. So can you comment on that, please?
I think when it comes to that syrinx, you probably need to involve neurosurgery, but I'm not sure if it has an element to the stability or not. I'm not sure about that. If you can help with that, Dr. Marcus or Sameh.
I think it's very important to remember that those patients tend to fall a lot. Like cervical myelopathy, one of the most common symptoms is actually falling and instability with gait. You should also consider always having the element of central cord syndrome in those patients. Those patients tend to have an injury to the cord with any abnormal movement to the spine. You don't even have to have a fall to have an injury to your cord. Even a simple hyperextension injury while sleeping or while getting out of the bed or something like that can get you an injury to the cord. So as Omar said earlier in the presentation, the dynamic element of the pathophysiology of the pathology is very important to consider. It doesn't have to be something that's showing clearly on your MRI. I personally don't do dynamic MRIs in my practice. I'm not sure if it's going to add any benefit in when I'm dealing with those patients particularly. What do you think, Marcus?
I've done a few dynamic MRIs, but evidence is it doesn't actually make a significant difference. It doesn't change what you're going to do. You know, if you've got someone who's got a syrinx, then there's obviously a problem somewhere and you're going to have to address it. So I would probably go anterior for that anyway, but I would speak to my neurosurgical colleagues as well.
Okay, there's a question also to you. How to avoid failure of the posterior neck muscles, often observed after laminoplasty or laminectomy on multi-level, from Dr. Amin Hanin.
Sorry, the question, how to avoid?
To avoid the failure of the posterior neck muscles, often observed after laminoplasty and laminectomy.
So from what I've learned and seen is every layer has to come back to the other layer on the other side. This is a rigid rule in most of the surgeons that I worked with. A lot of surgeons will tag each muscle with non-absorbable suture at least during the approach, and then that will tell you later on when to suture them. But they go layer by layer, literally like any layer, they will bring it back to the next one. There is no way you can have any shortcuts around it. I've seen one of other surgeons using like non-absorbable suture, like the one you use for the rotator cuff repair to get all of these muscles sutured. If they want any failure to happen, they want it to happen for any reason other than the suture itself. So they need something like really solid, doesn't resorb, and get all of the muscles together. And the concept is pretty much clear, is those muscles will like spray if they're not sutured properly, and then instead of being extensor to the head, they will transfer to a flexor if they bypass the pivot point biomechanically.
There is actually a paper that was talking about this, that if you do an MRI for all the patients who are operated for posterior cervical, with a posterior cervical fusion surgery, you probably find some sort of muscle dehiscence at some point on those MRIs. And I remember talking to Dan Rue almost a year ago about this, and his opinion was always use as many Vicryl stitches that you can during that muscle layer. Make sure that you approximate it completely. It's not just about closing your fascia. That muscle layer approximation is very important. Also remember that the most important attachments of your muscles are at the spinous process of C2 and C7. So if you are doing C3 to C6 laminoplasty or cervical fusion, make sure that you don't violate the attachment of the muscles at C2 and C7. Those are the most two important attachments. Any thoughts on that, Omar?
Totally agree with you, Sameh. Meticulous dissection is the key to reduce the muscle pain, and usually that's well known for posterior cervical surgeries, that they will have pain, and that's we can deal with it by meticulous dissection and with the pharmacological treatment in the term of muscle relaxant like diazepam groups.
Last question. Is any one of you recommend the collar for managing these patients, either in the conservative management or putting the patient in collar post-operatively?
I think it doesn't have a rule scientifically based. I think a lot of people will not put them unless the patient is asking for it, or if the patient is not compliant and you know that patient is not compliant. So you give them something objective they can rely on and remind them not to take things lightly and pull things or carry on things. But from what I've seen, if it was given on post-op day 1 for ACDF, it's like a soft collar. And if it's given for the posterior, sometimes they give it for a longer period of time to help the patient adapt to the significant pain they have post-operatively. But when it comes to the outcome, I'm not sure if it has any impaction, to be honest. Because if you trust your fixation, there is no point to have it.
So for me, it really depends on the type of surgery that you operated. If I'm doing a motion-preserving surgery in those patients, I never give a post-operative collar, whether I'm doing a laminoplasty or doing a cervical disc replacement. The whole idea is get them to use their neck, to move their neck. I don't think there is any benefit of adding the collar. I might use it for 48 hours post-operatively just to relieve the soft tissue, not to add any sort of fixation. If I'm doing a posterior cervical fusion, I definitely use a collar. I use it for 3 to 4 weeks post-operatively, just to remind the patients that they don't move their necks much during the first 3 to 4 weeks. With ACDFs, initially where I was taught, they used to use a hard collar for almost 3 to 6 weeks post-operatively. I don't do that in my practice. I tend to use a soft collar for 2 weeks, and then I take it off. And as Naif said, it's just to remind the patient that they had some sort of surgery. It's very important as well, if you have an easy access to your patient and he's gonna come for regular follow-ups, then I wouldn't care much for the collar, to be honest. But in North America, where you operate the patients and they have to drive for 5 to 6 hours to come to your center to do an X-ray or to do a follow-up, I probably feel safer putting those in a collar.
Thank you so much. So we can conclude this collaborative meeting with the AO Spine. Thanks, Marcus. Thanks, Naif, Omar, and Sameh, and the AO Spine, and always keep up. And that is really a great job. And looking forward for further cooperation. Thank you so much. And the last talk actually now will be for Elixir Pharma. Thanks for sponsoring this webinar with Amgen. And the presenter will be Dr. Nada Abu Khashaba. In 5 minutes, will deliver something regarding their non-steroidal product, Recoxypride. Dr. Nada, تفضل.
Okay. Good evening. I'm Dr. Nada Abu Khashaba, Medical Science Liaison at Elixir Pharma. Elixir Pharma is a shareholding Egyptian pharmaceutical company founded or established early of 2018. Elixir Pharma was founded and managed by Dr. Hani Ali as CEO. Elixir Pharma had penetrated the Egyptian market with Recoxypride 60, 90, and finally the 120 milligram. Recoxypride is the first generic in the Egyptian market as Etoycoxib. Our vision and mission is to change the quality of people's lives by reaching the forefront of the Egyptian pharmaceutical market and leading pharmaceutical experts in Africa by introducing a high-quality product to enhance a patient's quality of life. Elixir Pharma is paving toward the future as it ranks number 95 among more than 800 pharmaceutical company just within 1 year. We are talking now about Recoxypride, the first generic in the Egyptian market of a selective COX-2 inhibitor, Etoycoxib, with different concentration to fulfill the needs of the patients as 90 milligram, 60 milligram, finally, the one and only concentration in the Egyptian market of Etoycoxib, 120 milligram. Non-steroidal anti-inflammatory drug classification consists of mainly 4 classes. The first class is the traditional or non-selective COX-2 over COX-1 like diclofenac, indomethacin, ibuprofen, piroxicam, and then naproxen, but with great efficacy, but with great side effects, especially on a GIT. Then the preferential selective as meloxicam, COX-2 inhibitor, selective COX-2 or COXIBs. The first generation is the celecoxib group. Second generation is Etoycoxib group. Finally, analgesic antipyretic with poor anti-inflammatory drug as a paracetamol. Non-steroidal anti-inflammatory drugs, mainly in traditional non-steroidal anti-inflammatory drug or non-selective, inhibit both inducible and physiological prostaglandin, which control pain and inflammation, but at the same time make great problems, especially on GIT and the mucus secretion. Instead, a selective COX-2 inhibitor effect only on inducible prostaglandin, so it controls pain and inflammation without any minimal effect on GIT. What I'm talking about is powered by MEDAL program, multinational Etoycoxib versus diclofenac arthritis long-term study, 2006, published in Lancet Journal 2006, which resulted in that Recoxypride as Etoycoxib 60 and 90 milligram showed tolerability and superior safety on the GI based on POS versus diclofenac 150 milligram. So our take-home message is why Recoxypride? Recoxypride with a great efficacy and minimal side effect for both long-term treatment and short-term treatment, or for chronic pain and also for acute pain. Long-term treatment for chronic pain for osteoarthritis with both concentrations 60 and 90 milligram once daily, rheumatoid arthritis 90 milligram once daily, ankylosing spondylitis 90 milligram once daily, and also for chronic low back pain 60 or 90 milligram once daily. Ricoxabride 90 milligram consists of 3 straps. Each strap contains 10 tablets with 56.5 Egyptian pound. 60 milligram, 2 strips. Each strap contains 10 tablets with 49.25 Egyptian pounds. And finally, the one and only concentration in the Egyptian market, 120 milligram. And that's why it's a strong analgesic effect in managing acute pain. The recommended dose is 120 milligram once daily for just 7 days, and with fast onset of analgesic effect within just 24 minutes. A pack contains just 1 strap, 7 tablets. Its price 46 Egyptian pound. Thank you.
Thank you so much, Dr. Nada, for your support and for your informative talk. And so we can conclude this webinar, and thanks for the all speakers. And we'll have a 10 minutes rest to stretch our legs and drink something. And at 6 p.m. exactly, we'll start the next webinar. It will be covering spinal tumors with our dear friends from Jordan. It will be in collaboration with the Jordan Spine and Pain Management Society. And our great mentor, Dr. Faraz Hussein, will moderate this session with us. Thank you so much, and see you after 10 minutes. Assalamu alaikum wa rahmatullahi wa barakatuh.
سامع صوت صوت unstable internet connection. I don't hear anything. Didn't hear anything. What's the problem?
No one is talking.
They are talking or not?
No.
دكتور محمد خطاب سامعني؟ أنا للأسف مش سامع شيء.
طب شايفنا يا فراس؟
هلا سامعكم. أنا ما قلتش أهلا وسهلا، مساء الخير. في مشكلة بالصوت مش عارف ليش.
في أنت اللابتوب.
كويس أوكي. يا ريت تقرب على السماعة عشان أسمعك. بداية إذا سامعيني كويس ولا لا؟
سامعينك كويس قوي.
And I would like to thank you, the Egyptian Association, for this really steeped activity about aging spine. We are, just enjoying the hot, subjects that we have seen in this activity. I would like, I'm very happy to be with my colleagues, all of you, the mentors of spine surgery. I know you from the history and now. And thank you very much for this activity. Today we will talk about spinal, in general, tumors. Dr. Ibrahim Speh will be with us just a few minutes. He has a technical issue problem, I think, and we have with us, we'll have 3 lectures. The first lecture is with Dr. Ibrahim, but if he will not be with us now, we will go first of all because Dr. Mohammed Al-Fawara with us. So we will start with Dr. Mohammed Al-Fawara. He is a consultant spine orthopedic surgeon. He is qualified by 4 years fellowship from USA in spine surgery and tumors. He is working in the private section also in Jordan and 2 other countries. He will talk today about bone tumors of the spine.
Thank you, Dr. Firas, for this nice introduction. And hello, everybody. Good evening from Amman. I will just start doing my lecture.
Can you share your screen?
Yes, I will in a minute. I'm just looking for the thing.
Excuse me, may I ask if there is any change regarding the schedule? Because I thought at 6 will be my lecture. I'm Dr. Omar Leptouche from Jordan.
أهلا وسهلا دكتور عمر. I'm sorry that we are just changing the schedule and you will be most probably Dr. Ibrahim and then you will have your talk. Okay?
Okay, thank you.
How can we share the screen فراس؟
لا you have اللي تشوف إنه في زر أخضر تحت مكتوب عليه share screen. Just share it.
أيوه. Right. So we have our screen now there.
Yes.
Okay, so we're talking about primary bone tumors of the spine, and I would like just to start my lecture with introducing this case. She's a 24-year-old lady with college students presented to the ER with neck pain, subclavicular pain. I want my guys to talk about it. We will talk about the management later on. I need to think about it. And this is here X-ray. If you see here, there is mild subluxation. And this is here CT scan. You see there's a big destruction in the left side, mainly involving with intraspinal lesion. And this is here also another cut of here CT scan. So this is here MRI. You should have major stenosis at the occipitocervical junction. It's sometimes taking some contrast, and this is here axial images of the MRI. So after throwing this case, and we would like our colleagues to help us in management of this patient, we will start with our agenda. I will start talking about just thinking that probably we think about myths, the incidence of primary bone tumors, how to build our management strategy, what's the presentation, physical examination, about some imaging, and we will just pass through the medical management, surgical management, some staging, and if we have time, we can talk about some primary bone tumors, whether malignant or benign. We need to insist, or we need to emphasize in that most of the tumors of the spine are metastases. So please, when you see a lesion in the spine, please think of metastasis, and the 5 most common tumors that go to the spine is breast, lung, prostate, thyroid, and renal cell carcinoma. And also think about infections because they can mimic the same image. When we are talking about primary bone tumors of the spine, they are usually rare. Incidence about 0.04%. Most of the time, they are usually benign, especially in second, third decade. Posterior elements, most of the time, you think of benign malignant lesions. They usually come in a later age and usually involving the vertebral body. Primary bone sarcomas account for 10% of the all diagnosed sarcomas. We need to build our strategy, and I will show you that. I showed that it is it's called the management pyramid. So you need to build up your management in a complete history, then physical exam, then you may need to do lab, not just to jump to the surgery because you are surgeons. CT scan, MRI will be needed, whether you will do next bone scan or PET scan. And I just want to emphasize that biopsy is an essential issue. Whether ever the lesion was small, large, or big, please consider biopsy because biopsy will direct your management after on. Then you will go either with chemotherapy, surgery, or even you can do nothing, or you can combine radiotherapy and chemotherapy after surgery. So biopsy, you have several types of biopsy. You can do fine needle aspiration. If you have a good cytologist, can read that, or you can do core biopsy, whether you do it yourself as a spine surgeon, or it can be done by our colleagues from the interventional radiology. Medical management, you can pass the patient or you refer the patient to the medical oncology. They can give chemotherapy, which is we have induction and adjuvant chemotherapy. Biopsy, they have several times. You see the open biopsy, you may need it. Sometimes you do curettage in the same session. Sometimes you do marginal excision and block excision or radical excision, which is sometimes not feasible in spine. What are the presentation of primary bone tumors? Most of the time, pain with sometimes neurological dysfunction, bony destruction, neurological deficit, sometimes proximal deformity. Pain is a cardinal symptoms of the bone tumors, and most of the time it is in 85% it will be appear axial or radicular, or it is usually unrelated to the activity. Night pain, what things can make good alert for us, which is persistent night pain and localization, unrelated to the activity. So night pain is a very alert sign to the tumors. Back pain can also, we said it's most common. It should be some alert. Sometimes the patient pain will be resistant, unrelated to the activity, worse during the night. So night pain is very important, and it is not related to the mechanical activity. Neurological symptoms, as we know, it can be presented with upper motor neuron signs of the upper cervical spine, or lower motor neuron, usually in lumbar and something like that, and your colleagues are very experienced in that. Progressive deformity, sometimes the only symptoms of benign bone tumors is progressive deformity, like scoliosis or kyphosis, if there is a big destruction of vertebra. Osteodystoма, most of the time people, they come after pain, they come with progressive deformity, and deformity either because of destruction of the vertebra or because of the muscle spasm or vertebral dysfunction. Age is a very important when you are dealing with benign or with bone tumors, because in young, most of the time it's malignant neuroblastoma, astrocytoma, or sarcomas. In adolescents, the most common lesions come osteoblastoma, osteodystoma, and aneurysmal bone cyst. In elderly age, you're more thinking of chondrosarc, metastasis, and multiple myelomas. And this is just a table showing you, this is a table that which age distribution, but this is not absolute, it's relative. So please, you need to consider any diagnosis, any age, but the most common are more common. Physical examination, most of the time you may find nothing. You may find palpable mass. Sometimes if you do PR exam for the patient, you can feel if there is a chordoma, scoliosis, especially in like osteodystomas, as this picture you can see, because of the paramuscle swam. Sometimes in neurological dysfunction, if the tumor big and destruct the spines and compromising the neuronal canal, then you will find some neurological exam. Just in this case, if you say she has spinal tumor or cervical spinal tumor, you say there's a torticollis in the spine, and if you just considering somewhere here around here, lower ED, you see the swelling there, so she has a big swelling over there when you examine her in a person. What you go next, you will just order, for example, after you finish your history physical exam, you start with the investigation. The simplest is an X-ray. I don't like to skip X-rays in my patient, because sometimes it gives you a big diagnosis instead of waiting for time and time to get an MRI or CT scan. So you need that big destruction of the spine till you see a difference. And if you see here, there is some kind of subluxation, and you see the destruction of the vertebra, then the lesion can be lithic, plastic, or mixed. I mean, the classical winking owl sign, you may see it, but most of the time you can skip it. Most of the time it has destruction of the pedicle and usually in the AP view, and most of the time it has malignant lesion. If you see there is a lytic lesion in this vertebra, just an example, and you see here there is a lytic lesion over there, or in the axial CT you see a lytic lesion, sometimes blastic, especially in renal cellular metastasis, you will see more blastic lesions, and sometimes this is also blastic. You see the whole vertebra is over dense. And this is a key, again, if you see, this is the X-ray, you see lytic lesion over there, and if you see it scan, there is almost no dens. And if you see, if you here with a simple X-ray, you see there is double shadow here with cystic lesion going with aneurysmal bone cyst in a young lady. Location of the tumor is very important for us. Sometimes when it is in the body, you think of metastasis, multiple myelomas, histiocytomas, chordomas, or hemangiomas. When it is in the posterior elements, most of the time it is benign. You think of osteoblastoma or osteodystoma. As we see here, you see this is in the posterior element. It was aneurysmal bone cyst over there. And this is, for example, you see in the anterior where it is metastasis, or you see here it is paraspinal about sarcomas. It's again, we are repeating of ourselves, there's osteosarcoma, or if it is in the body or malignant and benign. You can thinking for body malignant osteosarcoma, eosinophilic granuloma, hemangiomas are benign. The same thing in the posterior element, Ewing sarcoma or aneurysmal bone cyst, osteocytoma or osteochondroma, all of them coming in the posterior lesion. Again, with this diagram, we see that you need to think about if it is osteochondroma and aneurysmal bone cyst coming in the posterior element, also osteodystoма, and the anterior giant cell osteoblasarcoma, eosinophilic granuloma, and aneurysm. So this is geographical distribution of the tumors in the spine, the cross section. Also, about the region of the spine, for example, there is for chordomas coming to the base of the skull or the sacrum. So there's a predilection for some tumors elsewhere. Most of the metastasis coming to the thoracic and lumbar spine. So if you put that in your mind, you may reach your diagnosis easier than. For example, this is a chordoma. You see in the cribing from S2 down, and this is here CT scan and MRI. Sometimes you need to go past to see your lab test. You need general lab. Sometimes calcium level is very important. ESR, liver function, protein electrophoresis, maybe discover multiple myelomas, sometimes tumor markers. Parathyroid hormone is important in spine tumors. Bone scan is a very cardinal sign. Sometimes people, you'll find hot lesion, and this is mean increased activity, except in except in multiple myeloma, usually come in cold lesion. PET scan is more advanced, detect micrometastasis, and it's a very good tool, although it is a lot of radiation and sometimes it's more expensive. CT scan will help you to see the destruction of the vertebra and the exact lesion, sometimes give you the needles. For example, this is osteoma, so when you see this in the CT scan, most likely it is there's a nidus and sclerosis around, and this will be benign when you see that much destruction in the right side picture, which is, you think it's okay, this is more maybe with malignant lesion. Sometimes an MRI is very important. Most of the time we need it with contrast, and if you give you the exact lesion, sometimes give you special characteristics. For you see here, it's in the same young lady before, it is give you your air fluid level, which is coming more with aneurysmal bone cyst. Also the same thing here. So please consider doing your images before biopsy. Special characteristics sometimes available, because if you see for ballooning, chordroid, ballooning is coming with a normal bone cyst, chordroid with hemangiomas, Burkitt is the same, stable calcification with osteochondromas or with osteosarcomas, I mean with chondrosarcomas, and nidus with osteodysteoma and sclerosis. For example, you see this is chordroid here in the X-ray, and polka dots in the CT scan. This is going with hemangiomas, and this is destruction of, sometimes the X-ray give you the quality of the bone, the alignment and stability is very important. This you can change or even plan your surgery or management. You see that there is, when you see this X-ray, there is, the patient has unrelated complaint. She was complaining of scoliosis. They did X-ray of the cervical spine. They find lytic lesion over here, and then the management change they have. This is more urgent to be managed than scoliosis. And I think our colleagues, he went there posterior and get some biopsy, throw some bone graft over here, but this was not the optimal management. So this is 25 years, you see subluxation, and then this is will give you more about the patient. Neck pain, if you see here, special characteristic ballooning, we said before, this is going more with aneurysmal bone cyst or giant cell tumor. And if you go, so if we summarize the X-rays, give you the site, is it in the posterior element, anterior element, or in the body. This is will give you more about the diagnosis. We said that the bone scan is very sensitive to detect the activity, but it is not specific. PET scan can get micrometastasis. An amount of destruction we need us. We already communicated that. You see how this is CT scan. You see how much destruction. You will not appreciate this in the X-ray. And even you see how this is ballooning of the lamina and posterior element. And you see how much destruction over here. This is will come over with the CT scan. MRI will give you exact characteristics of the tumor and the exact compromisation of the neuronal element. So it will give you, maybe you have compromisation of nerves, then your management will be decompression more urgent than giving the diagnosis before. Biopsy, as we said, we can get a fine needle aspiration, maybe with the lab, or you can do it with open or with minimal invasive. Core biopsy under C-arm, you can do it. This is CT scan guided biopsy, or even with the O-arm. I mean, if you have available that, you can get your biopsy and you can get a good amount without major compromisation of patient status. What you said, sir? Open biopsy, sometimes you need it because you think it's the benign tumor or you couldn't get any diagnosis through the minimal invasive, then you can get biopsy. And if you see that the lesion was an aneurysmal bone cyst, so we can get open with it. And at the same time, we did the curettage and we were able to see the anterior or reach the anterior part of the body of the tumor through the posterior approach. And if you see here, I mean, our radiologist, he did stenting to the vertebral artery to keep away from us or to keep seeing it. And then biopsy, as we said, if you have a biopsy, for example, this patient, we have this tumor, we get a biopsy, so with good management. While this patient, it was have small tumors, the surgeon think that, okay, this is small tumor, I will excise it and fix the patient. So this is his management was primary excision and fixation he benefits the patient for just a week. Then after a week, looks how much her tumor coming bad that much with extensive metastasis, extensive recurrence, and the patient was complete paraplegic. So please consider biopsy because that can help you and help your patient. Now, if we jump to the next stage, would be staging. Staging, it's just amount of how amount of disease you have, and this is very good tool to check your survival of the patient and whether he has a lot of diseases or major issues or major metastases. And you have a lot of classification system through the physical exam, X-ray, CT scan, bone scan, and MRI. All that will give you the amount of disease you have. We remember in classification, we have stage 1, which is inactive, or stage 2 is active, like osteoblastoma, or stage 3 aggressive, like giant cell tumor. At the same time, we have Steve Boriani, Munstein Boriani, which is they go counterclockwise, and they divided the vertebra to about 12 sections like the clock, and each one will be staged. Then the depth of the tumor will be also from A, B, C, D. So if it's the extra osseous, we'll be taking A, B will be in the spinous process, and for example, D in the D extra osseous, extradular, E intradular, and if, for example, involving the vertebral artery, and M is metastasis. This is for cervical. The same thing for lumbar or thoracic without the F number because there's no vertebral artery. There's another classification which is Tomita, which is a good one if you can use it. Type 1, which is inside the vertebra. Type 2, more extensive, reach the pedicle. Type 3, reach the pedicle and the lamina. Type 4, extra epidural extension. Type 5, paravertebral, and 6, 2 to 3 levels. And type 7, more than with skip locations. And it also has numbering system to see if there is a slow growing or large or fast growing. There is also Takahashi, which is giving a scoring system about the general condition. This is give you more about the management. And if there is an extra spinal metastasis, a number of extra spinal metastasis to the near terminal organ. So you collect the score. And if the score comes from 0-8, then a survival less than 6 months, from 9 to 11, more than 6 months. If it's 12 to 15, so 1 to 2 years of survival. And this can help you to decide to management or to make or to do or perform a major surgery for your patient. Now, what's the management of our tumors? We can have, after we get the biopsy, we have chemotherapy or surgery or chemotherapy. Sometimes you do chemo, for example, you biopsy, then you do chemo or radiotherapy, then surgery, or then after that, you come back to the chemo with adjuvant. Our level or surgery, we have several levels. We can get a biopsy. We have marginal excision, wide excision, intralesion excision, or radical or palliative, which is just the compromising or debulking of the tumor. Before the surgery, please, before you go to do surgery for a patient, surgery is not a game. So know your pathology, know your abilities, your requirements, your apparatus, your setup inside the hospital you are in. Consider embolization. Sometimes it's a good device in your tool. So you send the patient to the interventionist, he find a major vessel, he block it, then you will save you a lot of blood transfusion, blood loss. You need to know the status of vertebral artery, especially if you are working in the cervical spine. You need to consider your approach, whether you are going anterior, posterior, or combined, and if whether you need to stabilize or not, and whether you are going to cure the patient or just palliative treatment. So please, tumor pathologists depend, then decrease the spreading of the tumor. Why? When we do that, shrink the size, the chemotherapy with the radiotherapy, shrink the tumor and make it easy to do the surgery. You need to think, is this a tumor radiosensitive or chemotherapy sensitive or chemosensitive? Then after that, you may rarely require an open decompression like hematological malignancies. How much time we have? So, for example, like lymphoma, leukemias, they are very sensitive. Small lung cell carcinomas and choriocarcinoma, they are sensitive to chemo. So please consider chemo before doing surgery. So there's a table that determines the radiosensitivity. There is a high, like leukemia, lymphoma, multiple, they are highly sensitive for radiosurgery. Radiosensitive, intermediate, and for example, low, like thyroid or renal, all of that, they are not radiosensitive. Chemosensitive, for example, osteosarcoma, Ewing, and lymphoma. Lymphoma, sometimes you give her steroid, you lose the pathology even. And for only surgery for chondrosarcoma and chordomas. So please know the pathology and know exactly what you are dealing with. This will give you better treatment for your patient. Now, whether to go with radiation therapy or surgery as a primary, this depends on the status of the patient and the diagnosis. For example, if the patient has retropulse with neural compromisation, so we have nerves are priority, so you may start with surgery, or if the tumor is a small enucleated benign tumors, then you can go. For example, this patient has retropulse fragment and it's compromising the nerve, so you can go with primary surgery for decompression and MEF fixation. We said about embolization is very important. Usually there's a big feeder here for the tumor, so it's good to decrease the bleeding, and it needs a good interventional, and sometimes you need intraoperative monitoring. So chemotherapy, most of the time you need it for malignant. Some benign tumors like giant cell tumors can get some chemo, and you need the timing. We have new adjuvant reduction of size and facilitate, and adjuvant, which is doing it after the surgery to decrease the recurrence. For example, you see this is the tumor, how big it was with chemotherapy with the first cycle, and you see this is with the final cycle, almost the tumor is not there. So you save surgery for the patient and you have better prognosis. So surgically indicated for most of the benign tumors, sometimes for biopsy or stability or neurological compromisation, or for surgical excision of the tumor if it is. For example, this patient curettage, it was aneurysmal bone cyst, so we have to curate it and put bone graft, and then you help the patient. Sometimes you need to do anterior and posterior approaches. For example, it was giant cell tumor involving most of the adenoid and the posterior element of C2, so we did anterior and then posterior approach with the graft, and sometimes you have to excise the whole vertebra, so we remove the posterior elements and anterior elements with stabilization, anterior and posterior. Palliative or decompression control sometimes. For example, this is recurrent chondrosarcoma, and he was weak, so we did decompromisation. And if you see, we have just decompression, and we will accept positive margins in that patient. If we come to the individual tumors, we have a big list of benign tumors. We have osteodystroma, osteoblastoma, osteochondroma, hemangiomas, aneurysmal bone cyst, and Langerhans cyst. There is also a list of malignant tumors. If we have time, we can talk about some. So primary benign tumors, they have 78 of them in the first 2 decades of the time, usually uniform distribution from C2 to C7. Neck pain is the most important. Neurological symptoms, not uncommon. So this is aneurysmal bone cyst. If you see here, this is aneurysmal bone cyst. This is giant cell tumor, and there's a big list of them. And if you're talking about benign posterior elements, mainly coming the osteodystroma and osteoblastoma, full body ABCs with granuloma or giant cell can occurring there. And as we said, this is eosinophilic granuloma. It's coming in the body, mainly in the pediatric age. If we're talking about osteodystroma, we remember that from the bone or from the long bone, it has anidas. It's come with sclerosis. Most of the time, the first 2 decades, it's very painful. And it's coming mostly in the lumbar spine, then cervical, then thoracic. And it is the same pathology as osteoblastoma, but the size is bigger. And so that mass effect will be with osteoblastoma more than osteodystroma. It can come in the cervical spine, as you see in this one, or coming, and then the treatment will be excision if it was affecting, and sometimes you just give him a bit of aspirin, it will be healed. For osteochondroma, if you see it is larger and sometimes compromising the nerve, then you need to remove it. The osteochondroma, it can come in the processes of the spine, and mainly it's coming as extra growth of the spine. Sometimes it can come growing inside the spinal canal and show major compromisation. If you see around this patient or this one, it's in the spinal process and you just excise it. This one, you need to do major decompression and maybe fixation. Aneurysmal bone cyst is a very common pediatric population, and sometimes it's very common. You see ballooning of the spine, and most of the time you may need good pathologist to read it or differentiate it between it and a giant cell tumor, and it can be healed by curettage, simple curettage, and bone graft. And this is very cardinal symptom of the MRI of air fluid levels or fluid levels very there. and it is بالMRI multiloculated expansile air fluid levels. Surgery usually recurrence more than 60%, but it is can you use cauterization phenol injectable and will be recurrence this than 14% in a giant cell tumor or by aneurysmal bone cyst. Giant cell tumor, it can also come in any bone. It also can come in the cervical spine. It is ballooning. It is can distract the spine while it is not. There is no air fluid or there is no fluid levels as in sometimes only you can differentiate based on the age and MRI imaging. Sometimes the pathology will be the same. And this is, you see the patient here and intermediate and had derwent excision anterior and posterior of both. Eosinophilic granuloma usually come in lytic lesion with major destruction. Most of the time it can come with vertebral plana, and usually it's young population, less than 5. Actually, I saw 3 to 4 of them. It's coming the age less than 5. It can come as solitary or part of syndrome, like histiocytosis X and shoulder disease. Most of the time when biopsy will enough, they usually treat it with immunotherapy. And this is the MRI. You see more of destruction of the spine. Hemangiomas. Do you say anything? Do you have any time or finished?
You finished the sentence.
Can continue. Just 5. You have only just.
I will just need in 3 more minutes. Okay. So this is hemangioma, is a very benign tumor. You see Burkitt's and Cordroy, but sometimes if it is a fill of blood, it can create some compression. And this is one of my kids was reported. There is a patient come with paraparesis and spastic gait. And it was only had pathology was hemangioma, and we did fixation anterior and posterior for it. And this is just to see how compromisation of the nerves over here, and you see there is the most of the how much compromisation of the neural canal, and this is also destructive lesion of giant cell tumor over there. Or this is I think this is the case we're starting with. Yes, this is a benign, and it was when we did a biopsy, there's only benign lesion. It was sometimes like if the lesion was benign, so we did only medical management, and you see how it is completely healed without any major surgical intervention from the spine wise. Treatment, I said, it depends on the location or side and curettage or something. You need to do primary malignant bone tumors, usually rare and more in females, and usually a neurological compromisation, except chordoma sometimes come with just bulky mass and constipation with pelvic symptoms more than. We have a lot of lesions like chordomas, sarcoma. I saw a lot of Ewing sarcoma and chondrosarc and chordomas. For example, this is treatment is most of the time usually you do either conservative if the patient have major issues, or surgery if there is collapse, pain, or surgery. We're coming back to our case. As we said, it was complete destruction of heat. We did a biopsy actually, and the biopsy came with brown tumor of the spine, and we did just only parathyroidectomy with a surgical excision. And you see, this is here images after 1 year. We accepted some subluxation, and this is here MRI. You see, this is upon the lesion and how fast she even complete the lesion was completely resolved. So, sorry for being long. So take home message, please consider doing history. Pain will be the first alert for spinal tumor. Biopsy is essential in your management. Proper indication for surgery. Proper approach. For example, the approach you do, you can master it, or the approach that's available at your institution. Consider alternative. Please consult medical oncology or radiation oncology. And interventional radiation embolization is good. Ask for help. Sometimes you need the access surgeon, or you need head neck surgeon to help you with the cervical spine, or you need to excise abdomen. You have general surgical oncology. Ask for help, we said, and use extra tools, monitoring, navigation, and please do proper follow-up. It is not any spinal tumor is not like a disc. You excise it and leave the patient. So you need to follow up with the patient, because one of our guys, we get a biopsy and they said this is nothing. It is not a tumor, not infection. We're lucky he came back after 2 months. It was a big destructive lesion. We did again a biopsy and it was lymphoma. And thank you.
Thank you, Dr. Mohammed, for this comprehensive lecture about bone tumors of the spine. So we have question from Dr. Amin. The first question, should we continue to perform mutilating surgeries such as in-block resection for sacral chordomas?
Well, it is. I think, this is a good question, and it is depending on your patient. For example, the chordoma, I show you in my X-ray, in my images, it is very big and involving from S1 down. And it was the major question, is it worth it to make the patient lose his bowel and bladder function and sexual function? And this young guy, his age was 48. So I was hesitating to do that. But if it is distal, for example, distal than S3, I will not hesitate to do it, if it is answering his question.
No, do you mean that, the in-block resection is more successful regarding the recurrence of chordomas?
I think so, yes.
Yes, excellent. And the second question, open surgery or radiofrequency ablation procedure for osteoma?
Well, I think radiofrequency ablation is very successful if you have that in your area. But sometimes we will refer it for them, and they said, okay, it's a spine. For example, if I have, okay, let me reformat my answer. If, for example, the osteoma, it's easy, you can find it very easy in the spine to excise it, while it is very vague field and it is in long bones. So I will not hesitate to take it out if the interventionist will not do it, because I have 3 to 4 cases in Jordan. I referred to the interventionist, he was hesitating to do that. Said I can't compromise the nerve, so we have to do primary excision. So, but I will get the patient the choice of doing it with radiofrequency ablation.
Even the success rate, of radiofrequency ablation is about 90%. What about the open?
Yeah. Well, the open in spine, I think it is, it can be higher than that because it is, you can find it. You have, your level, you can very easily reach the lamina and excise it. It is not like the long bones. The long bones, the success rate of surgery is lower than the radiofrequency.
Thank you, Dr. Mohammed. Any question from the panelists or from our colleagues?
Just a comment, Dr. Firas, regarding the question about chordoma. That currently some colleagues advocate intralesional debulking of chordoma and the carbon beam radiotherapy, and it gives good results instead of this severe radical surgeries, which can affect the urinary and stool control, plus, of course, the sexual function. Thank you so much, and we can move to the next speaker. Thank you, Dr.
Thank you.
Thank you again, Dr. Mohammed. And now the next lecture is about MRI features of malignant versus infectious spinal lesions. Dr. Omar Lubtoush, he is Associate Professor of Radiology of the School of Medicine, University of Jordan, and he has German fellowship in musculoskeletal imaging. Dr. Omar, please.
Yeah, hello everybody. Thank you for the kind invitation. My name is Omar Lubtoush. I'm working in University of Jordan and King Hussein Cancer Center as well. Today I will present a lecture about benign versus malignant vertebral compression fracture. Okay, now first of all, I need to give a short introduction regarding skeletal metastases. So skeletal metastases are common and result in significant morbidity. It could be a straightforward diagnosis based on history of metastatic malignancy. Sometimes they may mimic benign disease or other primary osseous malignancy. It accounts for 2/3 of all malignant bone tumors and seen in a vast number of primary cancers. Most commonly, it can be seen in lung, breast, renal, and prostate as well. So as you can see here, skeletal metastasis, it can present by local pain or even by pathological fracture or mass effect upon the nearby structures. So now we will move to our topic, vertebral compression fracture, benign versus malignant. Differentiation significance, so it's a very different if I would consider a lesion benign versus malignant, so it's important to have such a differentiation for management wise also as well as in prognostic implications. Characteristic imaging features can aid in such a distinction. So our objective is to see the MRI features, MRI and CT features for both entities. So this is it is an example. I will skip the answer, but just as you can see, here we have a vertebral compression fracture at the dorsal spine. I will not mention if it was benign or malignant, and this is another example as well. This another patient. Okay, I will refer back to this question at the end of my lecture. It is just an introduction to our topic. So mainly the etiologies are trauma, osteoporosis, or neoplastic infiltration. Osteoporosis account for 25%, osteoporotic vertebral compression fracture, 25% of all postmenopausal women. Trauma, it's in young patients, it's a common entity. Spine of metastasis is a site of metastasis is in 10 to 15%. To 15% of cancers, and primary tumor also of bone and lymphoproliferative disease such as lymphoma, myeloma, and even leukemia. It can be the site of disease involvement. MRI imaging traditionally has been the technique of choice, even over CT and radiography. In fact, a recently described sequences by MRI scans such as dynamic and diffusion weighted images have also a role in such a differentiation. Before we start, I need to mention this is a very important pitfalls or diagnostic dilemma in our daily work. The first of all is the timing of the fracture. So in acute cases, I mean acute less than 2 weeks, or even in subacute, the benign fracture can have a large area of MRI signal alteration, which can affect our judgment. So this is the first thing. With the chronicity, after more than 3 months, it become small areas of linear signal alteration, and it's easy to have our diagnosis. The other obstacle apart from the acute occurrence is the multiple myeloma, because multiple myeloma, it can diffusely affect the spine. I will give an example to clarify. So this is the normal spine. This is a focal infiltration of multiple myeloma, so it can be easily seen that we have vertebral infiltration. On the other hand, with diffuse myeloma infiltration, it can be problematic for us to say that it has an infiltrative process because of the diffuse pattern. So this is the second obstacle. Now we will move to our criteria, to our imaging criteria. The first criterion, as you can see on this image, we have total or complete loss of the signal abnormality. This is more in keeping with pathological fracture. In fact, pathological refer to malignant process, I mean. On the other hand, in osteoporotic fracture, we have preservation of the bone marrow. So preservation, when compared to other, for example, the above and the below vertebra. So this is hyper intense on T1 weighted images. So the bone marrow signal is preserved. This is the first criteria. As you can see here, we have another example of diffuse signal alteration. So it's more in keeping with malignant process. Second criterion is the abnormal marrow signal involving the posterior elements. In fact, in pathological process, the posterior elements are more prone to be involved And also, even the pathological fracture occurs after posterior element involvement. So if we see, for example, on the upper image, if we see an involvement of the posterior elements, it's more in keeping with pathological fracture. On the other hand, this is osteoporotic fracture because it is spared. Third criterion, it's a logical, which is to see a mass-like epidural or even paravertebral soft tissue enhancement or soft tissue component. So this is more indicative of pathological fracture. But also the problem in acute occurrence of compression fracture, sometimes you can see edema or even hematoma formation surrounding the vertebra. So it is important to have a look at the posterior enhancement, to have a look at the post-contrast enhancement. So if it's diffuse, indicative of soft tissue component, so it's more in keeping with pathological process. So this is the third criterion. Fourth criterion is the posterior convexity. So as you can see here, this is a posterior convexity. It's a very important to mention that the posterior convexity is described that it moves from upward to downward. I mean, it's not only at the end plate, at the upper end plate, because in compression fracture as well, I mean, in osteoporotic compression fracture, we can have a dorsal displacement of the upper end plate. So this is different, totally different from what we are referring to as posterior convexity. Posterior convexity, it's not a focal convexity. It's the whole border of the dorsal vertebral cortex that will be convex. So this is the fourth criterion. Fifth criterion, in general, it's a theory. It's a more theory. It's not very important, but I need to mention it. That thoracic and lumbar spine is more prone to be affected than cervical spine in malignant process, and as well as the lumbar region is more commonly affected than the dorsal spine. So when you move downward, the incidence of malignant process will be more. Sixth criterion is the multiplicity. So typically in favor of benign osteoporotic etiology. However, of course, everybody knows that multifocal metastasis should be also kept in mind. So these are not very important criterion, fifth and sixth. Seventh criterion, it's the whole picture of the patient, the whole picture. For example, presence of other healed benign vertebral compression fracture. So as in this case, we have multiple vertebral compression fracture with the preservation of the bone marrow signal. So if I want to judge on this fracture, I will keep in mind the whole picture of osteoporotic fractures. And I will describe this one as acute occurrence of vertebral compression fracture because we have still osseous edematous changes. Eighth criterion that we have the margin. Ill-defined or infiltrative margins are more likely to be seen in malignant vertebral compression fracture. On the other hand, for example, if we have a well-defined line, so this is more in keeping with benign process. By the way, the linear signal abnormality, it can be due to compacted bone, so it can be due to sclerosis. Also, it can be seen in fluid. So this is, as you can see, this is fluid or even gas. So the well-defined nature of the abnormality more in keeping with benign process. So as you can see here, this is a gas formation in the vertebra. So it is seen in osteoporotic fracture. The ninth criterion here, it's the enhancement. Heterogeneous enhancement is an indicator of malignant vertebral compression fracture. Typically, benign vertebral compression fracture will show an enhancement equivalent to the upper and the lower vertebra, except in acute phase, it can shows an enhancement. But in equivocal cases, it is sometime we will refer or we will recommend short-term follow-up in 2 to 3 months if we have a history of recent trauma. It is worth mentioning here that diffusion-weighted MRI is the technique is based in the ability to measure the change in the mobility of water molecule. So it can be useful, but in fact, it's unclear whether diffusion weighted MRI provide an advantage over the conventional MRI imaging. In our daily work, the conventional MRI imaging is the most accurate modality in diagnosis, but diffusion weighted MRI is helpful because there will be diffusion restriction in malignant process. I will clarify here. For example, what's a diffusion restriction? So in this case, this is the diffusion weighted images. So we don't have bright signal. This is osteoporotic fracture. So we don't have diffusion restriction at all. In the malignant vertebral compression fracture, we have a diffusion restriction. Okay, this is a classical example. Dynamic MRI scan, it represents the contrast uptake versus time. The ability of perfusion parameter to differentiate between benign and malignant process is not convincingly different from that of conventional MRI imaging. So the best imaging sequence is the T1 weighted images. We also we always ask for T1 weighted images without fat sat. So this is our gold standard, and it is the simplest sequence. Now we will move to CT scan. CT feature, it's more frequently found in benign vertebral compression fracture. In fact, some of the features are repetition of what we have already mentioned in MRI scan. So fracture of the anterolateral or posterior cortex of the vertebral body. As you can see here, we have a retrobulged fragment dorsally, as well as we have a ventral fragment. We don't have a destructive changes, only fragments. So this is more in keeping with benign. Retropulsed bone fragment as well. So if we have fracture line within the cancellous bone, so this is, as you can see, a horizontal fracture line, more in keeping with osteoporotic fracture. We have here a diffuse thin paraspinal soft tissue thickening. If we have a bilobed soft tissue thickening, it's more in keeping with malignant. But if it's thin paraspinal stripe or soft tissue thickening, it's more indicative of osteoporotic fracture. So this is another criteria. It's a puzzle sign. Puzzle sign means that we have a sharp fragments, so we can rearrange these fragments together to make the whole picture. So so what we have, in fact, is the burst fracture. We don't have destructive changes. So this is the puzzle sign. So we can return all pieces together to make the whole picture complete. Vacuum phenomena seen in benign vertebral compression fracture, as you can see here, we have already mentioned that. In malignant process, it's very easy. Here we have a destructive process, so we don't have the puzzle sign. For example, we cannot rearrange the fragments because it's already destructed. And also, if we have an epidural or paravertebral soft tissue masses, as in this case as well. So this is more in keeping with malignant vertebral compression fracture. So in summary, multiple criteria can be used in MRI and CT scan to differentiate benign versus malignant vertebral compression fracture. Combining the clinical scenario is important because the timing of the trauma is crucial. And will be more easy for us if the case is not an acute trauma after 2 to 3 months, and if it is an equivocal case, we can refer to short-term follow-up. Signal on T1 weighted images is a specific clue to the malignant infiltrative process. So this is a very important sequence to have a look. It's T1 weighted images without fat cell. At the end, this was our first example, vertebral compression fracture. Here we don't have a change in alteration. We don't have alteration in the signal. Signal is preserved. So this is benign process. On the other hand, we have here a diffuse alteration of the signal, loss of signal on T1 weighted images. So this is more in keeping with pathological process. Thank you so much.
Thank you, Dr. Omar, for this really dedicated and comprehensive lecture about MRI features of the spine imaging. So any questions?
It was actually excellent, informative talk, Dr. Firas. May I ask Dr. Omar regarding what is regarding the PET scan? Do you recommend it in favor of conventional CT scan for such cases, or we shall do CT scan and that's enough?
In fact, I would recommend having the MRI scan first of all, because on MRI scan, the advantage of MRI scan is that we can see the signal alteration compared with CT scan. We don't see only the destructive changes. The destructive changes can be seen on X-ray or CT scan, but on MRI scan we can see destructive changes plus the signal alteration. The signal alteration is the hallmark of differentiation between benign and malignant process. In our case, for example, if we have a small lesions, even if it results in focal depression or focal compression fracture, MRI scan is superior to both modalities.
Okay, just my comment that about spinal tumors in general, that I would like to ask also the panels if they do the same, that tumor surgery in the spine is multidisciplinary approach, and I believe the group of radiologists, pathologists, and spine surgeon, they have to be together for the diagnosis, even for the detailed treatment, surgery, or oncology-wise for the disease itself. So spine surgeon alone cannot treat real spine tumors without the real help from the radiologist and pathologist. I'm calling all the time Dr. Ibrahim Speh, Professor Ibrahim Speh. Unfortunately, and I'm sorry for this inconvenience, he connected his computer with the Zoom in the beginning and his laptop shut down. Until now, he's trying to open his laptop, but till now, I want to call him for the last.
Thank you very much, Firas. I will move to the next speaker, and meanwhile, if you can get Dr. Subeh, then let us know. And I would like to introduce Dr. Rafat Kamal from Alexandria University. Dr. Rafat, are you there?
Yes. Assalamu alaikum.
Alaikum assalam. Dr. Rafat, we woke up this morning على very tragic news. Please send our condolences to our.
Possible.
إن شاء الله يوصل بإذن الله إن شاء الله بقال الله.
Dr. Rafat, please give your talk on updating the management of neuropathic pain.
Assalamu alaikum. Actually, I enjoyed very much the comprehensive review on spinal tumors, but now I will take you to another problem, another subject, which is the neuropathic pain. And you know very well that how do we approach the pain and why we should relieve the pain. The goals of the pain management are always to treat the underlying cause of the pain and to prevent the recurrence of the pain. And this reduction of the pain improves the physical and psychological function and improves the quality of life. But above all, it prevents what we call the central sensitization or the development of the central sensitization of the pain. We know that we have in our practice three types of pain, either the neuropathic pain, the nociceptive pain, or the mixed type of pain, which is the gray zone of pain. So now we have the nociceptive pain, like the pain of osteoarthritis of the knees, and we have the neuropathic pain due to some pathology in the central or peripheral nervous system. And we have the mixed pain, which includes both nociceptive and neuropathic pain. And also we have the central sensitization or dysfunctional pain, when we allow the pain to persist for some time, so the pain becomes dysfunctional or centrally sensitized. We have many differences between the nociceptive pain and the neuropathic pain, but the most important of which is that the nociceptive pain, there is good response to the non-conventional, non-steroidal anti-inflammatory, while in neuropathic pain, there is a very poor response to non-steroidal anti-inflammatory. We should remember all the time that all the cases of chronic low back pain we encounter which means that this sector of patients will never respond to non-steroidal anti-inflammatory. If we comment on this figure here of just disc prolapse, we see that here the nucleus bulbosus is compressing the nerve root, and this causes a neuropathic type of pain. At the same time, the receptors in the annulus fibrosus, which is like the capsule of the joint, develops a somatic or nociceptive type of pain. So actually, this patient is having a mixed type, both neuropathic and the nociceptive type of pain. And if this patient is given or prescribed this patient only non-steroidal, he will never improve or relieve the pain completely. Remembering all the time that the non-steroidal, they are COX-2 sensitive, so they relieve the nociceptive pain, while in the neuropathic pain, the COX-2 insensitive. It doesn't, the mechanism of neuropathic pain doesn't include COX-2, and hence all the non-steroidal, conventional non-steroidal are ineffective. So it is very important to diagnose in our practice, is this patient is having neuropathic or somatic pain or both? The 3L approach, what we call 3L, listen, locate, and look. So first we listen to the description of the patient to the pain. Usually the patient is describing the neuropathic pain as shooting, burning, tingling, itching, numbness, but he will describe the nociceptive pain as aching or throbbing. Also the location, always the somatic pain is in the site of the pathology, while the neuropathic pain can occur away from the site of the pathology, like for example, numbness of the big toe in lumbar disc lesion. And also look, the third L, look, which means that look for any sensory abnormalities. If you have any sensory abnormality like hyperalgesia, hyperesthesia, anesthesia, hypoesthesia, allodynia, all these sensory abnormalities will never be present in somatic pain. Will be present in the neuropathic pain only. This paper actually is a very nice paper in the Pain Physician, published in 2015. Simply, it provides us with the guidelines for the clinical classification of the predominant neuropathic, nociceptive, or central sensation of pain. So if we have this paper, if we have these guidelines, simply we can determine what type of pain the patient is complaining. So this case, for example, is a 45-year-old male who is working as a computer programmer, who is an overweight, is complaining of chronic low back pain with no radiculopathy. So this pain actually is neurologically intact, and this patient pain actually is a mixed type of pain, both neuropathic and somatic or nociceptive. Another patient is 60-year-old lady who has chronic low back pain with neurogenic claudication and progressive decrease in the walking distance. This pain actually is a pure neuropathic type of pain. So this patient will never respond to a conventional non-steroidal anti-inflammatory. Through the history, we start the treatment of neuropathic pain with gabapentin in the 90s, and then we reach to the pregabalin. Now there is the restriction of the pregabalin, and now duloxetine is the most widely prescribed medication for neuropathic pain all over the world. All the societies, including National Institute for Health and Care Excellence and many other societies, they are describing actually the duloxetine as the first remedy for neuropathic pain. Another pharmacotherapy for neuropathic pain in adult systematic review and meta-analysis. Another in the Annals of Internal Medicine systematic review of an American College of Physicians. In 2012, the ACR, American College of Rheumatology, they have been describing duloxetine, and still up till now in 2019, still they are prescribing or advising duloxetine as a first line in the management or relief of neuropathic pain. Also, the Osteoarthritis Research Society International, as you can see here in all the type, you can see that they describe duloxetine in all the types to relieve the pain in all the chronic pain of osteoarthritis of the hands, knees, and hips. Also, International Association for the Study of Pain, still duloxetine is the first choice for the relief of neuropathic pain. So duloxetine is a serotonin and norepinephrine reuptake inhibitor. This group actually is the group of use now. It is indicated FDA approved for the management of chronic musculoskeletal pain, chronic low back pain, and chronic pain osteoarthritis in peripheral diabetic neuropathy and in patients with fibromyalgia. Of course, no drug is 100% safe, but fortunately, the side effects common encountered with duloxetine are very transient, including nausea, which is mild. Term effect on the blood pressure with duloxetine. And if we compare duloxetine with pregabalin, the safety range is to the side of duloxetine. Because duloxetine has no impact on body weight, unlike pregabalin, which induce increase in body weight. Duloxetine doesn't induce edema or peripheral edema, unlike pregabalin. Also, it offers the patients of peripheral painful diabetic neuropathy better quality of life, minimal risk of dizziness and somnolence, unlike pregabalin. Also, it needs no dose adjustment in renal impairment, so it is very safe. And also, it has no risk of abuse or dependence, unlike pregabalin, which we know very well. So to conclude, pain is the main complaint that patients seek medical advice in orthopedic and spine surgery practice. Pain type, neuropathic or nociceptive, should be determined before prescribing a pain relief remedy. Approach should be diagnostic and aiming at both symptomatic relief of pain and the treatment of the underlying pathology if possible. Duloxetine represents a safe and effective line for the management of neuropathic pain. The safety profile of duloxetine is superior to pregabalin as well as gabapentin. And neuropathic pain, low back pain, chronic pain of osteoarthritis, and diabetic neuropathy represent indicators for the use of duloxetine in daily practice. And lastly, combination of more than one drug for neuropathic pain management is possible, but should be resorted to in resistant cases only. Thank you.
Thank you so much, Professor Rafat Kamel, for your excellent presentation, highlighting the importance of managing neuropathic pain pharmacologically. And our condolence to our dear brother, Professor Yasser Alam, for his big loss. Dr. Firas, I cannot see Dr. Ibrahim Subih, so by this nice presentation from Professor Rafat Kamel, we can conclude the session. And thank you so much. Thanks for Jordanian Spine Society for their cooperation. They used to support us in the aging spine and in the scoliosis week as well.
Dr. Ibrahim.
And thank you, Dr. Rafat Kamel, for your presentation and always there supporting us all the time. Thank you so much. And so I think we'll start by 7:30 the next and the final webinar, and it will be in collaboration with Italy and USA. It will be the radiological perspective in managing the aging spine. Thank you so much, and see you after 15 minutes. Thank you so much. Shukran, Dr. Firas.
Dr. Muhammad, on the behalf of Professor Ibrahim and from me, we are sorry for this inconvenience. He called me now and he told me that the computer is not opening. So thank you very much for this very nice session. And
Allah can hear it in the next time, inshallah. Thank you so much. Shukran jazilan. Assalamu alaikum wa rahmatullah. Shukran jazilan. بسم الله الرحمن الرحيم.
Hello, everybody. I'd like to welcome you back in our last session, webinar number 8, and we kept our fruits for the end. This webinar would be coached by our Italian-American group, Professor Luigi Monfrey, Bassem Giorgi, Stefano Marcia, Annan Brooks, and Joshua Hirsch. I'll tell you, they are the best in the business. So let's start. Where's Dr. Bassem? Or Luigi, will you start, Luigi?
Yeah, for sure. I'm ready. Do you hear me?
Yes. Yes,
Great.
we can.
Yeah, so we can share the screen and start immediately.
Can you higher your voice, please? Hi, Bassem.
Hi. Hi. This way is better?
Yes.
Okay. Okay, I'm ready. So thank you so much for this kind invitation. I want to thank personally Professor Alawari and Professor Katab and my friend Bassem Giorgi. I'm Luigi Monfrey, chairperson for spine of the European Society of Neuroradiology. And for the next 20 minutes, we will try to analyze exactly what we can do in case of spinal canal stenosis and spacer. Well, I'll tell you that we have to face with an emergency. An emergency is that we have a world increasing in the population. We started with the Homo erectus, and in 1 million years, we added 1 billion people in the earth. Then in 1 century, we added a 2nd billion. Then in 30 years, we added the 3rd billion. In 15 years, we added the 4th billion. In 13 years, the last billion. They calculated that into 20th century, we started 1.6, and now we are 6 billion people all over the world. And we will be in 2050, we will be 10 billion people. That means that even the spine is a miracle of bioengineering, is not able to adapt to this incredible demographic explosion because it's too fast. And we need a lot of new treatments, easy, fast, and with low impact, particularly because I assume that in the future we will have to face, according to our habits, not with lumbar problem or with cervical problem, particularly because of the new time. Well, I was told when I was young that lumbar spinal canal stenosis was a degenerative disease. It was related to aging. Anyway, my doubt was why old people doesn't have the disease and other people with the same age develop the disease. So probably is not really
Dr. Luigi, sorry for interruption.
Yeah.
You didn't share your screen.
Oh, sorry for that. Wait.
From the green button lower down, you can reset and share the presentation.
Okay, now it should be shared. Do you see my screen?
No.
Okay. Now this one. Okay. And I say share. Now it's okay?
Yes,
excellent.
Okay. So I can, well, I don't want to start obviously, but just to tell you that the pathophysiology of lumbar spinal canal stenosis is honestly difficult to understand because it's not a simple degenerative disease. Recently, even if the pathomechanism of the disease is not completely understood, in December 2020, they found that in ligamentum flavum, there was an incredible amount of amyloid deposits in people suffering from this disease. And medicine just last year published a paper telling us that in people with spinal canal stenosis, there was a dramatic damage, oxidative DNA damage in the ligaments. This was related to the fact that these people got a very low level of catalase. So they got a less level of enzyme that protect us against the oxidative damage. So this is not a degenerative disease. This is a genetic disease that increases when you become old. About the grading, we got 2 grade classification. The most known classification is the one that you see on the right side, that is SCIDSA's classification, very well known. There is a more recent classification according to the position of the root nerves inside the spinal canals, is the Lee classification. Recently, we are trying to classify the spinal canal stenosis with a new kind of imaging, that is, diffusion tensor imaging, according to the fact that the more compact the nerve are inside the spinal canal, the higher level of fractional anisotropy you get on your imaging. Anyway, from a conventional point of view, I do believe that SCIDSA's classification remain the easiest way to classify and to understand which people should be treated and which not. And then the diagnosis. The diagnosis is not easy, like people say, because sometimes there are people that doesn't show the disease simply on a conventional MR imaging. You can have people with a dramatic clinical syndrome, with a dramatic electromyography, and apparently normal MR scan. If you see that man, okay, that man at 9 a.m. was completely normal, and at 9:23 a.m. got a spinal canal stenosis grade D at level L4, L5. What happened in 20 minutes? Simply we changed the way of looking to the spine of our people, because honestly, what we do nowadays are fake examination, CT, MRI. Okay, we study people in supine position. The new machine, the one we got just a few months ago, is the weight-bearing MR scan, and it's probably the more physiological way to study your spine, because you can demonstrate that a simple grade A spinal canal stenosis become a grade D spinal canal stenosis when the people are in the upright position. You can have a spinal canal stenosis in supine position and a listhesis in the upright position. So things change according to the weight bearing. That's why we do prefer to evaluate in a semi-quantitative way the spinal canal in our patient with our machine. And we must admit, even neurosurgical literature says that if you don't examine your patient in the upright position, you miss a lot of patients affected by lumbar spinal canal stenosis. Then the dilemma about treatment. We know that there is obviously the big surgery, the open surgery, but the useful of big surgery is still controversial. There is a great meta-analysis. The biggest one was done in 2018. They analyzed approximately 30,000 patients, so a very big amount of people, and 12% of these people were reoperated in 6 years. So nothing lasts forever, even the great surgery, even the open surgery. That's why we try to be more gentle using the so-called spacers, because we went back to biomechanics. The problem was the bulging of the ligaments. Okay, we put something in between the two spinous process and we flat the ligaments. So we managed to obtain an increase in the space about the interspinous area, an increase in the foraminal space, statistically significant, opening the spinal canal again. That's why we had in the last 10, 20 years, a lot of new surgical interspinous spacer. The fact is that surgical means surgery. That is not a true advantage. If I want to put a spacer surgically away, definitely I have to open the patient, general anesthesia, I can have hematoma, scars. That's why we moved to so-called percutaneous spacer. Percutaneous spacers are fast, easy to introduce. Sometimes they can be a little bit complicated inside, but it's so easy to put a spacer in our patient just in a very few minutes. This is our personal data, because we started to analyze our patient from 2009, and up to now we treated 952 patients. The most of these patients with a one spacer were treated with a single spacer in a single level, some patient with a double spacer, and some patient with a double spacer in the same place. We always analyze the Zurich claudication questionnaire, the OD, the VAS, and our follow-up was 3 and 12 months. We decided to do this treatment in SCIDSA's spinal canal stenosis grade C, D, and sometimes in grade B. we have to face with exclusion criteria. I do love, not the EBM, that is the evidence-based medicine, but the IBM. It is not a computer. It's simply the fact that if you want to do the right people, you have to exclude people without symptoms. No symptoms means no necessary to put a spacer inside. And from a neuroradiological point of view, you cannot put a spacer if you have a spinal canal stenosis that is related to ligaments that are calcified, because I will not be able to stretch the ligaments with a spacer if I have such a kind of situation. We cannot put spacer in scoliosis. I don't put too much spacer. I refuse to put 3 spacers because my fear is to create an excessive kyphotic, so to have a damage from a biomechanical point of view in our spine. And we don't put spacer in case of people that have a spinal canal stenosis unrelated to ligaments, like, for example, in epidural lipomatosis. If we have a people with a tandem spinal canal stenosis, this is a man with a 3 disease: cervical myelopathy for stenosis, meningioma, and lumbar stenosis. Okay, we know that if we treat the lumbar area, the clinical syndrome will dramatically become more and more evident. So we have to treat before people at cervical area if they have a tandem spinal canal stenosis. Obviously, spacers are not without sin. Okay, there is problems. Mainly drawbacks of spacer are: number 1, bone remodeling. We know that spacer reduce the pressure at the level of the facet and at the level of the disc, but they increase dramatically the stress at the level of the spinal processes. They calculated from a biomechanical point of view that approximately 23% of people got bone reabsorption after putting a spacer. And this is the typical result of putting a spacer and having a bone remodeling that is responsible for the failure of your treatment. And the drawbacks, number 2, are fractures. This is a patient where I put a spacer, perfect result on day 1. After 2 weeks, he's back to the square one with the same symptoms, and he got 2 fractures, one above and one below the spacer. What we did was just put 2 needles, injecting the PMMA, casting the spacer with the PMMA, and fixing the fractures. So obviously, considering that preventing in medicine is always better than repairing, from 2011, we decided not to treat people with spacer before without doing a PMMA augmentation of the posterior arch. It's so easy. I mean, it's something that you do in 30 minutes. Then we wait 1 month just to allow the posterior arch to become harder and harder, and then we put a spacer. So in our old guys like this, he got even a fractures of the pedicle. What we do is just to put 2 needles inside, inject the PMMA, and at the end, put the spacer 1 month after. Obviously, you have to remind that when we see white because of the PMMA, it doesn't mean that everything is PMMA. It's like for an aneurysm, okay? You see black, but it's not everything coils. 30% is coil, 70% is hollow space. It's the same in the spongy bone. You inject the PMMA, but it's not all PMMA. That's why we wait for 1 month. And the PMMA is not iron. That means if the patient does an extremely rude physiotherapy, this is what can happen. He can even break the PMMA. So you have to explain to the patient that they are old and they remain old even after the spacer and even after the PMMA. Okay, this is the typical second drawbacks and complication that we can have with spacer. This is a dynamic spinal canal stenosis. You don't see anything on conventional scan. You see the spinal canal stenosis on weight bearing. We put a spacer, everything works. Spacer works always. The problem is that patient doesn't work always, because we recommend to the patient not to move so much. And this old guy decided to do an incredible effort just 1 week after putting the spacer. And this is what happened. The spacer was squeezed off the area that is the space in between the 2 spinal processes. Okay, it's so easy to solve this problem because spacers are, just exactly behind the skin. So be brave. what we did in this patient was putting a second spacer simply because it works, the spacer works perfectly, and then introducing a small cannula. What we did was just with a clammer pinza removing the old one spacer. So solving the situation, we removed the bullet and only a single spacer remain in the patient. And this lasts forever if the patient, is quiet. We have to compare surgery with spacer. So there is a very interesting paper in the literature comparing decompression and fixation, laminectomy, I say all the surgical treatment against spacer, no matter if it's surgical or percutaneous. And it's interesting to see just in Asian Spine 2020 that analyzing 280 papers, they found different complications. Surgery got more surgical complication. That means hematoma, infection, dural tears. Spacer got the typical complication that was the spinous process fractures. They analyzed the operating time. That is important because we are talking about all people. The average operating time was double in surgery. They say that they put spacer in 43 minutes. Honestly, we put spacer on a seated-guided technique. I spent 5 minutes and a half to put a spacer because on a city guide, everything is so easy and so fast. And about the main complication, that is, the average intraoperative blood loss, definitely you cannot compare this surgery with spacer because in surgery there is more blood loss. So the conclusion of this comparison is that there is no difference in clinical results. There are different complications, more blood loss in surgery, fracture on the spacer, but if we put the PMMA, we don't have fractures. We have to understand that we do something that is important from a biomechanical point of view. One of the typical things that you used to say when I started to put spacer was, okay, you put a spacer and you create kyphosis. Well, we got our revenge with this newspaper telling us that it's completely the opposite situation. They find out in Spine 2011 that when we put a spacer, there is an improvement in the sagittal balance, an improvement in sagittal alignment. And this is simply because you reduce, the neurogenic pain, so the posture improves. That's why all the people with a spacer say generally, hey, doctor, I feel taller. I am able to stay more in the upright position, simply because they release from the pain and they are able to be more, balanced in the spine. Then the other question is, how much does it long? It will be forever. The new paper on Journal of Clinical Neuroscience, just in November last year, analyzed a follow-up in 8 years, and they find out that considering the VAS, SODI score, the range of motion, there was efficacy, and the efficacy of spacer was a long-term efficacy, even after 8 years. And there is the adjacent segmental disease where you can use spacer. When you block a patient, you know that one of the most frequent complication is creating a new stenosis. Like in this patient, he got a very old-fashioned, posterior fixation with bone graft, and he developed a new stenosis just at level of L through L3. What we can do in this patient is, number one, extending the posterior fixation, so moving again and probably recreating the condition for a new spinal canal stenosis or putting a spacer. And it's interesting that in the literature, someone is facing the problem of using spacer in a prophylactic way, because when we do a posterior fixation, we can have a new spinal canal stenosis above or below the posterior fixation. And there is a very nice paper just last year, August 2020, that analyzed people with a simple posterior fixation and with a posterior fixation and a spacer, assuming that the spacer create a sort of dynamic transitional zone, so a sort of a shock absorber for the posterior fusion. And it was very interesting to see that people with a spacer and the posterior fixation develop less complication, less adjacent segmental disease in comparison to people with a simple posterior fixation. Pain counts. And when we put a spacer, we have 77% of pain reduction in our patient. They refuse to use drugs. So see, this is very important in mannequins. I was told that health is priceless. Okay, but we live in a real world and healthcare got a cost. In 2009, in the US, they calculated that for lumbar-spinal canal stenosis only, they spent 1.65 billion in Medicare. So it was incredible. And if we compare the amount of money we spend between surgery and spacer, it's almost the same. It's approximately 30,000. If we don't do anything, that it's not for free. When we don't do anything, means that we spend a lot of money in the coming year for new MRI scanning, drugs, physiotherapy, and that's all. So in conclusion, according even to the study that we published on Journal of Neurointerventional Surgery just last year on our single cohort of people treated with spacer, spacer seems to be honestly a very valid for treating people with spinal canal stenosis, particularly if we do spinoplasty before, reducing the drawbacks of spacer. And the future of spacer, well, the future is finding out the right shape of spacer and the right way to put spacer. Because when we put a spacer, we decompress the system, we open a space, if we are lucky, we manage to resolve even the spondylolisthesis, but this is not fixation, and this is not stability. This remain unstable. So what we are looking for is widening the spinal canal and fixating the spine. And from the finite element analysis, we discovered that the right shape of spacer is flat. That's why in Europe, just this month, we will start to use new kind of shape of spacer. They are completely flat. They are, you see, they are squared, not round. And when we put this kind of new spacer, we open two very large wing that attach to the spinous processes, blocking completely the spinous process. So we fix and we open. So we resolve the spinal canal disease and we fix posteriorly the instability. And if you want to join us, I remind you that there is a fellowship from the European Society, our society, and we will do the next European meeting just in Italy, in Catania, at the end of October. I do hope that we will manage to do this in a, not virtual, but normal meeting. Thank you for your attention.
Thank you very much, Luigi. Excellent talk, and you've opened a new era. I thought that the interspinous device is going down, but you've managed to revive it. Thank you very much. And can you proceed with your colleagues, please? Bassem?
Aywa.
Bassem.
Can you guys hear me?
Yes, we can. Very well. Bassem is a dear colleague. He's been one of the founders of the Aging Spine meeting, and we had him in the past 8 meetings. And thank you very much to have you now in the COVID era as a virtual. And Bassem is going to give his talk on adjacent level disease imaging and intervention. Go ahead, Bassem, please.
Okay, can you guys hear me and see the screen? Okay. Yeah. So I would like to thank Dr. Hawari and Dr. Khattab and Dr. Ghamri for inviting me. It's always a pleasure to come to this meeting. And hopefully next year we'll be all together. I would like also to thank my colleagues from Italy, Luigi, Stefano, my colleagues from the East Coast, Alan and Josh, who will join us soon. Thank you guys for helping us and working during your day off. So I am going to talk today about adjacent segment disease, more like of the radiological or from the radiologist stand view, and kind of tell you that there is some interventions that we can do to help you in your managing your patients. We all know that adjacent level disease is very common, up to 27% of the post-operative cases. I'm going to talk about quickly about the biomechanics and pathogenesis. We'll talk about the different imaging findings, and then we'll talk about the non-surgical spinal intervention. I will focus in the lumbar spine because of the time of the talk. So let's start with definitions. So degeneration that develops at the mobile segment above or below the previously operated spinal level is known as adjacent segment pathology. Now, this pathology could be only radiologic changes, and it's called adjacent segment degeneration, or could be radiologic and clinical, and in this case, it's called adjacent segment disease. And obvious that the radiologic findings are more common than having a radiologic and clinical disease also. So the message here is that you can see a radiologic changes, but it doesn't mean that it's always associated with clinical changes. So the pathogenesis is very simple. I'm sure most of you understand it. So the abnormal loading and hypermobility at the junction of the mobile and fused segment is the cause of the development of the adjacent segment pathology. So in normal conditions, you have a long segment of the lumbar spine that moves together in flexion extension. When you cause a small fusion on the lower lumbar spine, you have an abnormal mobile segment above or below the fusion, and this is where you can have pathology. Now, this pathology from the radiologic point of view could represent disc degeneration, ligamentous enfolding, modic changes, facet degeneration, antero or retrorhizisis, and finally, foraminal stenosis and spinal canal stenosis. Abnormal process observed in the adjacent segment. This is what we look for when we read the films. Disc degeneration, either decreased height, signals, or irregularity of the edge of the disc, facet degeneration and lysis, herniated nucleus pulposus, stenosis, osteophytes, scoliosis, and sometimes even vertebral compression fracture. Now, and I'm sure this is well known for the surgeons, that we still don't know that the extent of which the adjacent segment pathology or disease is truly represent stigmata of the surgical intervention or the normal age-associated degeneration, and I don't think we have an answer to that question up till now. So risk factors, preoperative, high BMI, age, osteoporosis, female, pre-existing ASD, sagittal imbalance, pelvic tilt and incidence. Post-operative risk factors, length of the construct, the laminectomy, the insufficient lordosis after the correction, the extensive distraction at the fusion level, and injury of the facet joint adjacent to the surgery. So a very simple case. This is an immediate post-operative case of ALF L45, L5S1. You can see that the disc spaces above are looking very normal. 18 months later, you can start seeing some degenerative changes and a small osteophyte. And 4 years later, you can see more degenerative changes. And this can be picked very easily in a plain film. Compare this to another MR examination, where is the patient actually had an L3, L5 PLEF, but has an adjacent level degenerative changes before the surgery. And 16 months later, there is more degenerative changes, more spinal canal stenosis, but he's not symptomatic. But later on, after 4 years, now he's symptomatic from the advance of the degenerative changes. Another case, this is a young patient that underwent L5S1 laminectomy. You can see the laminectomy defect. And 18 months later, this is a typical case of post-operative adjacent level disease, where you have 2 levels of disc herniation. The patient had laminectomy and there was no fusion. And this what can happen in these cases. compare it to this older woman who had 2-level fusion. You can see in this case all the radiologic manifestation of adjacent level disease, sclerosis, disc irregularities, narrowing, spinal canal stenosis, and facet degeneration, and even SI joint degeneration. So this is a very, of course, well-known subjects for our colleagues, the surgeons. Maybe not some of the radiologists not familiar with it, but you all know the C7 plumb line that extends from the body of C7 down to the posterior superior angle of S1. You can have a positive plumb line, positive sagittal balance, or negative sagittal balance, and it's well known that the adjacent level disease will be associated with abnormal position of the plumb line. We all know the lumbar lordosis angle and the thoracic angle, thoracic kyphotic angle. So let's look at this case. This is a patient who underwent L5S1 fusion and eventually developed L4-5 adjacent level disease with some stenosis of the neural foramen and disc herniation. Patient also have some scoliosis. 4 years later, he underwent a L4-5 fusion, and then he developed another adjacent level disease above the fusion with the spinal canal, with neural foraminal narrowing, and then spinal canal narrowing and facet joint disease. 2 years later, you can see the sagittal imbalance with the plumb line, and also you can see the degenerative changes above the level of the fusion. Eventually, the patient went in and got a corrective surgery to correct the lumbar lordosis. I'm sure all my colleagues in the surgery are familiar with the PI-LL match and mismatch, and basically the pelvic incidence and the lumbar lordosis angle should be within 10 degrees between each other. And this is the sagittal, this is the sacral slope angle, the pelvic tilt angle, and the pelvic incidence angle. So the PI angle and the lumbar lordosis angle should be around 10 degree difference. There is what we call it a matched PI-LL angle, where the difference in around 10 degree, a mismatch when the difference is more than 10 degree, and you can see where there is a less lordosis or almost a flat back syndrome. And it's well known that when you have a mismatch of the PI-LL, you have a 10-fold increase in the risk of the adjacent segment disease. A case from the literature, when you have the pre-op angle is 6, patient underwent L4-5 fusion. 5 years later, the angle is still 4. There is no adjacent level disease. You compare it to this case, where when we started, the mismatch was about 20 degree. Patient underwent surgery. 6 months later, developed another adjacent level disease, and then was corrected with a further fusion above. Another case from the literature, when you have the mismatch about 20 degree, multiple disc herniations, and then corrected with the mismatch now is about 3 degree. Okay, this is one of our cases where there is a patient had a history of fusion at L3-4. It's almost a flat back syndrome, and you can see the sagittal imbalance and a very small lumbar lordosis angle. You know, there is a huge mismatch here. Patient developed the adjacent level disease below the level of the fusion and almost complete spinal canal stenosis. And then later on, he developed a compression fracture at L1. So these are the different types of imaging that we see on the from our side when looking at the adjacent level disease. For prevention and treatment, and this is more of a surgical slide, so most of the surgeons, my understanding, and correct me if I'm wrong, that when you work in those cases, you try to correct the biomechanical profile for a better balance, and you avoid the extensive soft tissue disruption to avoid adjacent level disease. So in terms of intervention, most of these cases will come to us for an epidural injection. When we have a previous surgery, we usually do a caudal epidural steroid injection. We try to avoid the regular interlaminar injection because of the a lot of the scarring and the hardware. There is a higher rate of a dural puncture. So we usually go from the sacral hiatus. I try to put a small angle in my needle and advance the needle into the epidural space from the sacral hiatus. This is a typical lateral view, and you can see the contrast. And the AP view, you can see the dispersion of the contrast into the epidural space. This is, of course, when the patient has a radicular symptoms. This is another case of a caudal ESI. Again, you can see the curve of my needle getting into the sacral hiatus in the lateral view. Patient had surgery and a bone marrow stimulator. You can see the contrast going through the neural foramina. And this is the lateral view, the AP view. And then this patient actually a few years later developed an adjacent segment disease with a disc herniation and underwent further surgery. In terms of transforaminal epidural injection, and this is usually done with when you have a very specific radicular symptoms or a dermatomal type of pain, and we always use a non-particulate steroids. We always use a blunt needle. Please use live fluoroscopy, and always go to the posterior inferior angle of the neural foramen. This is the parasagittal MRI. And this is the neural foramen. This is the nerve root. This is the segmental artery that we don't want to touch, and this is the vein. So we always try to go posterior and inferior. Hopefully you don't hit the vein, which doesn't happen often, but you try to avoid the artery that's up in the upper part of the neural foramen. This is a typical contrast pattern from a transforaminal epidural. You can see the reflux of the contrast into the epidural space from the neural foramen injection. Again, use live fluoroscopy. If you see a vein, you try to readjust your needle. You don't want to see an artery because you can. Then that's one of the reasons that you don't want to have any particulate steroids. We get a lot of cases for facet joint disease, and usually those are above or below the fusion. There is no reason to do any facet injection at the level of the fusion because there is always no median branches, and usually after fusion those facets are fused, so they don't move, and usually they don't contribute to the pain generation. In fact, actually most of the insurance carriers in the United States now will not pay you if you are actually trying to inject a facet joint at the level of the fusion. It has to be above or below. Facet joint, usually axial pain, usually positive facet loading, pain with extension, rotation or bending. The pain usually does not extend below the knee. You can do a direct intra joint injection when you do an oblique view under fluoro, or you can do a median branch block, whereas your needle is at the level of the eye of the Scotty dog. This is a typical facet joint disease that develops after fusion, where you can see a lot of sclerosis below the fusion. You can see it also in the CT examination. And those cases are usually hard to do under fluoro. You can see my needle here because you have to navigate through the hardware and the sclerotic changes of the facet joint. You can proceed with radiofrequency ablation, and you can see this patient had a adjacent level disease above the fusion. We did a median branch block at the level of the fusion, the level just above the fusion and the level above. And you always remember that For the facet joints, each one is supplied by 2 nerves from the same level and the level above. So always 2 medium branch blocks for each level. You can proceed with radiofrequency ablation. And always remember to do sensory and motor stimulation before the radiofrequency ablation. Other intervention techniques will include spinal cord stimulators, pain pumps, or vertebral augmentation. This is a 56-year-old male, had a fusion at L4-5, and then he developed modic changes at L5-S1 few years later. And then he underwent an extension of the fusion for L5-S1. However, he was unlucky. He developed compression fractures at L2 and L3 above the fusion. I end up doing vertebroplasty on those 2 levels. I made sure to use the spine jack to try to maintain the height of the vertebral body. Unfortunately, I was in severe pain and ended up having a spinal cord stimulator placed later on. Last 2 slides about the SI joint. They can happen as a part of the adjacent level disease in the lumbar spine, up to 75% of some literature. Causes of SI joint pain, usually due to the increased mechanical load due to the altered biomechanics, or due to the iliac crest bone grafting, or due to misdiagnosis of SI joint syndrome to start with before surgery. The literature talks about higher PI angle that's associated with a higher risk of SI joint after surgery. Floating fusion, which means non-fused sacrum, is less prone to SI joint compared to fixed fusion when you extend the fusion into the ilium. Management of SI joint, we can do injections, we can do radiofrequency ablation, and some of us are now doing the SI joint fusion, minimally invasive. Remember that you have to make sure that you have at least 3 positive tests of the SI joint provocative tests to prove that this is an SI pain, because most of those tests are not sensitive or specific. When we do the injections, we usually do it in the lower part of the SI joint. I try to avoid injecting contrast, use the volume or the space on the SI joint for injecting the steroid and the lidocaine when I do it. And we can do radiofrequency ablation, either doing each median branch or using the Simplicity probe, where you can put the probe over the SI joint and just ablate all the nerves together. This is how it looks in the AP and the lateral view. Or you can do the iFuse implants that some of us are using now percutaneously. And there is 2 other implants available in the market in the US now. So take-home message, adjacent segment pathology is a controversial, but it's clinically important entity and can affect up to 25% of postoperative lumbar fusion. Pre-existing adjacent segment disease, sagittal malalignment, pelvic incidence, and lumbar lordosis may provide important information for preoperative risk management. Many interventional minimally invasive procedures can help treat patients who are not suitable or who decline further surgical management. And thank you very much.
Thank you so much, Dr. Bassem, for this informative talk, and I'd like to thank Luigi as well. And we can open the discussion for the 2 presentations before continuing for the scheduled program. There is a question from Dr. Amin Hnain to you, Dr. Bassem.
Yes.
Asking about what is the ideal dimension and length and diameter for casters in epidural steroid injections?
I actually use the 21 gauge needle. You can use an 18 or 20, but I usually use 21. If you use an 18, it's a little bit big and you can end up with a CSF leak if you touch the epidural space. 23 and 25, they are very flimsy and they move in your hand easily, especially if you have a scarring. So I usually use the 21 gauge, yeah.
Okay. Regarding, you mentioned that one of the pathology which can be anticipated after fusion is adjacent level fracture.
Yes.
So what about prophylactic cementing the proximal vertebrae?
You know, I don't think we have data about that, but I will be very happy if you're doing any case and you're suspecting fracture, I will do it for you. But I don't think we have data for that. But, you know, remember that, you know, one of the predisposing factors is the old age and osteoporosis. So, you know, by statistics that they will be more prone.
I think, Basim, we lost your voice due to internet connection.
So what I'm saying is, you know, because most of those cases are older in age and osteoporotic, so by statistics, they are more prone for compression fractures. Yeah.
Okay. Dr. Luigi, do you think that interspinous spacers play a role in preventing adjacent level pathology by gradual decrease the stresses over the adjacent level after fusing the segments and apply proximally interspinous spacer, but that way we have transition in stresses between the fused levels and non-fused levels?
Yeah, I think so, honestly, because looking even from a biomechanical point of view, it makes sense. Just to reduce the so viewed change in dynamics between the fixed spine and the normal spine. Putting a spacer, I think that is a very nice idea. Honestly, it's something that we don't do routinely in Europe, but it's something that is, coming in the mind of lots of surgeons to put something that can reduce the stress to the adjacent level. So I think it makes sense, honestly. Even from the literature, they say that it's a nice idea.
Dr. Luigi, actually, from my experience, I got training in Germany with Michael Meyer, and we were developing the N-space in 2006, 2007, and we applied N-space in many cases, and we revised most of these cases, actually. And I can remember that the best indications in their hand at that time was kissing spine, dynamic stenosis in patients with really have no severe stenosis. It is dynamic stenosis that appear after they start to walk or do some exercises. Also, when the patient have grade 1 spondylolisthesis and the segment is lordotic, actually is lordotic, they don't recommend it at all if there is gas sign or if there is evident instability or kyphosis at these motion levels. So I hope you can address this as well in your cases.
Yeah, definitely. I mean, probably the drop down of about the enthusiasm regarding spacer in the literature 5 years ago was related to the fact that a lot of people applied spacer for a lot of different diseases, but spacer play a nice role, but in really selected patients. So exactly like you said, I is not supposed to put spacer if you have a kyphotic man, for example, with spinal canal stenosis. We have to take into account the biomechanics of the spine. Otherwise, we risk to put spacer to everyone, to every people, and it will be a disaster, obviously.
Last question to both speakers, actually from one of the attendees asking about using antibiotics for patients with modic type 1 changes in the MRI, because he thinks that one of the theories is that it is a low-grade infection. Do you have any experience with that? Yes, Dr. Luigi, can you answer?
Yeah, honestly, we don't do injection of antibiotics anymore for MODIC type 1. Simply, when we have MODIC type 1 and we suspect that there is that this is the source of pain, what we do is, number one, we do aspexity just to confirm that the MODIC type 1 is active. And number two, as a treatment, we do prefer to do a basivertebral ablation. So what we do simply is going inside the vertebra, burning the basivertebral nerve, and that's all. So we don't inject anything, but we simply denervate the vertebral body.
Thank you very much for the previous two speakers. And now we shift to our dear friend, Dr. Stefano Marcia from Southern Italy. And he's going to speak on something which I think most of us don't know, what are vertebral implants. So Stefano, could you go ahead, please?
Hi, good afternoon to everybody. It's a really pleasure to see you, and thank you very much for your kind invitation. Let me say cheers to my friend Bassem, Alan, and Josh from the other part of the ocean. And I hope to see all of you in Sardinia in June, crossing the fingers for the COVID, but okay, now I can share my screen. Could you see me now?
Yes. Yes, we can.
The presentation is fine?
Yes, it is.
Perfect. Okay. So here are my disclosures. And we know that the goal of treating vertebral fractures are pain relief, prevention of relief and deformity, and anatomical restoration of the vertebral body. What are the technical options to achieve pain control and high restoration? Current treatments are conservative, bed rest, brace, or traction, mini-invasive, vertebroplasty, kyphoplasty, and intravertebral implant, and surgical, posterior anterior, and combined stabilization. But we know that conservative treatment is still the gold standard for some group, but we know that they have some limitations. High morbidity per bed confined time, lengthy hospitalization time, no reduction effect via ligamentotaxis, and no action on vertebral end plates. Here, an example of T12 vertebral fracture got worse 2 months after treatment with corset brace. And a huge area of osteonecrosis is present in the vertebral body. And recent trials provide new evidence for less invasive procedure in the treatment of vertebral fracture, but was also underlined that conservative therapy is not always risk-free due to many comorbidities. And so why not consider the vertebral disc complex as a normal joint, such as the knee, for example, and apply the AO principles? So anatomic reduction, stable fixation, maintaining of blood supply, and early mobilization. So why augmentation? Because augmentation provides fracture reduction to restore anatomical relationships. Fracture fixation, providing absolute or relative stability as the personality of fracture, patient, and injury requires. Preservation of blood supply to soft tissues and bone, early and safe mobilization of the injured part as a patient, as a whole. So treat the fracture, have a direct action on the biomechanical properties of the spine, and increase the patient quality of life. Many scientific societies wrote the guidelines for the treatment of vertebral fracture. The indication for vertebroplasty are painful, osteoporotic, traumatic, and malignant vertebral fractures. For kyphoplasty, the best indication is traumatic, acute, less than 7-10 days, with local kyphotic angle more than 15 degrees. The rest of indication are similar to vertebroplasty. And why implant? Implants were introduced in order to impede the secondary loss of vertebral body height encountered with kyphoplasty after balloon deflation until cementation. The indication and contraindication are similar to those from kyphoplasty and vertebroplasty. And according to Mager classification, we can treat with vertebroplasty, kyphoplasty, and implanty A1, A2, and A3 fractures. And the applicability of appropriateness criteria using the RAND USCLA method for the choice between neurosurgical management, kyphoplasty, and vertebroplasty was assessed by an international multidisciplinary expert panel. And the use of vertebral implants has been demonstrated to be safe and effective in the treatment of osteoporotic, traumatic, and malignant vertebral fracture, providing better high restoration compared to vertebroplasty and low rate of vascular and disc leakage. And we can perform this procedure under daycare surgery, angiographic guidance, and local anesthesia and deep sedation. The first, one of the first implants put on the market was the Vertelix, produced by the Spinaline Medical Company, indicated, according to the indication from the company, for traumatic fracture Mager A1, A1.1, A1.2, and 1.3 with high-grade osteoporosis. That implant was nitinol-made, that compared to titanium-made, could be possible to close it after its opening, but with no power of expansion, so was no indicated for treatment of traumatic fracture, but was indicated for osteoporotic fracture. Once the implant were deployed inside the vertebral body with bilateral approach, the bone cement could be injected with dedicated bone fillers. And even if some studies demonstrated the efficacy and safety of this device for the treatment of osteoporotic fracture, the device is no more on the market. The VBS is vertebral body stenting, is a balloon expandable stent that can be delivered, can be deployed inside the vertebral body with bilateral approach after the inflection of the two balloons. After that, once the implant is properly positioned, we can introduce the high viscosity bone cement dedicated with dedicated bone fillers. And many studies compare the VBS with balloon kyphoplasty, showing similar results, but with more material-related complication as well. This other study showed increase of number of complications related to materials used during the procedure compared to kyphoplasty. Compared to vertebroplasty, showed improvement in terms of vertebral high restoration of kyphosis and lower cement leakage rate, but the technique of VBS is more demanding compared to kyphoplasty and vertebroplasty. VBS has been demonstrated also to be effective in treatment of traumatic vertebral compression fractures in young non-osteoporotic patients, facilitating vertebral high restoration. The OsteoFix was an intravertebral mesh positioned with a bilateral approach. According to the indication of the company was Alphatec Scientics, it could be deployed with or without the injection of the bone cement. Personally, I always used it with the injection, combined with injection of the bone cement in order to have immediate pain relief. The OsteoFix is no more on the market as well. The Kiva. The Kiva is a nitinol coil that can be positioned inside the vertebral body. It's a peak polymer case that can be positioned inside of the vertebral body through the introduction of unilateral, unipedicular nitinol coil, and once the nitinol coil is in place, the polymer cage can be introduced over the nitinol coil. Then the nitinol coil can be get out, and we can inject the bone cement inside the cage. And the kiva is indicated especially for traumatic vertebral fracture, according that paper, but also is useful in treatment of osteolytic metastasis. The vessel plasty is a mesh which allows the interdigitation of the bone cement within the bone trabecula, and it can be introduced like a balloon kyphoplasty with unilateral or bilateral approach, has no power of expansion, so not indicated to provide high restoration, but can be helpful in reducing the leakage, especially in osteoporotic vertebral fracture or in osteolytic bone metastasis, like assessed in that paper for osteoporotic fracture, or osteolytic vertebral fracture, like in that paper was demonstrated. Similar to the vesoplasty is the soteira, also called shield kyphoplasty, that has been demonstrated to be effective in reducing posterior cement leakage, reducing the risk of leakage-related complication. Compared to vertebroplasty and kyphoplasty, the soteira demonstrated efficacy in reducing leakage, but since is more expensive, vertebroplasty could be considered the surgical procedure of choice, according to that paper. The Tectona is not exactly an implant, because after its expansion, the Tectona can be removed from the vertebral body, but we can turn the pistol 360 degrees in order to provide an internal bump and to get the restoration in the direction in the needed direction. After the high restoration, we can inject the high viscosity bone cement with dedicated bone fillers. This is the final results assessed by CT check after the procedure, and that paper demonstrated the efficacy of the Tectona system in treatment of osteoporotic and traumatic fractures. Similar to the Tectona is a vertex jacked with an expansion of right lamella. The Tectonic skirt, the vertex jacked is right, and that preliminary study comparison to kyphoplasty show advantage in terms of targeted and more gentle application and better pain relief in 6 months follow-up. And finally, the spine jack, the mechanism of action of that device is to apply a force opposite to that which caused the fracture. And the difference from the other vertebral augmentation system, for example, is kyphoplasty, that the application of the force is a craniocaudal instead of spherical force like we have in balloon kyphoplasty. And the procedure is quite similar to kyphoplasty, the bilateral approach, but in that device we have to introduce the two working cannula as parallel as possible to the end plates due to the craniocaudal expansion of the titanium implant. Once we are in the correct position, we can open the two implants, and after that to inject the bone, the high viscosity bone cement. And this is the final result compared to assessed by the 3D reconstruction. The spine jack allowed to treat some extreme fracture, like that case, 50 years old male, a 3.3 fracture L1 traumatic. And the patient refused the surgery, and we treat the patient under daycare surgery, local anesthesia, deep sedation, and we provide a good high restoration. This is the final result, but we had especially a very good clinical result because the patient went back in the afternoon and went back to daily activities the day after. And another interesting case is that one is a 73-year-old lady, A1.3 T7 osteoporotic, but it's important to note retropulsion of the posterior wall with some involvement of the spinal cord, asymptomatic, but with the spine jack, we had a very good results with ligamentotaxis. We had a reduction of the posterior retropulsion. In that case, we performed prophylactic vertebroplasty as well due to the T score and due to the kyphotic angle. And many studies compared the kyphoplasty with the spine jack, providing similar clinical outcomes, but the spine jack was demonstrated to provide high restoration and to maintain the high restoration over time. The spine jack was also demonstrated to be effective in the prevention of the disc degeneration, maintaining a good normal signal of the intervertebral disc. This study concluded that the spine jack is the only device suitable for the treatment of vertebral fracture due to osteoporosis, trauma, and bone tumors, with comparison to kyphoplasty, vertebral body stenting, and the osteofix. But the only one trial in literature is the SACUS study, where the balloon kyphoplasty was compared to the spine jack. 13 European centers, 141 patients, and both devices provide good results, but the spine jack provide better results in VIS score at 6 months, in middle high restoration, and in lower adjacent fracture rate as assessed in the conclusion. This is my personal flow chart. We can treat with all that device, vertebroplasty, kyphoplasty, VBS, spine jack, and tectonody. A2 vertebroplasty indicated for kyphoplasty, and not indicated because there is a posterior push for the spherical force. Tectona in some case, VBS spine jack indicated. A3 fracture, only the spine jack. Thank you very much for your attention. I remind and invite all of you, crossing the fingers, to Gribois Sardinia Spine next June in our wonderful Sardinia. At the moment, the Congress is planned. I hope I can keep the promise. Thank you. Thanks again.
Thank you so much, Dr. Stefano. It was a great lecture. Thank you very much. And actually, we have a lot of questions now. We have a question from Dr. Huzaifa. Do you prefer the parallel or conical implants?
I prefer, sorry then?
Do you prefer the conical or parallel implants?
Maybe I don't understand you.
Stefano, I think he may mean the ones that look like a conical, like a balloon shape.
Okay. Sorry. Sorry, my English. my English. Forgive me. No, I personally. Because the spine jack is good for different options, and unless in Europe the costs are similar to to kyphoplasty and the other kind of device. So unless I need to use smaller introduction needle, and I can have, for example, 10 gauge compared to 8 gauge of the spine jack in the Kit Express, in the balloon kyphoplasty Express, for example, T6 or T7. So in some case, I can I could need some smaller introducing needle. Usually, I prefer to use the spine jack.
Okay, there's another question from the same doctor. Does anybody have experience with barricade device for closure of an annular defect in disc herniation surgery? Do you know the barricade device?
No, personally not.
Oh, don't think so. Okay. There's another question from the Ahmed Zar. Was the material examined for the amount of loads that can bear in vivo, because it may fail?
No, I didn't feel any difference in the material except for the power of expansion. I never saw any allergy or contraindication.
Stefano, I think maybe they're asking a different question, but it could be my English that's the problem. I think what they're asking is, when you add the metal, do you think that changes the load-bearing ability over time compared to cement alone? And what the people may not realize is that the cement is generally put together with the implant. So it's a strengthening likely of the implant, not a diminution in strength. But I think that's the question. If you add metal, you add metal, I'm guessing, I don't know, but I think
this is the question.
Do you think the load?
Personally, I didn't note any difference in ejection fracture or the biomechanical change in my personal experience. I think that the metal can be helpful in reducing the strengthness compared to the bone cement, but it's my personal opinion.
And another thing to point out, Stefano, I don't think I've seen any reports of any complicated implant breaking over time. Any follow-up reports? Has anybody? Have you? Yeah.
I didn't have nothing.
I've not seen anything in the literature about that.
Okay, let's move.
Good afternoon to everyone.
Gamal, yes, please.
I'll take first of all the opportunity to greet my colleagues and friends from Italy and the US.
Hi, Gamal.
God, hopefully we can meet in person next year. Now, I have a question to the panel and to the speaker, and maybe each one of you can elaborate. Where do we stand now in terms of prophylaxis for the adjacent levels? Now we have been doing vertebroplasty like for the last 15, 20 years. And it's one of the initial questions that remains present. Where do we stand after having accumulated? Probably we have in this room more experience than anywhere else in any meeting in terms of vertebroplasty, kyphoplasty. So where do we stand now in terms of prophylaxis?
Because Boston is in between Italy, New York, and the West Coast, I'll get started.
Yes.
I think you will get very different. I think you will have very different answers. Our European friends have a very low threshold to do prophylactic augmentation. Stefano even showed a case. I know from lectures, Luigi and Stefano do it commonly. In the United States, because of the way It is reimbursed by Medicare. It is very, very actively discouraged to do prophylactic. And if you do prophylactic, you better not make a mistake and accidentally bill for it. So sometimes people do it, but it's much, much more judicious because you could actually find yourself in a little bit of trouble because it is not accepted here. Alan and Bassem, do you agree with that statement about in the United States now, with the current materials, prophylactic vertebroplasty is uncommon?
So I totally agree with
you will not get paid for it anyway. So nobody does it.
One area where you can consider prophylactic is actually in cancer. We have a large lytic lesion that they may radiate, even though it may not be very painful. So those are some areas that are coming down the line that we'll be able to do, not because of pain, but more for stability.
So let me just, before we throw it to our European colleagues, I wouldn't have included that as prophylactic, meaning treating a large lytic lesion is itself an indication. By prophylactic, what I was responding to on behalf of the United States was the fact that if you have a normal appearing vertebrae, for example, between two fractures, I would not treat that. I would not consider treatment of a dominant lytic lesion prophylactic, though it may be pre-macro fracture. Whereas in Europe, Stefano might consider treating T12 if he sees a T11 and L1 fracture that he's treating. And Luigi, I think, would do the same, a perfectly normal T12. So maybe we'll see if that's correct from Italy.
You mean the interposed level, right? The sandwich vertebra.
Correct.
Exactly. That's good example.
So what we need,
you would treat that, right, Stefano? You would treat that in Italy.
Usually I do. I do the interposed. I do. It's less frequent that I treat, like in the case of I showed before, the adjacent level, but depends on the T-score and depends also from the kyphotic angle. Because it has been demonstrated that adjacent fracture occurs due to the biomechanical force and the osteoporosis. So
we need to find a way to better image and measure how weak a bone is, so we can predict which one is going to fracture. So we need better imaging studies.
Yeah.
Could we start like a steering committee to put criteria for what vertebrae prophylactic injection we can do, depending on the site of the vertebrae, middle of a curve, middle of can we start that, or it won't work?
So Yusri, I think Faraz was saying something, but I'm not sure if it was related to your question. I think because I didn't completely hear it, your question is, can we establish expert consensus around prophylaxis? I think it's a great question. I would answer in two ways. PMMA may not be the final story here, and there may be very good reason to prophylax with agents that may come down in the future that, for example, help strengthen bone, or in the case Alan brought up, help treat cancer locally. I think an expert consensus panel is great. The challenge would be, it would be so geographically challenged, because in the United States, I actually think the Europeans have it a little more correctly than us, but it is very rare to see true prophylactic treatment in the United States. Even if we had expert consensus, that wouldn't likely change very much in the near term. What is an expansion of your idea, though, would be a review of the literature to decide the value of treating adjacent bodies because of the fear of adjacent body fracture. The data suggests you shouldn't. The data says that when you look at the randomized control trials that compare either vertebroplasty or kyphoplasty to conservative therapy or sham, There is no difference in natural history of adjacent body fractures between the treatment arm and the sham arm. But I think Alan's question highlights the real answer, which is that we all know some patients are at greater risk, even though we haven't seen it in the trials. If we could figure out which ones, I think all of us would feel good about treating that adjacent level.
Dr. Stefano, we have still one question for you, sir.
Sure.
What basis you decide which type of implant to use?
Depends on the type of fracture and the cause of the fracture. Because in traumatic fracture, I 90% use the spine jack. Osteoporotic fracture with more levels, for example, I can use a combined treatment with the Tectona, for example, and vertebroplasty, because the Tectona allows to treat more than one level. It's not an implant, so it's cheaper. And I can do, for example, T12 and T11 since they are in the thoracolumbar junction, and treat the other level with simple vertebroplasty. Depends on the type of the fracture, where is located, and the cause, osteoporotic, traumatic, or for example, VBS, for example, can be really helpful, like Alessandro Giaffoni demonstrated, like a mesh to contain in case of a huge area of osteolysis. So depends on the patient, on the fracture we have.
Okay, thank you. Our next topic will be by Dr. Alan Brooks from the United States. Spine metastatic disease, vertebral augmentation and ablation. Can I proceed, sir?
Yes, thank you to the programming committee and Dr. Georgie and all my European colleagues for the invitation. I'm trying to share my screen. I'm not sure why it's not coming up. I'm hitting share my screen.
Yeah, you can now, sir.
It should come up. Do you see it now?
Not yet.
You can't see my screen?
No.
Should be up there now. You don't see it? I see my screen. Doesn't help.
Does that help?
Why isn't it coming up? Desktop.
Professor Allen, do you see the green button on Zoom? Share screen.
Yes, I'm on Zoom, and I'm hitting share screen, and my screen came up.
When you click share screen, you should choose the presentation, then click share again on the blue button in that case. First, you click on the green button, share.
Yeah, I push that button, and I see you, and I'm back on, and I'm hitting share, and it's not coming up. I'm seeing the screen very nicely, but you need to see it.
Alan, if you have multiple screens open, just click in the one that have your PowerPoint.
Okay. Right now I'm on my PowerPoint. I'm seeing it. Do you see it?
No. Please get back to Zoom and click share screen.
I apologize. I'm on Zoom now. Do you see it?
Okay. When you go back to Zoom, you will find in the bottom bar a green button called share screen.
Yeah, I hit that button, and for some reason.
You hit it, then you choose the PowerPoint.
Yeah, it started now.
No.
Oh, yeah, not yet.
You click the share screen and then select PowerPoint and click share again.
I did that. It's funny that it's not opening. I don't know why.
It did a while ago. It did try. You
don't see it now? That is
No, just step by step. First, click the green button on Zoom. Open Zoom and click the green button. You can choose to share the whole desktop. First option on the top left.
I see all that, and it's not letting me right now do that.
And
I'm
you
sharing it the way I'm supposed to share it, but if for some reason it's not working. Let me.
You click share again. Click the blue button. Share again.
I'll rejoin.
Okay.
Might be easier.
Is anybody else by accident sharing their screen?
No. No.
Josh, can you, while Alan is rejoining, can you start your presentation?
Sure, I sent in my presentation. I pre-recorded it and sent it in.
Okay.
That's a great idea.
Go and Alan, meanwhile, try to get out and sign in again, okay?
Alan, they'll share my talk and then, yeah.
So from the East Coast, from US.
It's my great honor to be addressing this conference. I myself have visited Cairo in the past as a tourist. I am very proud to know Yusri Al-Hawri and
my talk seemed to disappear.
Yeah.
So we now I have the honor and pleasure to present Dr. Joshua Hirsch from the east side of the United States. Joshua is going to give his talk on morbidity and mortality effect from the vertebral compression fracture. So it's a recorded video and we're going to start it now. Josh, we'd like to have you again in Cairo.
Thank you, my friend. I am on call today. This is why I recorded it in advance. You can see when I came back from the hospital, I'm still wearing scrubs. So we'll go with the recorded one and then I'm available for questions.
Okay.
Am I correct that you're going to turn it on? Okay.
it's my great honor to be addressing this conference. I myself have visited Cairo in the past as a tourist. I am very proud to know Yusri Al-Hawri, and I appreciate his and Dr. Khattab's invitation to be here today. So to them, I say shukran, and I look forward to discussing this concept of mortality and morbidity associated with compression fractures. These are my disclosures. In this era of virtual meetings, let me make a pitch. This was the ASNR meeting I ran last year, ASNR 20, and it was the most successful meeting in the history of the society in terms of participation. We had 4,500 doctors from all around the world. We're going virtual again this year, and for a relatively nominal fee, you can be a part of this meeting. Consider it. It has all kinds of great stuff, including wonderful spine that you can see listed here. Morbidity and mortality around compression fractures is a pretty hot topic. If you take a look at this group of papers, Ong is the one I'm most familiar with. At 10 years, 15% of patients that have had a compression fracture are alive. That's it, 15%. Now, that doesn't mean they've died from the compression fracture, but they had the compression fracture, and 10 years later, 1 in basically 6 are able to talk about it. That's a pretty dramatic death rate. I would make the point to you that we've been talking about how benign compression fractures are not benign for a long time, and this very famous downward spiral, which was first promoted by industry, is one of the very few industry-related slides that I'll use. I've used it for years because it so elegantly made the point that this terrible term, benign compression fracture, is so misleading that between the different impacts, the opioids, the gastrointestinal problems, the difficulty with respirations, mortality was likely to go up. At first, though, that was inferential. We assumed that these findings would be borne out. I want to show you this because it's going to make a point that we're going to come back to. Everybody in the augmentation space knows these two papers from 2009. You may not be familiar with these, but I will say to you that whichever people you looked at, we had a whole bunch of different papers come out. Here's the one I did. Here's the one my friend Dave Calmes did. Demonstrated a dramatic drop-off in the incidence of compression fracture treatment with augmentation after those 2009 studies. Now, Av Edidin was the first person to really look at mortality in a meaningful way. Av looked at 3 years of the Medicare database, almost 900,000 patients, and what he found, and I'll show it to you graphically, is that there was a far better mortality rate with kyphoplasty than vertebroplasty than non-surgical management, meaning there was a survivability bonus associated with treatment. This effort was challenged by the work of Dr. McCullough. Dr. McCullough took a database of smaller patients and said, I think you're thinking about this. And you can look at how small the population dropped to with propensity score matching. So they've taken this very important statistical methodology and they've used it, propensity score matching, to try to match cohorts. Before they did that application, they had the same finding everybody else did, that mortality was much higher in patients that didn't have augmentation. But what they found was there was no difference once they applied the propensity score matching. And they argued that the finding was therefore spurious, that it was a reflection of underlying disease. Now, there are a lot of critiques of this paper, like there are any claims-based data set review. Only one I would highlight is that the original edited paper separated kyphoplasty from vertebroplasty, so I would have thought it appropriate to do the same here, since this was in some ways a rebuttal paper. I would also make the point that it may not have been reasonable, given the relatively small numbers you were dealing with. A lot of other groups went on to prove the same thing that Edison did, using different papers. This was the look by the Bloomberg School of Public Health at Johns Hopkins. They, again, accounting for differences in the way you do the graph, found basically the same thing. Kyphoplasty better than vertebroplasty, better than non-surgical management in terms of survival estimates. The Germans, similar look. Again, smaller group, but they were coming at it, looking at their own set of claims data. And what they found was, similar to McCullough, comparing operated to non-operated, that there was a very substantial difference in survival estimates. Now, Kevin Ong is a really, really sophisticated statistician. And our approach to him was predicated on the notion that, look, there was a tremendous drop-off from before 2009 till after 2009 in the number of augmentations. And our look at the CMS database, Kevin Ong's look, which I'm associated with, when I use the possessive term, that's why, there was a 40% drop in the penetrance of augmentation. And you could argue, understandably, after those trials occurred. Well, Kevin looked at, with us, over 2 million fractures over a 10-year period, with a very large number of vertebroplasties and kyphoplasties. The headline news was that there was a statistically significant mortality risk in the group that came after the 2009 studies compared with before. Now, there could be other reasons, but certainly it seems reasonable to suggest this huge drop in mortality was, huge drop in patients getting augmentation might have been a cause. That was the headline news from the paper. In my opinion, the more important news, the less reported news, was that in every 10 years. Now, using number needed to treat, which is a straightforward statistical methodology, and again, working with statisticians, this was not me doing my own quick calculation, we determined using the same data set, the number needed to treat, and we actually found that it was smaller than you think, that after treating 12 patients. The question number needed to treat is number needed to treat to have an impact. Our impact was survivability. And, you get out to 4 or 5 years, you're talking about a dozen patients. That's a pretty profound number if you really think about it. Lots of reasons why this may be true. I mean, you're probably familiar with the opioid crisis, at least as you referred to it in the United States. You may be familiar with this more recent randomized controlled trials where sagittal height preservation was demonstrated. I mean, there are lots of reasons why people who are mobilized early off opioids might enjoy a mortality benefit. I'm just showing you slides from the VAPOR trial that showed how the height loss was progressive in patients who had compression fractures randomized away from treatment. Similarly, in Virtuos 4, on these findings, the studies agreed. And I think they were really pretty much common sense. The logical extension of the group of mortality studies was to do a meta-analysis. Ranil Chandra was the former fellow working with a group predominantly headquartered in Australia. We did study this by looking at the various studies that looked at mortality. And we used very typical meta-analysis protocols. And what I would say is, it's noteworthy that we looked across the world, which implied we were looking at different populations. Now, again, we did a typical look and found 16 studies were appropriately potentially included. We excluded several because they looked at the same population. And it was really something to see when you looked at the scatter plots, just how favored the augmentation group was over the non-surgically managed group. And I think this is a really important point. Again, recognizing on this group had the biggest population, therefore it had the effect. It is not in any way clear that ONG's data was the strongest, though. There were other groups that showed a larger survivability benefit, and I think that that's an important point. It didn't skew the results in such a way that it was challenging for them. So I would just point to that to say that I think that these scatter plots were powerful in that it really says, except for McCullough, all the literature was pointing in kind of the same direction. And remember, Ong was a serious statistician. He used propensity adjustment. This was not a raw group of numbers. This was a group that accounted for the differences using those statistical techniques. Now, look, anytime you do a meta-analysis, you got to recognize the limitations. Anytime you look at claims-based data, you have to recognize limitations. But I think the key thing is how much do those limitations make you say there's no validity to what we're reporting? And I would say, with the vast majority of studies demonstrating the exact same thing, even if they use the propensity adjustment techniques, I think it's time to acknowledge that mobilizing people, getting them off opioids, all of these things are incredible positives for survivability. And it's surprising to me that those points are not more universally recognized than they are. This was our conclusion from the paper. You can see that, again, there was a fairly strong conclusion. Dr. Jack Jennings was asked to write an invited commentary, and it was his point that it's time to stop arguing about this, that this is really a fact almost at this point, that augmentation confers a survivability benefit, and I would argue it does so for biologically plausible reasons. I'll close with this concept of the NICE guidelines from the National Health Service. The NICE guidelines are, I think, important in that they represent a very distinguished comparative effectiveness research look. They were interested at that time in the biomechanical factors that could improve survival. They said it was reasonable to assume that vertebroplasty and kyphoplasty prolong life compared with optimal pain management. And you'll remember that they advised people to get vertebroplasty and kyphoplasty. My final thoughts are, look, this is a tough disease. 15% of patients survive at 10 years. As Lee Jensen coined, conservative therapy is not risk-free therapy. There are reasons it's not risk-free. Progressive kyphosis was shown to be a problem in the vapor trial. I think that that's probably a part of it. Obviously, less opioids is probably a part of it. I would say to you that, for me, there isn't much of a question. There appears to be a signal here. I mean, at least enough to say that there is a mortality impact that is biologically plausible when you do kyphoplasty over non-surgical management. And I think that that's really important. With that, again, shukran, assalamu alaikum. I hope you enjoy your conference, and I look forward to when we can have these conferences.
Josh, thank you very much for, although it's recorded, but it seemed lively. Okay. Thank you very much. So do we have questions for Josh? So can I ask Alan, are you okay now with the
I'm back
signing
up,
in?
and it just says that I'm supposed to allow Zoom to share my system preferences. So give me a second, and that's the only thing I need to do. Evidently, it's a new computer, and it should work easly. I don't know why I have to add.
You were saving that computer to the last, huh?
Yeah, I should never have done that, huh? Printer sharing, file, screen sharing. Screen sharing. This should work. Hopefully it works. Can you see my screen now?
Not yet.
No?
Not yet.
Oh, this is terrible.
The question is there a morbidity benefit, Alan, to sharing screens?
I've done this so many times all over for different Zoom conferences. It always works very simply.
Alan, while you're figuring out, maybe I can make a quick comment in response to Wael Abu-Zaid's question. But while I'm answering Dr. Abu-Zaid, or Abu-Zaid, I think, yes. Keep trying to bring your computer up, okay? So, Dr. Abu-Zaid, I think that the argument of why kyphoplasty more than vertebroplasty has three different answers depending on who you ask. If you ask Dr. McCullough, it's not a real finding. So Dr. McCullough believes all of this data is a mistake. And the reason he can say that, he says, is that when you compare the treatments, the non-surgical management are the sickest, the kyphoplasty and vertebroplasty are less sick. I don't believe that that is credible. The vertebroplasty advocates say the exact same thing. So when we did the number needed to treat paper, that it was eventually published in AJNR, one of the people who reviewed it was obviously a believer in vertebroplasty. He argued, I say he or she argued, that vertebroplasty patients are sicker than kyphoplasty. Ang's paper on this is, in my opinion, authoritative. Actually, the kyphoplasty patients in that database were sicker than vertebroplasty. So in my opinion, the finding is real. And his use of propensity adjustment is important. And I think the answer is there is presumably better height restoration. And when you look at vapor and vertose, height restoration or height preservation was better in vertebroplasty than in the control groups. So it seems to me that that type of progressive failure would be an explanation. And I do think that as we look at Dr. Stefano Marcia's work and those in SECOS, there is a suggestion that implants may even confer a fracture advantage, not just a survivability advantage, but an adjacent body fracture advantage over time by the maintenance of height over time. So there's more, I think, coming with this study. I'll say one other thing as Alan still tries to pull this out. Because Alan, don't wait. If you think you can share it, I'll stop once
Okay,
you're.
so I want to change my laptop.
Okay. So I'll just keep going for one more second, which is that if surgeons like Dr. Yusri and many of the people in the audience had been the people who started up vertebroplasty instead of radiologists, we would have thought of sagittal correction as a major primary endpoint. Unfortunately, we latched ourselves to the completely subjective pain relief concept, which becomes very complicated over time in the kind of population we're dealing with. So one of the reasons I think we had the trial failures early on was because we picked pain in 85-year-old patients with back pain as an endpoint versus, let's say, for example, the much clearer objective measurement of sagittal preservation of sagittal height. While Alan's figuring that out, are there other questions from the panel?
Yeah, there's a question from Dr. Gamal Baroud. What is the best predictor, in his view, in your view, for anticipating osteoporotic fractures?
What is the best? What was the question? The best what? Best what?
What's the best predictor, in your view?
The best predictor for osteoporotic fracture.
Yeah.
That's a great question, Gamal. Not surprising for such a good man. You've got the best question. The best predictor is ready, set, having had a previous fracture. So people think it's being elderly, being skinny, being white. They think it's all of these different things, but the single biggest predictor of another fracture is having had a fracture. So the way I explain this to patients, if you have identical twins that have lived together their whole life, one has a fracture, one does not, the likelihood of that person having a second fracture versus a first for the twin is 5 times greater. A third fracture is 12 times greater. A third fracture with severe osteoporosis is 75 times greater. This is why, in my opinion, the use of augmentation is too small. Because again, as radiologists, we've been trained to think about this in terms of pain. But in fact, preserving the height has a value because I believe it actually saves people from having so many challenges over time. In my opinion, far more than the 20% that are currently being treated should be treated when you start thinking about it in the context of this mortality data. Great question, Gamal.
He said that the prophylaxis became important.
Say that one more time, please.
The prophylaxis became important now.
Yes. So I would argue, I think I said it in a funny way before, but that the Europeans have it more correct than those of us in the United States. I mean, you look at a person like Bassem, who's been a thought leader on this forever, and he would, I think, agree. Very hard to take the risk in the United States of doing a treatment Medicare says you shouldn't. So let's say Bassem does it or I do it, and we say don't bill for it. That's okay. We don't bill for it. But if something goes wrong on that treatment, we would be in very big trouble because they would say Medicare even tells you not to go ahead. Oh my goodness, this is a great day.
I apologize, gentlemen. I really apologize to everybody. I hope you can hear me.
We hear you great.
I hear you.
Thank you. So it's a pleasure to be on my laptop speaking to you with my colleagues from all over Egypt, internationally, and thank you to everybody for inviting me. I'm going to speak about percutaneous treatments for spine metastases. And it better go forward. So we all know that cancer is a leading cause of death worldwide. The total number of cancer incidence and mortality is increasing from 14 million in 2012 to 24 million, doubling in 2035. The spine is the third most common system after the lung and liver. Metastasis takes place. In the presenting system, common complaint is mostly pain. Neurological compromise is most dreaded complication. I will show you an overview on augmentation for cancer patients and ablative techniques and some future considerations, as well as the overall summary. So with osteoporosis, we know there's many different shapes of lesions in the spine. Cancer is very different. It's not always a similar appearance. You can have epidural disease, you can have large lesions, partially sclerotic lesions, so it's very different. And the question with cancer is not always pain, but it's stability. And not all metastases come in the same types of patients who are very sick and have many other comorbidities. What's interesting, the history of cement usage in cancer started in the 70s. Dr. Harrington noticed that patients were living longer, and he placed polymethyl methacrylic into his hip transplants when he had these pain patients. And what was remarkable, not only did these patients live longer and they had less pain, but it was noted in the few patients he explanted the hip with the cement, the tumor never ate into the cement. So there was a natural ability from the heat of the cement that would kill the local cancer. 40 years later, we have a lot more patients surviving, and cancer is seen much more in the spine than in other places. And again, pathologic fractures can cause a lot of dreaded complications. With cancer, it's very different than osteoporosis when you percutaneously treat with cement. A lot of times you can't see the vertebral bodies well, or at least the pedicles, which makes it much more difficult to place your needles safely. In these cases, you're using the levels above and below to find the pedicles and find out how to keep your needles safely placed in the proper position to do these procedures safely, so you don't have extravasation of cement into the vertebral bodies. This is a case of a cervical spine lesion, a lytic lesion of C2 with terrible pain, especially upon turning the patient's head. This was done under CT guidance, where you see a posterior lateral approach where the needle went in, and using very viscous cement, we stabilized mechanically the cervical spine. Majority of cases of metastatic disease does not have just one level like you just saw, but how do you know which one is going to compress, or do you treat all of them and take the risk of each treatment combined? And so the idea is to prevent spinal cord compression. Trying to figure out which lesion is the weakest is sometimes still very, very challenging, to say the least. In 2005, I was sent a lesion that was not painful, and we chose not to treat it prophylactically and ended up with a dreaded complication of cord compression. So this is one of those cases where prophylactic treatment was considered, but we didn't do it back in 2005. So we have to make sure we understand in cancer, it's different than just pain. It's about stability and pain. The most pertinent publication came out in 2009 from this group, Dr. Bilski's group, showing that when you have 40% lytic lesions and you're going to get focused radiation, these will more likely compress than not. And treating these with cement preferentially is, in fact, in the literature and probably better to do. And we have quite a bit of cancer patients coming in for cementing or in and around the radiation therapy. So the idea of stability is very, very important, especially for our Italian colleagues, as they know some buildings need help with augmentation. We know there's a lot of This is a a myelogram that was performed during vertebral augmentation. And when you look at the CT of it, when you put cement into a tumor, it can push back the tumor posteriorly against the nerves. Therefore, we know that these cementations do have side effects. You have to be aware of them and prepare for them. This is a case of an osteoporosis patient of mine that we treated an L1 fracture that was seen on a bone scan as the patient couldn't have an MRI. And this is not kyphoplasty, just filling it with a lot of cement. The patient came back a week later with no pain and presented a little farther along the line with a CT scan that we saw because he presented back in the ER. And you can see the cement pushed out the bone marrow. This is not cement in the psoas muscle. It's actually the bone marrow. So we know by placing cement in patients, we're pushing bone marrow, and in cancer patients, pushing cancer into different places. In AGNR, it was demonstrated that normal vertebroplasty had pushed bone marrow fat into the lungs on a pathological specimen. So theoretically, we're doing good by placing cement in these bones for stability, but where is the cancer being pushed into? In the lab in our place, we've done kyphoplasty experiments with all kinds of balloons and other devices, saying that when you push out this bone marrow, you can't place it into the lungs. So that's the rationale before the second half of my talk about the idea of ablating tumor prior to placing cement or a device which clearly can push tumor into areas and metastasize into other places. And so we'll talk about radiofrequency ablation most commonly, but any type of ablation, whether it's high frequency or cryoablation, can work to give you room for where your cement can go to add stabilization. In the literature, there's a few good papers out showing that using radiofrequency ablation along with cement can lead to decreased pain in almost all patients. And the radiofrequency equipment doesn't add any major complications to our treatment. This was a nice case by Jack Jennings' group that showed a posterior oligometastases, the only metastases seen, that they did a posterior ablation, and it led, after 10 months, it didn't light up anymore, thinking this was a cure. Again, longer-term follow-up is needed. This is a case where the two lower levels were treated with balloon kyphoplasty after ablative techniques. The top two levels only had radiation and no ablation and started to expand with time. So radiofrequency ablation killing tumor clearly has a role. The largest paper that's in the literature, many of us were partners in, showing 128 metastatic lesions were identified in 92 patients. Radiofrequency ablation was technically successful in all lesions without complication or thermal injury. And the study showed, with a very good clinical significance, that it decreased the VAS scores at 1 week, 1 month, and 6 months post-operatively. So we know we can do this safely and with good pain management. But radiofrequency ablation alone or cryoablation doesn't augment or stabilize the bone itself. This is another center's experience showing similar palliation. So we know that vertebral augmentation still has room for improvement. We don't always change the height. We don't always have long-term stability in the literature, but we're getting there. Sometimes cement alone doesn't always stay in place when you have these large lytic lesions. So when you look at Dr. Marcia's lecture, he mentioned different devices you can use. In cancer, it would be nice to place a geometric shape like this Kiva device in the middle of the cancer after ablation to make sure the cement stays inside the bone or inside your device, give you a geometric redefinition of the bone. This is a case in an osteoporosis patient where you elevated the height and you can see the cement staying in the Kiva device. This is a case of Dr. Totten's where you see a complete blowout of the wall. And then after giving Kiva, you can see the cement stays within the device. So you're actually making a geometric placement inside a very diseased bone to keep the cement in place, and actually looks like a square or rectangle to redo this vertebral body with good result. We don't take the place of a surgical stability team. We work with our team in tumor boards and understand all the instability and all the different things that go into a team approach to these cancer patients who are usually very, very sick. But percutaneous treatment with cement and with these devices is in the literature as part of the standard of care for stabilization and for pain management. So the question always comes in now, is it just pain or stability? Preoperative embolization also is a possibility in these patients. When you have a patient with certain cancers like thyroid cancer, hepatocellular cancer, they're very vascular. And prior to surgery, percutaneous treatment can have a role. There's many papers that have been published on this. We do quite a bit of preoperative embolization to make it safer for our surgical colleagues to do surgery safely. There's evidence out there showing that the complication rate with intravascular devascularization is safe on a preoperative sense. In addition, there are some tumors that are very small, similar to what people do for ABC tumors or giant cells, injecting cement in to stabilize that bone. Even for tumors, we can percutaneously inject liquid agents into these lytic lesions for devascularization. So it makes them stronger, and it'll take away the risk of bleeding when you can inject these glue-like devices, onyx, into the cancer. In the future, will we have the ability to have good literature on putting something into the cement, whether it's radiation beads like you see here with I-125, methotrexate as a chemotherapeutic agent into the large lytic lesions, so we can not only augment them, but also be treating the cancer. These are things that we're starting to understand on where we can be successful. These smaller case series came out, not only were they successful, but they also didn't have any of the side effects that would be expected. Did the radiation beads go too close to a nerve and cause myelitis? Did they extravasate and cause radiation damage to the spinal cord? And these small case series, they were all done very safely. This is a 2-year follow-up showing radiation iodine 125 seeds in a vertebral body that showed the cancer didn't recur after supporting it with very nicely placed radiation therapy. So I think in the future, we may be able to treat cancer locally with embolization techniques where you can put intra-arterial chemotherapy into the spine, as well as percutaneously placed radiation and chemotherapy as we get more experience in the lab and literature. So my summary is different fracture morphology and etiology demands a tailored patient-centered approach. Pathological fractures related to cancer may benefit from ablation and vertebral augmentation and stabilize them. The improvements in our devices and cement types will allow for interventionalists to play a key role in minimally invasive spine care. Injective biologically active agents may help with this stabilization in helping to cure cancer along with our team of surgeons and oncologists. So thank you. The one take-home point would be, if we're not for the great variability among individuals, medicine might as well be a science and not an art, by the great William Osler. Thank you so much for inviting me, and I apologize for having a little difficulty getting this talk together online with Zoom.
Alan, thank you very much. Great talk. Can I ask you about this iodine seeds? Do they by itself do the killing of the tumor, or you have to add radiation to activate them?
The ablation alone will kill the tumor, and the heat will also allow the cement to cure very quickly and allow stability to take place. So you don't need radiation beads or chemotherapy. That has to be studied more and get more studies and saying who and when that'll be successful. That's down the line.
No, I meant the iodine seeds. The iodine 120. Seeds.
What's that?
The I-125 seeds you put with the cement. How does it work?
So in the case series that were presented, those are inside the cement and give off a little radiation around the cement for the 6 to 12 months. And all the case series of 1 or 2 cases have very good results, but there are no long-term data or control series showing that this will be benefit a large group of patients. It's still only a few cases in the literature.
Alan, just a quick comment. You may remember a number of years back, we worked on a couple of papers regarding the theoretical idea of attaching radioactive things like iodine and other agents to the cement. They were just statistical studies, and it's true that it's now been expanded on, that there are clinical efforts underway where small case series are showing that. So it is an optimistic idea, Yusri, to be able to help locally control systemic disease by adding these radioactive elements to standard PMMA. It's exciting.
Dr. Alan, we have a question for you from Wael Abu Zaid. How would the pathology of the primary affect the percutaneous treatment?
So it's a very good question. When you have vascular tumors, you have to be more cautious with bleeding. If almost all the tumors respond very well to augmentation in the strengthening of the bone for stability. Almost all the ablative techniques work very well unless you have a prostate cancer with a big sclerotic bone. Then the heating techniques don't work as well as cryotherapy.
Gamal, do you have a question?
I have a comment.
Okay.
You remember, Alan, there was a publication from a German group from Hamburg regarding the circulating tumor cells after vertebroplasty and kyphoplasty.
So,
Basim, remember we attempted to write a small little article related to it. Already it has been demonstrated, like once you got to remember always Archimedes' principle. Whenever you put something inside, you have to displace it.
This is very true. And it's actually, in the few cases I showed where you have emboli to the lung, actually on pathological specimens, there's clearly some extravasation of either bone marrow or tumor. And that's why patients are still going to get the radiation or chemotherapy appropriately. When someone goes in, a spine surgeon, and decompresses 2 levels and puts a cage in, there's also tumor going into veins and into the lungs as well. And that's why systemic therapy also is never disregarded here. It's as warranted as the typical chemotherapy is needed.
Oh, that's one of the big arguments for doing very aggressive local treatment like radiofrequency ablation or cryo to avoid the systemic embolization.
Okay, at the end of the session, I would like to thank Josh, Basim, Alan, Stefan, and Luigi for really putting your time and your day off. And we'd like to invite you to Egypt once the COVID is over, and we'll meet in person. Thank you all. It was a great session, and thank you very much.
Thanks to everybody. Always a pleasure. Thanks you. Bye-bye.
Goodbye.
Thank you. Bye-bye. Bye-bye.
Bye-bye. Bye-bye.